Welcome to the second annual Alagille Syndrome Alliance virtual roundtable event. We're thrilled with the opportunity to bring together Alagille experts, pharma partners, researchers, and families in an amazing atmosphere inspired by the ALGSA mission, which is mobilizing resources, facilitating connections, promoting unity, and advocating for a cure to inspire, empower, and enrich the lives of people affected by Alagille syndrome. The ALGSA Syndrome Alliance is in its 27th year. It was built on the idea that connecting families with other families and to knowledgeable doctors and resources, families that would not face their Alagille syndrome journeys in solitude and isolation. Through the years, the ALGSA has provided an outlet for Alagille families to make friendships and connections to other families by way of regional meetings and symposia, which many of you have attended. And we've created an online community which started as a message board in the early years where families could post questions to other individuals dealing with this syndrome. And it typically had a turnaround time of anywhere from 5 to 7 days for an answer. And due to the small number of Alagille families plugged in, it was a lifeline for so many, for those individuals. I remember posing a question on this message board, which ultimately became one of the most critical pieces of advice I'd ever received from an Alagille young adult regarding itching. She told me, don't tell your child they can't itch. Make sure that others understand they can't tell her to stop because this will bring shame and could make the symptom and the reaction something dark that affects her life negatively. She said, I turned to cutting with safety pins, thumbtacks, and paper clips because I wasn't allowed to be myself. This type of advice is that of something only an individual living with Alagille syndrome every day could express. Families for 27 years now have been coming to the ALGSA to connect to other families for this very reason, to relate, to have someone on their side who understands their day-to-day struggles, the deep emotional toll ALGS has on a family, and to build on the mission which encourages connection with all stakeholders for the ALGSA, vital stakeholders. Today, we welcome deeply devoted speakers dedicated to improving the lives of those dealing with Alagille every single day. They also represent institutions committed to fighting big and small battles with ALGS with us. These individuals are change makers and path pavers who spearhead major movement in treatments, research, and understanding, so one day we'll see relief in areas of great turmoil within this disease. We hope you enjoy this event. Take in all the information these experts have about the challenges of ALGS, the actionable plans of attack they might share, and the knowledge sharing that will take place here is just invaluable. Thank you so much for joining us today. I'd like to introduce Cher Bork, the ALGSA Executive Director, and she's going to go from there.
All right, thank you. Welcome, everyone. Before we start, I just want to give you some details about the content of this meeting, as well as our goals for today and tomorrow. Central to everything we do is the patient voice, and we have found that there is no better way to dig into your challenges and your needs than surveys. The 4 recent family surveys that we've had out, we've had Measuring What Matters, which was that big general survey, had the adult needs assessment, the guilt survey, and then also a survey about bone pain. And I just wanted you to know that together from those surveys, we've had over 300 responses. So thank you for taking the time to answer those surveys. There were 5 main topics of concern that came out of the surveys, which sort of make up the content of today's agenda. And that's nutrition, itch, bone pain, cardiac concerns, and then also emotional health. So today and tomorrow, we'll have an open dialogue about these important topics, bridging any knowledge gaps from families to clinicians to researchers, back and forth. Maybe we'll come away with an understanding of some resources that might be needed to help meet some of your challenges, and then also uncovering some potential focus on future research and care. The surveys, they were an incredible source of insight, and In addition to those 5 main topics, I did want to just take a quick minute to touch on some of the other priorities that have come from the survey's priorities for us to keep working on. Kidney concerns, xanthomas, eye and ear issues, those were all issues that were raised. Also, misdiagnosis was a big one. You know, over 30% of the respondents to the surveys indicated that they were misdiagnosed. On the overall impact of ALGS on daily life, 70% noted that sleeplessness and sleep disturbances are an issue. And I know some of you here are nodding. That is, you know, to affect over 70% of our families. That's really huge. So that's a big priority for us. On the adult side, ALGS adults, in addition to bone and joint pain, which was at the very top of the list, about 78% are also dealing with chronic fatigue. And then 53%, so more than half, are dealing with bleeding issues and also blood clot issues. On the adults also, we have about 40% that indicated that their Alagille syndrome has significantly impacted their ability to earn an income. And that's due to things like the fatigue and the pain. So there's still so much that we have to learn. And we just thank you all again for taking the time to answer the surveys and share your experiences with us so we can better help you. There are a couple of technical things for today that I want to mention. If you would please stay on mute as much as possible. I think Roberta probably has control over that, but just in case, after each section, there will be an open dialogue time where we can talk about questions and have some discussion. And of course, you can come off of mute then. But if you'll just help us stay on track, it might be best if you type your questions into the chat. And then that way, Roberta and I can pick those up and make sure that those get answered. As she said, this meeting is being recorded. So I just wanted to remind you of that. And then lastly, it's a very tight schedule, as you can see. So we will need to stay on track as much as we can. We do have some breaks. Our first break comes up at 10:15 Eastern. So that's going to be a 15-minute break. So there's some breaks throughout the day. And we'll put the schedule up on the screen maybe during those breaks. Thank you all again. And I want to go ahead and turn it over to our first speaker today, who needs no introduction. Dr. Piccoli is going to tell us a little bit about, I think, some history and then also about the clinic there at CHOP. So Dr. Piccoli, whenever you are ready to go.
Thank you very much. Everybody, hi, welcome to those I know and those I don't know. It's really a pleasure. We'll come back to this later, but I do want to echo one thing that Cher said. The surveys and the participation of a large number of people are really a major avenue toward improving Alagille syndrome and patients' lives and families' lives. They are so important. And even though we think we've been doing this forever, you know, a lot of things are not discussed in the office or not discussed as fully or honestly. They are great. And when Cher and Roberta sent these last surveys, I was just blown away. They were amazing. And there are a lot of things that we do have to address. And we take those very seriously. They're incredibly valuable. At our institution, Zoom is not allowed. So I suspect that I'm going to make some major technical problem here, but I'm going to give it a try. And I'm going to try to share my screen and see if we can get that to work. Does my screen show up here now?
Yes.
Okay, good. All right, I needed that feedback. We all need a little feedback. So I'm at the Children's Hospital of Philadelphia, along with Kathy, who's on the screen here, and Binita Kamath was here for many many years before she moved northward. We've been involved in Alagille syndrome for a long time. I really came here to be a liver doctor back in the early 80s. And so my first assignment is to discuss the creation and the evolution of a clinical care and research program here at the Children's Hospital of Philadelphia. We always have to put these conflict of interest statements in. I have no conflicts around this. So when we build a center, and we have the luxury of being in a hospital where many of our programs are extremely large. We have 61 faculty members in the division. We have 90 people who provide clinical care. And so when we go from individual care to building a center or a program, we really think about it in terms of CHOP cares, and we do this for a number of different diseases. But it's primarily, it's about the ability to provide excellent clinical care, but it also involves advocacy for patients. For most of our centers and programs, we're involved in research, could be bench research, clinical research, translational research, epidemiologic research. The education that we do, and as a big academic institution, we're educating fellows, residents, and medical students, but it's really important to provide education for other physicians who don't see the same amount of these diseases, and particularly patient education. And so I'll talk a little bit about that. And then anything that we can do to provide support. And of course, the major thing that we do with Alagille syndrome is we've partnered since forever with the Alliance. So how did this sort of happen here? Well, it turns out two of the most notable liver names of the late 70s, early 80s ended up here. John Watkins, who was the first chief to all of us in GI, and GI was a brand new field then, pediatric GI, and Cam Witzlaben, who was the chair of pathology. And in the 70s, they had both written about bile duct paucity, bile duct transports, bile duct morphology, and so it was a perfect place to come. And many of us who came to train here came to train specifically in liver disease. And really through the 80s and early 90s, we took an interest in Alagille syndrome, and we mostly had local patients, and we had a very small team, and we didn't really understand as much all the different manifestations of Alagille syndrome and the real complexities, and I think particularly we didn't understand nearly as much the relationship to severe cardiac disease, renal disease, and so on. But we had always wanted to study this. We wrote some papers in the 80s, but they were not life-altering papers, to be sure. And then in 1992, Nancy Spinner was a PhD who had done some training here, had gone away, and then came back to run one of the major hospital labs. And that for us was really the change in our ability to focus on Alagille syndrome. And together, we in a small team wrote a research grant. We wrote an IRB to say that we were doing ethical study of patients. And then we had a middle of the winter in '93, we had a Saturday special where we brought a bunch of patients in and we talked about the research we wanted to do, and we drew lab studies, genetic studies, and genetics back then was really, really in the dark ages. And in 1994, we actually really just got lucky. One of the families that we had been following for more than 10 years from a small town north of Philadelphia actually had a translocation. So that was a very rare genetic event, still rare, but where 2 chromosomes crisscross. And because 3 people in the family had Alagille syndrome, and actually it was kind of the translocation that proved to us that the other two people kind of had it because they sort of had it. And that obviously through the 90s was a big problem, who really has it and who maybe has it and who could pass it on. But they all carried this translocation. That gave Nancy Spinner's lab an incredible insight into the break point almost always happens at the gene that you want to be interested in. And there was a lot of enthusiasm. It was a teeny lab, but Nancy was absolutely a dynamo. Then one of her grad students, Ian Krantz, came on the scene, and Ian is just like Nancy, brilliant, tremendous researcher, and not just in Alagille syndrome, but in other multi-system diseases. And so we really adopted this, and we had the support of other people in the institution and the local patients. And our clinical program at the time involved these people, and I'm not going to read all these names, but some of them are now your doctors in other areas, other hospitals, but far and away, one of the most important people, the most important person who came into our system because of our interest in Alagille syndrome was Binita Kamath, and she has even back then established herself as a really innovative thinker, brilliant, thoughtful, and now clearly a major leader for Alagille syndrome care and research internationally. But all these other people sort of came on. You sort of understand scientifically a dominantly inherited disorder that affects multiple systems was extraordinarily interesting, not just back then, but even now, because we really did not understand how genetic disorders could make so many different variants of so many abnormalities in so many different organ systems. So it was really very easy to get more and more people at CHOP to be involved in this, and we built the team. But as we started to see more and more patients coming in from across the region, we realized that we needed a savvy, a smart team of cardiologists, endocrinologists, and other people to help us focus on this and care for patients. And because we got more and more patients to come in, and over time met more and more patients at different symposia and things, that we acquired experience with the less common features of Alagille syndrome. So in terms of scientific exploration, we were interested in bioductility in the lab, and clinically, we have one of the longest standing nutrition programs in the country, and we worked a lot to expand the phenotype to get a better understanding of the large number of clinical abnormalities in each of the different organ systems. And now it's pretty clear that liver disease can go from totally normal to totally terrible. Heart disease can go from a minimal murmur to a highly abnormal chambered heart with other restrictions. But at the time, we didn't have as good a feel for that. We started to spend more time with bone disease, and we'll talk a little bit more about that, although I have to say that the survey was much more extensive than some of the things that we had been looking at. But Kathy Loomes, Tina Bales started to focus on the bone disease in Alagille syndrome. And then the kidney disease, and Binita Kamath, along with Kevin Mayers and the nephrology team here, started to collect more information about the different types of renal disease. And of course, the genetic story, which you have heard, but for us is a major, major part of our scientific explorations around this. And you know that we've gone from deletions to translocation to mapping. And then in 1997, we had the gene discovery, which then changed all of these different things dramatically, because we had a much better sense of who really had Alagille syndrome and who didn't have Alagille syndrome, and what that meant and how that mattered. And we could do things like genetic counseling. We could understand the relationship between patients who have Alagille syndrome and other genetic diseases in that pathway. So that was really a kind of a before and after era. And at that point, we had a significantly larger number of people who were interested in coming and working on the disease. Now, a lot of that early research and some of our continued research has been kind of like single center or small collaboration research. But I have to say that some of the best things that have happened for Alagille syndrome care and understanding are these national collaborative research consortia. And so about 20 years ago, the NIH put out a request for proposals. They started to study something called biliary atresia, which probably most of you had considered for a while if your child was identified as a neonate. And there was a biliary atresia research consortium, BARC, which was very successful. And it was just a small number of centers, but it was national. So people started to share data and information in a way that really hadn't happened much before. But the NIH had figured out that for rare diseases, you need a lot of big centers willing to work together to get answers. And then just immediately thereafter, the Cholestatic Liver Disease Consortium, or CLIC. Pediatric liver doctors are very obsessed with cute names for projects. And so this, thankfully, included Alagille syndrome. And at the time that this was set up, kind of each center had one disease. So CHOP was kind of the lead for Alagille syndrome, but there were other diseases. They were the FIC disorders that Alagille families have become more and more familiar with because there are similarities, and certainly at the pharmacological, the bile acid level, some significant overlaps. There was mitochondrial disease, alpha-1 antitrypsin, and it's very fortunate for Alagille syndrome, but sort of unfortunate for some other genetic liver diseases that didn't get in the club, and then they were they've never had this same kind of international study advantage. The fact that these two groups, the BARC and the CLIC, were so successful that in a subsequent NIH grant funding cycle, the NIH said, why don't you bring all of these together and why don't you expand this to many more big centers? Because the more patients you have, the more surveys you have, the more activity you have, the more excitement, the more success, but also the more likelihood that you'll be able to understand things in big data rather than individual anecdotes. And so these were also a major change. And for us, not only was Alagille syndrome elevated to one of these diseases, but Nancy Spinner was a lead in the genetics core. Pierre Rousseau, who's our head pathologist and had been involved in Alagille research also since the early 80s, was the head of the pathology core. But everybody really worked together in an amazing way. And this consortium now gets something like $6.7 million a year in NIH money. Not all of it goes to Alagille, but now about 15 different centers have come together, and some are in or some are out every 4 or 5 years. It changes a little bit, but they all have adopted all of these diseases. So we have the ability to look literally at hundreds or sometimes even thousands of patients, collected specimens, data. It's really been amazing and marvelous how well this has worked. And this collaborative in total has published now about 120 papers. So it's really a phenomenal consortium. It's ongoing. It was just refunded. It's really, really valuable to Alagille families. And then the newest thing, which Binita Kamath will talk about, which is really a spectacular idea, is the Global Alagille Alliance study, GALA. And I won't take any thunder from this, and certainly don't get any credit for this. She's really done an amazing job, and they are already incredibly productive. And probably many of you are involved in this directly or indirectly. So what about the CHOP Alagille team? We have a liver and liver transplant team. And again, I'm not going to read all these names, but dedicated MD nutrition people and dietitians, cardiologists, neuro and neurosurgery, nephrology, kidney disease, orthopedic surgery, genetics, and genetic counseling obviously is extremely important. There are many people who know their genetics or know that this has happened, but don't have a sense of what does it mean for the family members who are already born and for children of those members who might be born. And then other groups like PT, OT, Child Life, and the other different support groups that help us. We do have a second opinion program that's fairly formalized. We do about 2,000 second opinions a year, not in any way all Alagille syndrome, because we see a lot of other diseases. But we have a website dedicated to our second opinion process. We make a major effort to get records, and records are really everything. And for many families who've gone to one center for one thing and one center for another thing, and maybe 2 or 3 centers where they were trying to make a diagnosis before it was correctly made, it is really, really important to collect and own all of your records. So with the Affordable Care Act, what some people call Obamacare, one of the goals was to have computer systems talk to each other nationally. And so we and something, I don't know what the percentage is, but many pediatric centers in the country are on Epic. A number of others are on a platform called Cerner. And then there are a number of other platforms. But it really has been incredibly valuable when we do second opinions. If we can look at the computer record of another center, we can make a lot of insights and clinical care advances that we just couldn't do if we were sort of winging it with a couple of, poorly faxed paper records. But I would encourage everybody to go back and look at every place they've ever been and collect those records and scan them to a PDF. It's an incredibly valuable resource, and it makes your care better. You can't always understand those records, but if you don't have them and you don't understand them, you won't get great care. So I think that's a really important thing. We look at those records, we write a little summary first, and then we try to have coordinated visits with the specialists. We understand that most pediatric gastroenterologists have seen Alagille. Some have seen a few cases, some have seen 10 or 20, but most of the specialists that they work with have never seen a case. So if you have significant kidney disease or endocrine disease or other abnormalities that really matter, it's good to have specialists who are familiar with those kinds of problems. Sometimes a cardiologist or a cardiac surgeon can look at a patient with, say, tetralogy of Fallot, and they kind of know what to do because it's tetralogy of Fallot. But tetralogy of Fallot in Alagille syndrome is sometimes significantly different than it is if you have tetralogy of Fallot in 22q deletion or Down syndrome or isolated TET. And so having someone who knows those things, and Jeff will certainly talk about this later on in the day, that focused expertise makes a major difference in all the different organ systems. And so there are a number of centers now in the country that have seen enough Alagille syndrome that they can they have that expertise in other people, so that you're not walking in with Benita's kidney paper to a nephrologist in, someplace and saying, my liver doctor said, give you this kidney paper and you'll know what to do, but I know you've never seen this before. That's not like high confidence, although it actually works. People want to help. They'll go in the back room, have a coffee, read the paper, come out and say, I got a plan. All right, we've tried very much in our second opinion program to do collaborative care with family and with the local primary gastroenterologist. We recognize even before telemedicine, we used to have something called telephone medicine, where, you know, if you're on the other side of the country or the other side of the world, you can't come in every time you have, you know, a bleeding xanthoma or, you know, a change in the color of your urine. So we need the local people to be partners. So we don't ever want to be competitive with them. We want to be collaborative with them because they don't have as much experience in this. They might have a lot of experience in something else. We need to work as a network and a team around your children and your families. And we try very hard to do that. You know, we tell our fellows, don't sit there and say, oh my goodness, do you know they missed the thyroid disease? Like, that's not very helpful. Thyroid disease is a standard part. Let's deal with it, you know. Okay, family education. We believe this is really important for rare diseases and rare complicated diseases because if you collect a few papers, watch some information, go on the Alliance website, you can learn enough to help your doctor be better, and you can understand what's going on with your child. So we, for more than 25 years, have done annual picnics at the Gaiman home in Pennsylvania. It's been kind of a, you know, hot dog, hamburger, and stuff potluck. It's been wonderful. We give talks, and we really did this since kind of the beginning of time. They've generously hosted this. We've had education days that are sort of focused education days, both at CHOP and nationwide, the little two-person traveling show. But really, the most important thing have been these Alagille International Family Symposia, which are really spectacular. And for those of you who haven't been to one, you definitely should go. We're all virtual now, so that anything can happen at any time. But our first one was in Milwaukee, Oregon, in '98, and the technical problems, the housing problems, but it was lovely, and it was really, I felt it was like Boy Scouts, Girl Scouts out in the woods. You know, shared communal bathrooms at the end of the hall. It rained way too much. We didn't have a laser pointer, so we were using a big bamboo pole to point the things on the slide. It worked, examining kids on picnic tables, you know, but we've come a long way, and many of these are now videoed. You can hear the talks, and obviously COVID has pushed us all into very sophisticated video platforms, so that patient education now should not be a problem. It's out there, it's in a lot of places. You should be able to get it, access it, and if you know the issues as a patient or a parent, you'll be much better cared for, because you'll know what to think about, what to ask, in what's otherwise, you know, an incredibly complicated disease. I really think there is almost no disease that we take care of that's more complicated than Alagille syndrome. More manifestations of more types, ranging from genetic to nutritional to degenerative, and so patient education really important. I think I can put a little plug in. We're booking Cincinnati yet again. It's a perfectly geographically placed area with a great place for both, well, for everyone, the scientists, the clinicians, and the families to sort of be. And so we're hoping to get that off the ground, and we're hoping that we'll be able to do face-to-face at some point in the future. We will. 2021, we can hope. These were in large measure pushed by the Alliance, although we've made these kind of educational DVDs for other diseases as well. These are purely aimed for families And, you know, they were made in the era where everybody had a DVD player. As I've been instructed by my elderly children, you know, they're not as valuable anymore because people look at them and go, why is this not online? Why is it not on Hulu or something? But we've given out over 3,000 of these. The Alliance has sent out, I think, almost their entire stash. We're down to like our last 20 or 30. And you can see here the part of the CHOP team. So this young lady lectured with us at Downstate for a couple of years at the medical school. There's Binita Kamath, Kathy Loomes. When we get, you know, marketing and PR involved, the pictures get nicer. But a lot of people participated in this, supported in part by a company and by families. And the information that's in the newer edition of this is still good. There are very few things that have really massively changed, and this is Alagille 101 and 201. And I think the thing that we tell families is that this is the spectrum from good to less good. It doesn't mean your child is going to get all of these things. And eventually we will put this online and update it a little bit more. It's easier to do than it was. This was a heroic thing at the time, and a great partnership between all the different groups. But I think more and more these educational things will be easily available, and hopefully most people on this got one of these, you know, either from the Alliance or from our office. So as time has moved forward, part of clinical care is investigating the disease and adding significantly to the knowledge base. And these are the people, first panel here, gastroenterologists, liver doctors. Second panel with Nancy, Ian, Kathy, and Binita, a tremendous number of researchers at CHOP. Many people have cut their teeth and honed their careers on Alagille syndrome. We have great pathologists who are involved, cardiologists who do research, anesthesiologists, the nutrition people, general nutrition issues, bone issues, kidney disease, surgeons have been involved. They're an important part of things, orthopedic surgery, endocrinology, and neurology. So these people are involved. For the people who can be clinical, they're clinically involved, but for the people who either have labs or work with people in the labs, they've also contributed significantly to the knowledge and then ultimately to the care. So the other thing, and you'll be able to collect this, you know, from the recording, but this is sort of our core clinical data set. So we kind of fill this out for every patient. And if you bring this to your new practitioners, your new physicians, it really is very helpful in crystallizing the big picture of your care or your child's care in terms of, are you an adult who is found symptomatically, or are you a child who was sick at, you know, 4 days of life? Do we know your mutation? Do we know the other mutations in your family? And then what's the status of your liver disease? And because liver doctors still claim Alagille syndrome, although others might say not so fast, we break down the liver disease into all the different features that we watch: the cholestasis, the pruritus, the xanthomas, the jaundice, the portal hypertension, the GI bleeding, and the amount of bile duct paucity. But then it's also important to know the facies, the eye, kidney, blood vessel turns out to be very, very, very important. Ian, Binita, others wrote some really seminal papers that had us really thinking about blood vessels in the chest, not just the heart, where they're incredibly important, and you'll hear a lot more about that, but in the abdominal space with kidney arteries, aorta, other things, and then the fragility of some blood vessels and the other complications, really a major area that we didn't recognize for a long time. Bone and spine, what's the family history? We have a line, did we give you an Alagille DVD? Are they enrolled in the National Collaborative, which you can only do if you're seen in an ongoing fashion at the centers that are in the children grant. So we do have some patients who come to see us just for their research visits, but they get their clinical care in collaboration with someone else that's, you know, far away out of our area. And then, you know, this is an area that is important and families have different feelings about it, but have we done genetic counseling? Who did it? Do they want more? Do we do the counseling with the parents, but now the 10-year-old is 20, and do we need to update that and so on? So that's kind of, the letters are obviously much longer than that, but this is our sort of core data set that we fill out for hopefully everybody that we see. Probably nothing is really everybody. So that's the talk. And if I've been successful, I'm back to the broader screen. And I think, Cher, if the moderator agrees, we have probably got a minute or two or as much time as you want to give to any questions or comments or concerns.
Yes, thank you, Dr. Piccoli, so much. I am always just blown away by the history and just everything. Just your knowledge is just incredible. We do have a couple of minutes if anyone has a burning question for Dr. Piccoli. I think Roberta can see if you raise your hand or take yourself off of mute.
I have a question.
Stephanie? Yes,
I'm just
ma'am.
going to jump in.
Sure.
How do we, is there like a master list, or how could we know or make sure that like our center is part of the children collaborative or anything like that, just to know?
Yeah, no, it's an important question. And I should say, there are great centers that decided not to be in those initial grants. And it's I don't want to say it's a club, but it's a closed entry environment. So there are some really great liver centers that didn't want to write a grant in the beginning, or, you know, and there are some that were in it and are out, and there are some that are, you know, and liver disease is hard. There are a lot of other pediatric gastroenterology areas that it's easier to practice in, it's easier to survive. So all of that being said, there are some real, you know, phenomenal pediatric centers and good liver programs that are not in it. But if you want to know who's in it, just type Children Liver Consortium into Google, and you'll hit the NIH site, and you can find as much or more about it. They also have listed like 120 papers, not all Alagille syndrome, and not everyone who wrote an Alagille paper is listed there, but the NIH site is great. It's easy to get to, and you know, that gives you the list. And at one place in there, there's a cute little map with like a button on each center, you know. So.
Thanks. And Stephanie, we can also post that for you too, so you don't have to.
Okay, I was just curious. Thank you.
Good.
And one question, Dr. Piccoli, can I?
Sure.
Sure.
During the history that you just described, did you ever contact hospitals outside the USA?
Yes, and you know, it's important to say that some of the really incredible work on Alagille syndrome has been done in a number of different centers. You know, at King's College in England, Alagille's hospital, Bicetre in Paris, Maggiore in Italy, for a long time, Ingo Huntsman in Germany. So there are many excellent centers, and we have had different collaborations with different people over time. Belgium, the more I think that there are a lot of places, Melbourne, that have really good programs. We communicate with, I think, anyone who contacts us. A lot of us are not multilingual. We hired someone recently who speaks like 6 diseases, and I'm always in awe of that. I know 5 words of Italian, and think I took French once upon a time, but pretty much everybody does communicate at the scientific level, communicates in English. So we're happy to help and work with anybody at any time. So.
Thank you.
Anyone else have any questions for Dr. Piccoli? I have one here that came in, Dr. Piccoli, and it's a very general question. For a new family coming in, what is your best piece of advice for a brand new family?
Yeah, I think to get as much information as you can about the disease, accessing it yourself, as well as getting an understanding of how familiar the physicians in your region are with the disease. So there are many times where someone will come into our center one time early on in life, where we'll go over a lot of those things and maybe redirect or pivot some of the therapy based on what we think is happening and is likely to happen. The one thing we always tell families is that every organ system is independent. So you can have someone, and as we went through the last 30 years of research studies, we've realized that some people have tremendously severe cardiac disease, and nobody ever used the word Alagille syndrome until maybe they had a sibling who had it or something else occurred, and then people started to think about it. There are people who have no liver disease at all. There are people where the only manifestation or the only apparent manifestation is in a different organ system. Or some people just have like a little bit in their eye and their spine and they're fine. So understanding that spectrum and recognizing that you need to look in those other places. I said for a minute, thyroid disease. A lot of people just don't think about thyroid disease as a part of Alagille syndrome. But a surprising number of kids and young adults have thyroid disease. It's easy to check. Blood tests, just add it into the 20 other blood tests. Looking at the kidneys is important. So I think those are the things. A lot of it is education, checklists, communication.
Okay. And then I have one other that has just come in, back to second opinions. I'm not sure how to approach my doctor. What do I need to say to them when I want a second opinion? Yeah,
that's a sometimes dicey and tough question. So most pediatric gastroenterologists and hepatologists, liver doctors, are totally fine to get a second opinion, family directed or not. They just recognize that maybe it'll help their patient, maybe it won't, but either way, no harm done. There are some people who get a little fussy about it, and I think the one thing that people, referring physicians, appropriately get upset about is that if we see a patient start to change things don't communicate well, then that's a mess. And we really think that's wrong. So, you know, it should be a collaboration. It should be a team. And you can't have 2 different cooks or 3 different cooks. You know, and that's even a problem if like your liver doctor's at one place and your kidney doctor's at another place, and they're arguing about like the vitamin D, which one and how much, you know. So some people do it as a sneak. We, maybe that's a bad word, but you know what I mean. We have on our second opinion intake sheet, are we allowed to contact your doctor? And sometimes people say no. They just know their doctor is not going to be happy. Now, the thing that people don't realize anymore, and it's kind of an oh my goodness, is that if you show up in our system for a visit and their system has a computer that communicates with our system, they'll see it. And it now comes up on your screen. You don't have to query it. You can see, I can see that Kathy Loomes, no, I can see, but who's somebody who's at another place that we've graduated. I won't use any names, but I could see that they went to this person if they're in the same kind of computer system that we're in. So it doesn't cross from brand to brand, but most people are using one brand of electronic health record now. So then there's an annoyance because like you did this behind my back. So I think the best thing to say is, look, I'm happy with your care, but these guys in San Francisco, Toronto, Chicago, whatever, they do a lot of this. I think it's always fair to say, since we're all related, we are, if you go back far enough, apparently we all have like Denisovian and Neanderthal and, you know, so we're all related. So you can always say, look, I got relatives in Chicago and I just thought that, you know, we were going there and we just wanted to drop in with those people and see what they thought. I just wanted to tell you.
Okay.
You know, my mother-in-law said, that's another one that works.
All right. Okay. So we know there's hesitancy, but just want to get the message out that it is okay because we are collaborative, part of a team, you know, for you and your child. Thank you again, Dr. Piccoli. We will see you again shortly. We are going to, Roberta, if you can switch over, we're going to go to nutrition, and we are going to hear from Dr. Kathy Loomes, and then our family portion of that will be Stephanie Perry, who will talk to us a little bit about her experiences with Bryce.
Well, good morning, everyone. Thank you so much to Cher and Roberta for setting this event up and for inviting us to come and speak with you today. I have been charged with speaking about nutrition in Alagille syndrome, and the schedule says that I'm going to first give an overview and then spend a little time talking about some nutrition research. So I've broken the talk up into 2 parts based on that. I do have a few disclosures. I've been working with several of the companies listed here who are all trying to develop new therapies for patients with Alagille syndrome, but this doesn't impact what I'm going to talk about this morning. So nutrition is a huge concern for patients with Alagille syndrome, almost universal, I would say. Many kids with Alagille syndrome have difficulties with taking in enough calories, with absorbing the calories, and also sometimes utilizing those nutrients. And the result of that is that they can have poor growth and also nutritional deficiencies. There are many different factors involved in the development of malnutrition in children with Alagille syndrome. And one of the major factors can be fat malabsorption because of the cholestatic liver disease. And many of the patients are also not able to consume enough calories and other nutrients, or they may not tolerate the amount of feedings that they really need to be able to gain weight. So as I was putting this talk together, I thought, let me see if I can find a growth curve that exemplifies what growth in Alagille syndrome looks like. And I realized as I started looking through a few different charts that as with all of the other features in Alagille syndrome, one size definitely does not fit all. So this growth curve is a patient that we've been following, and it's been very difficult to get him to gain weight. He's pretty proportional, he's developing well, he's running around and talking and chatting, but he's just a small guy, and he has been for a long time. This is another patient that we've followed with Alagille syndrome who underwent transplant a couple of years ago and has really taken off with his growth. Height and weight. And then this little girl also underwent transplant, but really she's remained small. She just keeps growing. She's slow and steady and growing right along the 3rd to 5th percentile. So looking at all of these growth curves makes us realize that like anything else, all of the kids with Alagille syndrome are individuals. Everybody's a little bit different. And one approach doesn't work for everybody, but there are some general principles that we can follow along with trying to optimize growth and nutrition for these kids. So when we see kids in the office, we're always thinking about calories. We're always trying to think about how can we maximize the number of calories that we get in, because often children with Alagille syndrome need to consume more calories than healthy children. The recommendations always depend on a child's age, body composition, and also the activity level and how many calories they're burning. And often we are consulting with a dietitian who we work with very closely to help us in figuring out what the caloric needs are for each individual patient. In addition to age, for older children, there are some determinations of gender for caloric requirements, and in general, boys require more calories than girls. So where do the calories come from? There are really just 3 sources: fat, protein, and carbohydrates. In general, the recommendations are that healthy people take about 50 to 60% of their calories from carbohydrates, less than 30% from fat, and 20 to 30% from protein. For children, these recommendations are similar, except that infants and younger children need more fat in their diet because they are developing brains and making new neuronal pathways that need fat for myelin to develop there. In general, if we look at the intake of children with Alagille syndrome, they do consume lower fat diets than healthy children. But they may not absorb fat completely, and fat is the highest calorie part of the macronutrients. So fat has more than twice as many, or about twice as many calories per gram as protein and carbohydrates. So fat really has a lot of bang for the buck in terms of calories, but sometimes it can be difficult to really load diets up with fat in kids with Alagille syndrome and chronic cholestatic liver disease because they don't absorb it and they may develop diarrhea and intolerance of those feeds. We definitely try not to restrict fat because the child will benefit from the calories and also the vitamins in the fat that they do absorb. The other thing that is important about fat is it contains essential fatty acids. And these fats are necessary for maintaining integrity of the skin, structure of the cell membranes, and also making important biologically active compounds. If the fat is too restricted, children can develop essential fatty acid deficiency, and kids who have essential fatty acid deficiency develop really severe rashes such as what you see here. So one of the mainstays of fat composition in some of the formulas that we use, and also some of the supplements that we use to give more calories to kids with liver disease, are medium chain triglycerides. And this is a specific type of fat. And the reason we like to use it is because medium chain triglycerides don't require bile flow for absorption. They can just be absorbed as is. And so if the bile flow is poor or slow, as it is in cholestasis, these kids can still absorb medium chain triglycerides. So we often, especially in infants, will use formulas that have a different fat content to typical infant formula. Something like progestamel or alimentum has more medium chain triglycerides than a usual formula. So we will often supplement with those or use those for kids with cholestasis. And then we can also just use the MCT oil by itself, or there's an emulsified form of it that can be used to add to things, or just given by itself to add calories. As I said earlier, a registered dietitian can be very helpful in making recommendations for boosting calories. But no matter what we do with the diet, some children really just can't get enough by mouth. And in those cases, we do use either supplement feeds through a nasogastric tube, which would be placed usually for nighttime feeds in a child to give them extra calories while they're sleeping. Or sometimes if it seems that we will need to do this on a more chronic basis, we will recommend placement of a gastrostomy tube, which is a small surgical incision to place a tube into the stomach. There are many kids who do very, very well with these interventions and help them to gain weight and achieve optimal nutrition and achieve their growth potential. But sometimes these tube feedings do come with issues with tolerance and spitting up and things like that. So what about fat-soluble vitamins? This is something that is a huge issue and a big focus for all children with chronic cholestatic liver disease, not just Alagille syndrome, but particularly in kids with Alagille syndrome, they can really develop profound deficiencies of some of these vitamins because the fat-soluble vitamins A, D, E, and K are absorbed along with fat. And when bile flow is poor, the secretion of bile acids into the intestine is not happening as it should. These vitamins are unable to be absorbed normally. And so we need to give additional supplements, and sometimes at very high doses, in order to normalize the levels of these vitamins. In kids with Alagille syndrome, up to half of the dietary fat can be malabsorbed. So along with this is malabsorption of the fat-soluble vitamins. We really need to supplement, and we need to monitor the levels to make sure that we're doing a good job of supplementing and adjust the doses as needed to prevent these deficiencies. Many children receive ADEX or a combination dose of the 4 fat-soluble vitamins, but we often also will add individual supplements and just tailor the doses to the levels to make sure that we're achieving adequate levels of the fat-soluble vitamins in the blood. So a little bit more about each of these fat-soluble vitamins. Vitamin A is required for normal vision, for cell differentiation, reproduction, growth, and immune function. It's mainly found in foods of animal origin, so liver, dairy products, including milk, cheese, and butter, as well as tuna and sardines. I imagine there probably aren't a lot of kids who snack on sardines, but it is a good source of vitamin A. If one becomes deficient of vitamin A, one of the main signs of that is increased susceptibility to infection, difficulties with growth, and also night blindness. So vitamin A is very important for the function of the retina. Vitamin A can also be toxic, and it can be toxic to the liver specifically and cause scarring or fibrosis within the liver. So one needs to monitor this carefully and be careful about over-supplementation of vitamin A. And for this, we do careful monitoring of blood levels and look at that periodically to make sure that we're not giving too much. Vitamin D is another important one, and vitamin D can be really hard to get adequate levels in kids who have chronic cholestasis. So vitamin D is important for intestinal calcium absorption and really important for strong bones. So bone mineralization requires vitamin D, and kids who lack vitamin D can get difficulties with their bones. Naturally, it's found in a few foods, such as fatty fishes and also eggs. There are some fortifications, so milk is fortified with vitamin D, as well as some yogurts and orange juice. And if you're out in the sun, your body will actually make vitamin D. But of course, we have to balance overexposure to sunlight. But if you're out in the sun a little bit, it can be enough to help the body make some vitamin D. What if you're deficient in vitamin D? The most severe bone manifestation of vitamin D deficiency is rickets, which causes bone deformity and can be very difficult to deal with. These kids need massive supplementation with vitamin D and can then help normalize the bones. But if it's not detected, there could be irreversible changes to the bones. We often do have to give very high doses of vitamin D in kids with Alagille syndrome, and we're often checking the levels and adjusting these doses to keep the levels as normal as we can. Sometimes we're happy just to get into the normal range. High end of the normal range would be great, but if we can just get it normal, sometimes we're satisfied with that. If patients are taking cholestyramine or Questran, this can bind vitamin D, so they should be given several hours apart. What about vitamin E? This is important as an antioxidant. It's found in vegetable oils, nuts, and grains. If one is deficient of vitamin E, it can result in muscle weakness and degenerative neurological problems. The water-soluble forms of vitamin E are most easily absorbed in children with cholestasis because they can be absorbed not with fat, so that is helpful when bile is not flowing well. Vitamin K is another very important cofactor. So vitamin K is needed to actually activate all the blood clotting factors that are made in the liver. And it's also important in bone metabolism and bone mineralization. If one wants to look for vitamin K in your diet, it's going to be found in dark green leafy vegetables such as spinach or kale or broccoli. And deficiency in vitamin K can be very dangerous. So sometimes it can just be silent and one might not know that the clotting times are prolonged, but this can cause serious bleeding if it's not detected. The best way to monitor for vitamin K deficiency is to check the PT-INR and the PTT, which are routine labs that are typically monitored in kids with chronic liver disease. We actually don't have an assay to measure vitamin K levels directly in the blood. So we use this indirect way of looking at vitamin K sufficiency. There is an assay of something called PIVCA, which is called proteins induced in vitamin K absence. And that is maybe not widely available, but if there is vitamin K deficiency, it will be highly elevated. If the oral vitamin K sometimes is not sufficient, we do have an injectable form of vitamin K, and some kids really need to receive this on a routine basis in order to make sure that they continue to have normal blood clotting numbers. Calcium is another important nutrient or mineral for bone growth and density. Of course, it's found in dairy products such as milk, ice cream, and yogurt. And these are all things that are also kind of high in fat and calories. So we often, if kids can tolerate milk, we do try to emphasize some of these high calorie foods to boost calories in the diet, and they also are good sources of calcium. Other foods such as orange juice and cereal bars are also being fortified with calcium, so that can be a useful source as well. Kids with Alagille syndrome may need more calcium than healthy children because of the fat malabsorption, and also with vitamin D being important for calcium absorption, that can go hand in hand. Magnesium is another important mineral, and it's part of the structure of bones and teeth. If one eats a lot of green vegetables, cereals, beans, and animal products, they're all good sources of magnesium. If a patient becomes depleted of magnesium, it can lead to low calcium levels and can also contribute to the metabolic bone disease that we see in chronic cholestatic liver disease. Copper is another important element. Copper is a cofactor in lots of different enzymes in the body. It's important for bone marrow function to make red cells. So if one's deficient of copper, you may not have normal blood counts. Patients may become anemic. It's important for synthesis or formation of connective tissue. Copper is widely distributed in the food supply. Shellfish and liver are good sources, but also copper is present in chocolate and also in mushrooms and some beans. Usually in kids with cholestasis, we don't actually see copper deficiency, but we do worry about copper overload sometimes in these patients. I know Dr. Piccoli has been very focused on this recently, and thinking about how copper toxicity could be affecting the liver disease and Alagille syndrome when copper excretion really occurs in bile. So there's another inherited disease of copper metabolism called Wilson disease, where the copper can't leave the liver because of a protein that's necessary to transport it into bile. And in Alagille syndrome, if bile is not flowing, the copper can really build up in the liver, and this can cause some toxicity and oxidative injury in the liver cells themselves. Zinc and copper compete for absorption. So if the copper levels are too high, we can give zinc to try to reduce copper absorption. So that was just a super quick overview of some nutritional aspects of considerations for nutritional treatment of patients with Alagille syndrome and cholestasis. We know that kids are at risk for poor growth and nutritional deficiencies, so this is a very big focus for us as clinicians. We need to make sure that we're giving plenty of calories. We want kids to reach their full growth potential, and sometimes we have things working against us, other factors such as the liver disease, sometimes kidney involvement can impact growth, as well as congenital heart disease. So we have all of these different factors, but we want to try and optimize everything. We need to really carefully monitor the fat-soluble vitamin levels and make sure we're doing a good job of supplementing them. We may need to give additional minerals, and we want to individualize everything to meet the nutritional requirements of the individual child with Alagille syndrome. And I think in doing that, partnering with a dietitian is very, very helpful. And they have excellent insight into a lot of different tricks that we can do to increase calories or in managing supplemental tube feeds if those are necessary. So that, Cher and Roberta, that's what I have for the first part. I don't know if you want to stop here for questions, or shall I carry on with the research and then we'll do questions at the end?
I have a question.
Sure.
Was that a bone of a finger X-ray that you showed in your presentation?
It was the legs.
Oh, okay. Okay.
Yeah.
So Kathy, one of the big issues that we see for nutrition in our support groups is, in infancy, when children are starting to get their NG tubes or G tube, and we see a continual issue with projectile vomiting and being able to absorb the nutrition in the infant stage. Can you speak to that at all? You know, we see diagnoses of reflux at that time, and then later on into, you know, being a toddler, that reflux is gone, or they're not being treated for that anymore. Can you speak to what you might know about that phase of infancy where, you know, this projectile vomiting and the lack of ability to hold down formula or food is going on?
Yeah, that can be a huge problem, and I know it's really frustrating for families, because you're feeling like you're spending your whole entire day, like your mission is to get these calories in, and then the calories come flying back out of the child, and it's just, you know, you just want to cry, I'm sure, when you see that happening. So you know, it is a huge issue, and I think it's multifactorial, and again, it, you know, depends on the patient. So infants often have reflux. Healthy infants have reflux. So reflux is very, very common. It's one of the most common things we see in GI clinic. We know that in babies, they have a weaker muscle at the lower esophageal sphincter. They're just more likely for things to come back out. In kids with liver disease, you may have an enlarged liver. You may begin to have an enlarged spleen. Some children may have some fluid in the belly, depending on how their liver disease is. But at least if the liver and the spleen are both a little bit big, you think about a small baby, and there's just less room in the belly to fill the stomach with whatever we're giving them. So, you know, so that I think part of it is mechanical, that there just isn't a lot of space there. I haven't, maybe, I don't know if Dr. Piccoli wants to comment, but I haven't really thought of Alagille syndrome as having a primary motility problem. You know, I don't think there's necessarily a problem with the way that the stomach empties. I suspect it's probably more mechanical, and just the fact that we're trying to pour so many calories in that the babies are just, we're filling them up, you know, too quickly. So there are some different ways that we can try to get around that. One is to slow things down. So if we're using tube feeds, we can try to do sort of a slower, more continuous type of feed. We can try and do small, frequent feeds rather than giving them too much at once. We can use different medications that can help to prevent or help to treat reflux in terms of preventing any irritation of the lower esophagus. So like acid blocking medications to prevent injury from that reflux. And I think, you know, if the lower esophagus starts to get inflamed and injured, that makes everything worse. So we definitely want to prevent that. At times we can use medicines that help motility or help emptying to prevent the kids from spitting up. And then if we really get pressed and we're trying to do NG or G-tube feeds and they're just not being tolerated and the baby's not growing, for a period of time, sometimes we will actually put in a different type of tube that bypasses the stomach altogether, and we start delivering the calories a little bit farther down to the small intestine. So we do have a lot of different ways that we can try to deal with this. And as you say, it is something that usually gets better over time. So it's more of trying to do as much as we can and address it in many different ways to try and help get through that really difficult, stressful period in infancy and early toddlerhood, and then it tends to improve. But it definitely is a big problem. I can't hear you, Roberta. Are you muted?
Thank you so much. Katie Temple has a question from Scotland.
Oh, from
Yep.
Scotland.
Yeah, hi.
Hi.
Hi, thanks for your presentation. It was really interesting. I noticed that a lot of the foods that you were talking about are dairy products. My son's got a dairy allergy. Do you find that kids with dairy allergies have even more problems getting the right nutrition into themselves?
It can be difficult, for sure. I know, you know, it's probably different in different countries, but we are lucky that we have a lot of very specialized types of formulas that we can use. And you know, some of them are not as palatable, but some of them are actually pretty good, or the kids will get used to them and will actually drink them. So we have formulas that are based on different types of protein. There's definitely some soy ones, but then there's lots of formulas that are totally broken down, where if kids have allergies or intolerance to milk or soy, we can use these to deliver lots of calories without using milk protein. And then, of course, there are other options for different types of yogurt and non-dairy types of products that can be used.
Yeah, and as Kathy said, the one other thing is the composition of the formula itself, separate from allergy, is not always well tolerated by infants. And so we think about the particle density of the formula that goes in, and the concentration of calories, the amount of liquid, and the amount of fat that we use. So for a long time, when Kathy and I were a bit younger, we used to put a tremendous amount of MCT oil into these formulas. And it turns out that wasn't as well absorbed and wasn't as well tolerated. But like for your child, if you use an elemental formula, meaning, you know, one of these anti-allergy formulas, and I think you have different brand names than we do, but it's the concept. But then if your dietitian says, we're gonna make it 26 calorie per ounce, when you take that kind of formula and you concentrate it, there's a tremendous amount of particles. And then if they do an additive and they say, oh, we're gonna add this, or we're gonna add that, sometimes people aren't thinking that what they're doing to this makes it disadvantageous rather than advantageous. So there are a lot of times where starting at a slightly lower rate and goal, and probably the best single thing, it's not most convenient, but it's way better than it used to be because of the technical aspects, is to just go 24 hours a day continuous in the beginning to get the GI tract used to the calories. And once upon a time, we had these pumps that weighed 20 pounds on these 6-foot poles, and everything was a mess. But now you can get these cute little pumps. You can have the teeny little bags. You can put it in a backpack. They can roll around on the floor. So continuous is always better than bolus. Good particle density is always better than too much. But always, ultimately, the eye on the prize, you want to get more calories absorbed. And if you have an occasional vomiting, but the total number of calories is good, and they're gaining 20 grams a day, okay, you're achieving your major goal is to gain. And, you know, as Kathy said, most people get better with this over time. So it's key not to give up. And if you need to put the tube in the J for a little while, less convenient, need a radiologist, but it's another approach.
Thank you. Another question is, how can you give some advice on how to balance midnight feedings with parents sleeping and the emotional turmoil that comes from having an NG tube in where they can hook into it and pull it, and the worry of aspiration? We have a lot of new families that are dealing with that, and you know, it gets to a point where there's some times where we have to tell them it's okay to create your own routine in the middle of the night, whatever that means. If it's, you know, get 2 hours of sleep and turn the pump on for 20 minutes and go back to sleep, or get up for 2 hours and turn the pump on. The parents sometimes need permission to make their own routine, especially when they're so worried about aspiration and these midnight feedings. Can you speak to that a little bit?
Yeah, that's another big concern for parents. I mean, we do try to kind of really talk to our families and say, you know, what's going to work for you and your routine. I mean, it's easy for us to say, well, do this, this, and that, and feed around the clock every 3 hours, and you know, people just aren't getting any sleep, and everybody needs some sleep. So, you know, I think compromise is key. I think in terms of the aspiration risk, I mean, we do have a lot of patients who are on overnight NG or G-tube feeds, and we haven't really seen that as a major problem. You know, lots of kids are sleeping through the night and getting their feeds without somebody with eyes on them the whole time, and they're doing okay. And that's something that we do a lot. But I know it does make people nervous, and it's something to think about. You know, sometimes we can kind of change schedules to deliver more calories during the day and less at night. But as Dr. Piccoli said, sometimes with the tolerance issues, you kind of need to use more hours throughout the day to get those calories in, because you really have to slow down the feeding or give more frequent meals more often. Sometimes, depending on insurance, we can advocate for some home nursing hours, which can be really helpful and allow families to get a break at nighttime if there are overnight feeds going on. That can be a good way to advocate for the need for home nursing. So depending on people's situations, if we can do that and they're interested in it, that can be something that we can write letters for and try to help with, because that way the parents can get a good night's sleep and know that somebody has their eyes on the baby and is dealing with any issues that arise in terms of pulling that tube out or having it get dislodged or whatever it is. Yeah.
Excellent.
Yeah, I would, if I could just echo, in nearly 40 years, I always think about, is there going to be aspiration? And is this cord going to wrap around their neck and hang them? And there are a few people who have like oromotor abnormalities and so on, where they can't separate the two pipes and so on. It's a different story. But in all the other kids, and I would say thousands, hundreds of thousands of nights of tube feeding, I've never seen it. It's probably not impossible. You know, your kid could like stand up on the edge of the crib and wrap the tubing and, you know, but we don't see it. So it is, and it's important to like split the duties. If there are two adults, you know, to have one sleep with the child and the other one get a real night's sleep, so that at least every other night, then you're like an intern. Every other night you get some real sleep for, you know, a while. Mm-hmm. We have a hard time getting home nursing anymore, but it is less toxic and better. There are a lot of families who would say he tolerates the tube feeding overnight. The day is the problem, and that's the much more common scenario.
Stephanie?
So I was just going to say, one thing that we did for Bryce whenever he was in this stage is I got a pool noodle and I cut it like lengthwise. And so I popped that around his tubes, because we went from NG tube to a Broviac, which that's up by your heart. So then he was rolling by then. So then I was really scared he was going to choke himself. So the nice thing with the pool noodle is that I did it probably 2 feet long or so. So that he couldn't, even if he was rolling around in his sleep, it wouldn't like wrap around anyway. And then we also put a little wedge in under his mattress, his crib mattress, so that he was a little bit elevated, so that when he did projectile vomit, it would automatically, he would be, you know, a little bit higher up. So there's lots of, I think, brainstorming ways, and that's where I think like even throwing out a quick message on the Alagille Syndrome Alliance on Facebook and stuff can give people like, oh, this is the crazy contraption we created to work around that and stuff. So, but it is very challenging.
That pool noodle idea is awesome. I love that. I think we're going to steal that, right, Dr. Piccoli? We might borrow that.
I need.
Sounds good. Do we have to pay royalties for
yes,
that?
I want credentials. I want royalties. No, I looked it up because I was like, I cannot be the only one who's ever had this challenge. And so I looked it up, and it was, I think, on Pinterest or something, and it was glorious. I was like, this is phenomenal. So yes, I'm all about brainstorming and coming up with new ideas.
We are
Dr. Piccoli saying that
community.
the baby standing up on the side of the crib reminded me of this video that a mom sent me one time of her toddler standing up in his crib, and he grabs the tubing and starts pulling the pump towards the crib. He pushes the button to shut it off, and then he pushes it away and he goes, bye-bye.
Yes.
It was amazing.
One last question on this is, when you have a teenager transitioning into adult care, is there anything different nutrition-wise that they should be doing or be aware of versus when they were in the pediatric setting? Moving into the adults, they want to, eat more junk food, have a lot of pop, hang out with their friends, and,
Yeah, I mean, that's a challenge for all adolescents, I would say, in terms of nutrition and trying to get them to really eat a well-balanced diet. That's an issue for everybody. Once kids are a bit older, we're sort of shifting into more of the weight maintenance and kind of keeping good nutrition as opposed to continuing weight gain like we are for the little ones. But we do want to make sure that we keep good nutrition, keep a healthy body mass index, and try and get those calories in. But I agree that the nutritional content is a challenge that is hard in any kid of that age.
Mm-hmm. Mm-hmm.
Can I ask a question about the growth post-transplant? You showed two graphs, and one of them, the child gained weight, and another one, they kept tracking on the same curve that they were already on. What do you generally see post-transplant?
I'd say it's a bit variable. I mean, I think the literature is also variable on this. There are a couple of papers that show that maybe the catch-up growth isn't as good in Alagille syndrome as it is in other conditions like biliary atresia, for example. And then there are some other papers that show that there can be good catch-up growth and even linear growth after transplant, and we definitely have seen that as well. So I think like everything else in Alagille syndrome, there's probably variations from individual to individual in terms of what the growth potential is. And I think that some of the growth issues in Alagille syndrome may be sort of genetically mediated by the mutation in jagged 1 or notch 2. But there definitely are plenty of patients who can grow quite tall and gain good weight after transplant or after the liver disease starts to improve, if that happens as they get older. I think one thing that definitely happens after liver transplant is absorption normalizes. So the patient doesn't have cholestasis anymore. They're going to be absorbing their calories more completely. And so hopefully they can use those calories to grow. And we have seen a lot of patients where that happens.
Do you think it also might be age-related at transplant, or you think it's just more genetic?
I think there probably is some component of that where, but I think at any age though, if they still have good growth potential, if they haven't completed puberty, they should still be able to get some catch-up growth in. The little girl whose growth curve I showed where she didn't grow a lot after transplant, she was also, she had small parents. So part of it is also like anyone, if your parents are small, you may be small. The other child has a very tall father, actually, as I think of it. So, so part of it is just, you kind of look like your parents as well in terms of your height and your size.
Thank you.
As far as research, Dr. Loomes, what do you have in terms of the research, and what do you know about? Is there research in nutrition, valuable information that families can look up, or what do you think about the research aspect of nutrition?
So that's my next talk. Is that a lead into the next
It is.
the next question here?
Smooth, right?
So I realized, you know, as I was putting this together, that I think this is a major unmet need in Alagille syndrome. So I was trying to search, you know, Alagille syndrome and nutrition and growth, and Dr. Piccoli, I don't know if you agree, but I think there's just not very much great research out there. I mean, there's several excellent papers that were done from CHOP, actually, more than a few years ago, some of them almost 2 decades ago, where there have been some very specific studies that I'll talk about briefly in a few minutes here about body composition and nutrition and growth in Alagille syndrome as compared with other liver diseases. But there hasn't really been much recently focused on that. And I think it's an area that is ripe for more investigation. In the nutritional realm, most of the work has been done really in bone health, and I'll talk about some of that. And then a little bit in the lipid area, which we haven't really touched on at all. But I'd say just in terms of general nutrition research, there really isn't very much out there. Dr. Piccoli, what do you think? I think we need more.
Yeah, I agree totally. I think that we went through a phase where, so for the people who are, you know, 25, 30, 35 years old, we used to have terrible problems with rickets, much more so than we do now. We had terrible problems with spinocerebellar degeneration. The first patient I ever saw when I was in Boston, that it was a breakdown of the neural communication pathways for walking and coordination, because we had no preparations that did vitamin E. A lot of that research happened a long time ago, and I agree, there hasn't been as much. There are actually very few people who are trained in pediatric nutrition, and a while ago, people were worried about undernutrition in those fields, and so that micronutrients were relevant to Alagille syndrome. And now most of our nutrition trainees are worried about what is literally and figuratively a much bigger problem, which is overnutrition, the liver disease of fatty liver, obesity, diabetes, metabolic syndrome. It is an area that clearly could use much more research. It also needs more people who would do the research.
Okay, with that, I'm going to launch into this little overview of nutrition research and Alagille syndrome. I was charged with giving a short research update. So this is very short and really like a 30,000-foot view of some of the research that's been going on in nutrition-related topics in Alagille syndrome. And as we just said, growth deficits, of course, have been recognized from the earliest descriptions of the syndrome by Daniel Alagille. And there have been some studies of body composition and resting energy expenditure and growth in Alagille syndrome. But as we just said, really nothing recent and nothing too new in terms of ways that we can intervene to really impact this problem. And I think this is an area that we need more investigation. One thing we haven't really discussed yet is that children with Alagille syndrome seem to have an increased fracture risk. So there have been a lot of studies of bone health, and we've been involved in some of those, and I'll talk about some of them briefly. And then there also is an issue in kids with Alagille syndrome, especially those with significant cholestasis, with hyperlipidemia and xanthomas, and I know that's a major concern for families. And there have been some interesting studies of lipid composition, but this isn't also an area that we've thought about and we think could be a good area to focus on for future research. So I'll just spend a few minutes talking about each of those areas. So the growth deficits have been recognized, but this is really an unmet need for new research in this area. So I'm just going to highlight a few studies that are now pretty old studies that have been done on this. So Dror Wasserman, who was a fellow at CHOP years ago when I was a fellow, published this paper in 1999 in Journal of Pediatrics. And he did nutritional assessments in 13 children with Alagille syndrome. And these were just sort of full nutrition assessments looking at body composition and anthropometrics and height and weight and growth trajectories and all of that. And in this paper, he described deficits in growth, nutritional status, and also fat mass in these patients. Alicia Rovner, who was a dietitian and did a lot of research in the Alagille syndrome group at CHOP in this era, also published a paper in 2006 where she looked at resting energy expenditure. So one hypothesis was that patients with Alagille syndrome didn't grow well because they were burning more calories than the average kid. And there's a way that we can measure this scientifically. We have a big nutrition growth lab at CHOP. And one of the ways that we can look at this is to measure resting energy expenditure, which just looks at if you're just sitting there, how many calories are you burning? They did this in 16 Alagille children and 37 healthy controls. And they found that resting energy expenditure was not actually increased in Alagille syndrome. So that was interesting. And again, goes back to the idea that maybe they're not growing well because they're not absorbing the calories, not because they're just burning more. Jessica Arve, another dietitian who worked with our group in the early 2000s, published a paper on body composition. And this was looking at Alagille syndrome compared with biliary atresia, which is another chronic liver disease with comparable cholestasis, at least in younger children. And they found that the growth deficits were more significant in Alagille syndrome with low weight, low height, less fat, and less muscle stores in these patients when they looked very carefully at the body composition. So these are a few of the papers that have come out about this, but I really was having trouble finding a lot of recent work, and I think this is an area that we need to focus on to do more. So some of the main work that's been done in the nutritional realm in Alagille syndrome is on bone health. We know that these kids have an increased fracture risk, which seems out of proportion sometimes to their degree of cholestasis or even their vitamin levels. We had a retrospective study a few years ago that Tina Bales led that showed that in a survey that we did, that kids were getting very significant fractures. So not kind of like little arm fractures that most kids would get just running around on the playground, but these were actually femur fractures, so significant long bone fractures with not very much trauma. And normally it takes a lot of trauma to fracture a femur, but these kids were fracturing femurs at a 50-fold increased rate compared to the normal population. So we have thought about this a lot, and there have been some studies of bone health and kind of looking at the structure and integrity of the bones in Alagille syndrome. So this paper, which came out a couple of years ago now, was a study that we did as part of the Children Consortium, and Dr. Piccoli mentioned this earlier. This is the Childhood Liver Disease Research Network, and one of the studies in children is a study called Alagille, which is a longitudinal study of children with genetic causes of cholestasis, one of which is Alagille syndrome. And we did DEXA scans, which is a way of measuring bone density on the whole body, on 148 children with inherited liver disease of these different types. 49 of the kids had Alagille syndrome, and then there were some other kids with PFIC, alpha-1 antitrypsin deficiency, and bile acid synthetic disorders. In the Alagille syndrome group, we did find low bone mineral content and low bone mineral density, which associated with poor growth. The kids with the PFIC had significant bone deficits that persisted after adjustment for height and weight. When we looked more carefully at the bone deficits in the kids with Alagille syndrome, we found that they correlated with the bilirubin. So the kids with a higher bilirubin had worse looking bones, basically, higher bile acids. Also, those kids had worse bone density. Interestingly, vitamin D levels did not correlate at all with the bone density in this particular study. And also liver function correlated. So kids that had a higher INR or a lower albumin indicating potential hepatic insufficiency had worse bone density. And these are just two figures from that paper. This is showing the correlation with the bilirubin. So if the bilirubin is high, the bone density is low, with 0 being a z-score that's like right in the middle of the curve, and below -2 is really abnormal. So the kids with the highest bilirubins had the worst bone density. Vitamin D, this scatter plot is all over the place. There's really no line that you could make here through any of those dots, showing that there's no correlation between vitamin D level and bone density in this study. So what are all the different factors that affect bone health in Alagille syndrome? We know that there's low bone density. They can get these femur fractures like you see here. They can absorb malabsorb fat and calcium, which is important for, of course, building strong bones. Vitamin D deficiency can be a factor that impacts this, as well as vitamin K deficiency, because vitamin K is important for bone mineralization, and then poor intake and malnutrition. I don't have time to talk about it right now, but we've done some interesting mouse studies looking at the role of JAGD1 in bone development, and we found that it's important and essential for not only bone development, but also fracture healing. And we wondered whether it's not just all of these nutritional things, but is the bone structure actually abnormal in Alagille syndrome as a result of the variance in JAG1? So we did a small pilot study, and what we wanted to do was look at the bones in a different way. So this machine that you see over here is called a peripheral quantitative CT scan, PQCT, and it looks at the bone. It doesn't just measure the density of the bone, but it can actually characterize the bone trabeculae, which are the little bits in the middle, and also the cortex, which is the strong part, the circumferential part of the bone that really gives the bone its strength. So we can really look under a microscope almost at the bone and look at it in a different way. So we did this in collaboration with Babette Zemmel at CHOP, who is an expert in bone biology and these types of ways of looking at the bone. Joe Kindler ended up pulling this paper together for us. He was a postdoc with Babette and really did an awesome job. This paper just came out in Bone like a month or two ago. So the pilot was small. We did it in 10 children with Alagille syndrome, aged 12 years. 9 of the kids ended up being female, and the mean bilirubin was 3.3, so not particularly cholestatic. We did DEXAs, which I won't talk about that data right now, but we also did PQCTs in everybody. And we also have this really special machine at CHOP called the high resolution PQCT. And we did that as well to really look at the bones carefully. And I'll just show you a couple of figures from this paper. And these are, hard to make sense of, but basically this is looking at the trabecular bone defects. And what we see from this is that the bone mineral density and content are low, and the trabeculae, which are the little spicules of bone kind of in the center, they're not as thick, there are not as many of them, and they're spaced farther apart. So if you could imagine, it just means that the bone is not as dense as a bone would be expected to be. And then when we look at the cortex, which is the outer part of the bone, again, the bone mineral content is lower, the area is lower. So this is kind of looking at the z-scores. This dotted line is what would be considered like average. All of these are below average. And then the only thing that's above average is the circumference of the inner part of the cortex, which means that the bone itself is thinner. So we definitely did find some deficits that were sort of unique in these patients with Alagille syndrome. Of course, it's a very small study, and to some extent, these were correlated with the patients being smaller in size. We also correlated with biochemical markers of cholestasis, and we found some correlations there. So we found that even in these 10 patients, the skeletal manifestations were widely variable. But what we think this pilot study shows is the need for additional studies to characterize structural abnormalities in Alagille syndrome bones. And this may be, we wonder whether it could be contributing to fracture risk in these patients. I just wanted to show one figure from this other paper that came out a few years ago now. This is a collaboration that we had that was very productive with Kurt Hankinson, who is a vet PhD bone biologist who's now at University of Michigan, but he used to be at Penn. And we got to know Kurt and did a lot of mouse work with him, looking at the role of JAG1. In collaboration with Kurt, his lab did this study where they had a model in the mouse of a fracture, and they basically made a little defect in the skull of the mouse. And this is sort of the untreated mouse. This is the defect. And then they tried different treatments. And what you want to see is for bone to start filling in this hole, basically. So they looked over time to see, how quickly and how well these defects would heal. And what they did was they actually delivered JAG1 to the bone. So they can conjugate the JAG1 to like a scaffold or a material, and then they put it right on this little defect on the mouse skull. And they could see that in the untreated mouse, if that's a 1, the JAG1 treated mouse, it was almost twice as much bone formed in that animal. And then the other thing that was important to know is that the bone mineral content was higher, and there was more bone volume in the mice that were treated with the JAG1. So this is an area we've been interested in for a while. It's very translational to think about whether delivering JAG1 to a fracture site could actually improve bone healing. And I think this is something that could be important, not just for patients with Alagille syndrome, but perhaps in the wider population of bone biology. And then finally, I just wanted to spend a minute talking about hyperlipidemia and xanthomas, studies of lipid composition. So there are a number of studies on this that have been done, but I think there's room for more investigation in this area. So we know that patients with Alagille syndrome have very high cholesterols at times, sometimes in the thousands. They can be pretty alarming numbers. But the lipoproteins, or the proteins that are bound to that cholesterol, are different in Alagille syndrome compared to other patients who have similar cholesterol levels. And we don't really understand why that is. And that's something we'd like to understand better. We'd like to understand why patients get xanthomas, what's in the xanthomas, how do they form, how do they get better. This is another paper that came out actually in 2005, but hasn't really been followed up, from a Japanese group. And they were looking at the risk of atherosclerosis, or vascular disease in Alagille syndrome, and PFIC, another progressive cholestatic disorder. And both patient populations had high cholesterol, but when they looked at the carotid arteries, there was increased thickness of the artery and also stiffness of the artery in the PFIC group, but not in Alagille syndrome. So it seems that there's something in the proteins that are binding this cholesterol in Alagille syndrome that's protective against coronary or vascular disease associated with high cholesterol, but we don't know what those factors are, and I think that's something that would be very interesting to look at more. This is something that Dr. Piccoli and I have thought about quite a bit, and Dr. Kamath is interested in as well. There are some really cool techniques for looking at lipids, lipid populations, along with all the other omics that we hear about now. There's also lipidomics and metabolomics that can be used to characterize these lipids in the serum or plasma. That's something we could think about doing in some of the samples that we have stored away. And there's also a lot of interest in statin drugs, which can bring the cholesterol down, but we know that they can also sometimes make xanthomas better pretty well, that they work pretty well for that. And there's also some emerging information that statins may have a direct effect on improving liver disease. So this is something that we're very interested in studying, and maybe something that we'll hear more about in the next couple of years. So that was just a really quick overview. Like to acknowledge all the people who helped work on all of these projects, NIH and IDDK, the Children Network, the BSEC Liver Center, and of course all of our colleagues and collaborators at CHOP and elsewhere.
That's great. Dr. Loomes, I know we need to get to the family presentation, but I had one quick question. On the slide where you were adding the JAG1 to the skull fracture in the mouse, what was the elapsed time there?
That is a good question. You know, I'd have to look at the paper to know for sure, but I'd say it was probably like maybe a week or two.
Okay.
The mouse would, you know, stays alive through that, and they let the fracture heal for a period of time, and then they kind of harvest the samples. Yep.
Okay.
Thank you so much, Dr. Loomes, for shining a light on this area. We definitely have learned through the surveys that, you know, as you've indicated, this is an area that really needs attention, you know, research-wise, and we thank you so much for bringing this information to the forefront. I'd like to introduce, thank you for coming. I'd like to introduce Stephanie Perry. She's going to do our family presentation on nutrition.
Hi, everybody. I'm Stephanie Perry. I live in Colorado Springs, Colorado. My son, Bryce, has confirmed Alagille syndrome and is a liver transplant recipient. And we are associated with Children's Hospital of Colorado, that's based out of Aurora, which is by Denver, because I know everyone knows where Colorado is located. And then, yeah, so we have definitely dealt with nutrition for the last 3 years, especially before transplant. That was a huge issue in our lives and a huge stressor. So I was kind of sitting down and thinking last night of, you know, what I would share with like someone new to this whole journey, things like that. And some of the things that I would say are the biggest issues with nutrition is definitely the vomiting. Everything in our house was always just covered in vomit. And I don't know if anyone has smelled the progestin, but it's horrendous. And then whenever it comes back up, it's even worse. So that between the Aquadex, which Bryce was on because of his low vitamin levels, Aquadex is bright orange and just stains everything. So all of his baby clothes are pretty much covered in orange. One of the biggest concerns with that is that since the feeding and, you know, constantly having to put formula in them and things, it causes such a traumatic experience for parents and for kiddos, which then makes it very difficult to work on that skill. I know I was very resistant. My son Bryce was in some feeding therapy and stuff, and I'm like, it was just exhausting. It was constantly having to count the calories, and then the calories come right back up. And Bryce was extremely small. I would say even almost for Alagilles. He had in utero growth restrictions. So when he was born, he was even small. He was only 3 pounds at birth. So we were behind the curve, and then ended up, of course, with the Alagille diagnosis, which put us even more behind the curve. At about 6 months or so, we moved on to the NG tube, and that only lasted about a month. He did make some nice growth with that, but at that point, we were also having the discussion of a liver transplant. So his team on his chart, if he had continued growing with the NG tube, he wouldn't have gotten onto the chart until he was 14 months old. And one of the biggest success rates or whatever, things that can impact successful transplant is decent weight and being at a healthy stage. So for Bryce, he wasn't going to make that growth and like before he needed that transplant. And so it was kind of juggling those two very important pieces back and forth. So for him specifically, his team moved forward with a Broviac that I think I'd mentioned earlier. And that's it's TPN and lipids, so it's actually intravenous feedings that get put into basically near the heart. So it completely bypasses your stomach and your intestines and everything else. And he was able to gain 5 pounds in 3 months, which put him in a much better place for transplant. And then he was able to have a successful transplant. One of the other really challenging things is trying to explain this whole nutritional concept to family and friends. My grandma would always be like, I don't understand, if he's hungry, he should eat. Like, doesn't he feel hunger? And I was like, I don't think he does. I think that that whole developmental system of, you know, babies, they cry, they are hungry, they get fed, they feel better, and it kind of moves on. Bryce never experienced that. He never had that healthy relationship with feeding, which then limits his ability to know when he's hungry. And that's even something now that we, 2 years post-transplant, that we still deal with. He will get hangry, more so than a typical 3-year-old. And we're like, you're hungry, dude. Like, you need to eat some food. Eat, you'll feel better. And I think that there's just like a biological piece that kind of gets missed with some of these kids with Alagille syndrome whenever they do have such impacting nutritional issues at such an early age. One of the biggest things that I can't stress enough to families is don't be afraid of the NG tube or the G tube or the Broviac or any of these crazy contraptions that doctors, you know, are using to put some weight on our kiddos. It was the Broviac, especially for us, which is, I think, probably one of the most extreme sides of nutritional implementation, but it was like just a whole weight was lifted off of our shoulders. We didn't have to count every single calorie. He wasn't vomiting it all day, every day, things like that. And feeding may look different, and it may be different than what you expected going into having a child and even having a child with a rare disease, but that's okay. And it's what works for your family and what helps you guys get through that very difficult period. So for us, the NG tube, we worked on it and we were kind of getting there, but like I said, he just wasn't making as much progress, so we had to move to the next step. But I know a lot of friends who have their kiddos have G tubes and things like that, and like I said, it may not look typical, it may not look like what everybody else is doing, but it can be so freeing, and that alone is worth it tenfold. The other thing that I wanted to kind of just mention really, really quickly is some of, I think, the long-lasting impact of that nutritional piece. With infants, especially developmental milestones for that oral motor piece and even sensory integration within feeding, that follows a very typical path. And for a lot of our kiddos, due to all the medical intervention that they're receiving or being orally traumatized, whether intubation or the NG tube or vomiting all the time, any of that kind of stuff, that can be very traumatizing for kiddos. And it can disrupt all of those typical pathways. And that can be very difficult to recreate at a later stage. For Bryce, he has always liked crunchy foods. He never did the baby food stage. Even now, I know some of you guys may have seen a couple weeks ago, I don't know, maybe a month ago, maybe 6 months ago with this COVID time, but I had posted a video on Facebook of Bryce eating grapes, like fresh grapes, and that was huge. Like, I was in tears, and I still like hold on to that. He hasn't had grapes since, and you won't put them anywhere near his mouth, but I held on to that one incredible experience that we had, and I know that we can get there again. So yeah, don't take it in. It's tough, but you guys will get through this, and they will get through this, and then you'll be in another different tough stage. So there's always that. So that's my spiel.
Thank you, Stephanie. How do you approach coping with the nutritional challenges, I guess staying sane with the process, and also understanding at the end of the day, a new day starts and you start fresh? How do you, rejuvenate yourself emotionally? Because this nutrition piece is a tremendous emotional weight, just as Kathy had pointed out, the pressure to get those calories in. And now when they transition from infancy to toddlerhood and beyond, trying to now get them to eat solids and even just, feel them, put them in their mouth, taste it. How do you approach the emotional aspect of sanity around this?
I'd say it's a combination of stuff. Especially in the early days, there were tons of tears on my part. It's hard. It's so hard having your kiddo be so small. You know that they need to gain weight. And then for us, we knew that transplant was becoming a very real possibility. And, of course, we want to do everything that we possibly could to set Bryce up to be as successful in that transplant. So there's definitely a lot of crying, which I think is completely okay and reasonable. I reached out to my community, especially my one go-to kind of Alagille's mom friend at the time was Julia, and she still is. But that feeding piece, just hearing from other people that this can be how it is, and it's kind of almost typical for our kiddos to experience a lot of that. That really helped to know kind of the why behind it. It wasn't because I wasn't holding his bottle correctly, or it wasn't because I wasn't breastfeeding him right. That wasn't the reason. It was really, his little body that just wasn't working correctly. In addition to that, I would say, we did get Bryce involved with PT and then OT at a pretty young age. He was about 8 months old. And so early intervention is definitely, I think, a huge, sometimes untapped resource for these little ones. And then brainstorming, okay, how can we make this work for our family? For Bryce, even now, he doesn't do great with his meds. So we would put his meds in a little baby bottle nipple, and we would spray them in there, and he would suck them down. And so my husband and I brainstormed, and we were like, okay, what is the most difficult aspect of our day? And even if we could make little changes that got a little bit better, that really kind of helped us. Okay, now we can take on the next thing, and now we can take on the next thing.
Thank you so much. As with this being a virtual roundtable, what we want to do is take just a few minutes to brainstorm or talk about how we can approach better education in nutrition, better education for families, and any thoughts or responses to Stephanie at all?
Stephanie, I think you brought up a really important piece of the puzzle that I didn't touch on in my talk, and that a lot of kids who have feeding issues early on, and even like vomiting and reflux issues and things like that they can develop oral aversions and have a lot of texture issues with feeding, and that can take a long time to get better, and that's something we have to help support families through. That is quite common, and there are a lot of good feeding teams out there, but again, it's like a stressful experience to deal with that, and some of those interventions are pretty intensive in terms of the time that's required, daily visits and things like that, and that's just a lot to expect. So it's hard for people to put that into their daily lives and realistically do that sort of thing. And it takes a long time sometimes to get better.
It does. It does. And I think, each family has to kind of, at the end of the day, find what works best for them. Bryce just recently had his 3-year-old checkup, and overall he's doing phenomenally well, but feeding is still an issue for us. He doesn't have an NG tube and he doesn't have a G tube, but he relies heavily on, we use Kate Farms formula, and we know that's where he's getting a whole lot of his nutrition. He still very, very much so prefers crunchy foods, and or he lives on French fries and bacon, and I'm okay with that. Looking back at where he came from, I'm like, you know what? He's 3, he's been through a transplant, and we've been through all this. I'm going to give it to him that it's okay that this is still hard. Like, we all deserve to kind of be able to carry our own baggage, I guess. And so we respect that. We still work with him whenever we can. But I think it's, finding that sweet spot of, and I'm all about the therapies and, supporting them and stuff like that. And I know what we need to do. And like I said, we do work on it, but I also respect that, that this is his thing and that he'll get there.
Mm-hmm. Yep. He will get there eventually. And I think, like you say, it's important not to try and make it a big battle, because then feeding becomes really not fun for the kids. And
yes, or for the parents.
Or for the parents. And you don't want them to just not associate food with positive feelings.
Yes. So yeah, I mean, for his birthday, we made him a cake that he blew out the candles on, and then he had a pile of French fries, and that was
French fries.
And I'm like, whatever. Like my mom got him a McDonald's gift card, and he was ecstatic because he gets more French fries. So it's part of who he is, and we'll get there with everything else.
Thank you, Dr. Piccoli, for coming on to talk about bone pain. Just really quickly, I did want to tell everyone, bone pain, joint pain, unexplained pain were very hot topics on our surveys. And super quickly, on the top 12 symptoms that affect the ALGS warrior the most, the number 3 symptom was bone pain. So this is something that we are really excited to kind of dive into, and we know how important it is. So Dr. Piccoli, I am going to turn it over to you. Thank you so much. And after Dr. Piccoli, we will have 2 presentations, family presentations. Shami will come on, and then also Hannah Craig will come on. So thank you, David.
Okay, great. Thank you, Cher, Roberta. I have to say I was totally struck when first I got the notice that my topic would be bone pain. I said, because there's very little about it. And then when I saw the survey, I was really very impressed at how important it is in the lives of patients and families. And it really got me to think about some things. Had some good talks with Kathy, and I think this will be the start of an odyssey into bone disease, joint symptoms, and musculoskeletal disease. I am hoping if somebody can shake their head that you're seeing my screen. Okay, good. All right. No conflicts. So in thinking about this and thinking about it in terms of patients and degenerative disease and genetic disease, we talk a lot about bone pain, but we're really thinking about bones, joints, the muscles that connect them, the effect of and the limitations on activity, and then a number of other factors that are involved here, including things like nutrition. And I think that it probably could not be more complex for almost any disease than it is in Alagille syndrome. So I want to try to go through some thoughts about the different areas that are involved, give you a little bit of insight into what we have seen, and some ideas on how to deal with this. So the first, and this goes back to sort of the gene discovery time, the first thing early on after Jagged was described, but even by Alagille back in the late 60s, we knew that there were certain bony features that mattered in Alagille syndrome that were not present in Vic or biliary atresia. And then there were other disorders, other things that were very specifically Alagille syndrome. So one example of that would be the shape of the skull and the jaw and the so-called triangular facies and the frontal bossing, the prominence of the forehead seen in many people. And then the progression over time from, in many people, a very small jaw to a much more prominent jaw. Alagille recognized early on the spine abnormalities, the butterfly vertebrae. And somewhat interestingly, those butterfly vertebrae also happen in other genetic disorders. So it's not that that is specific in any way to Alagille syndrome, but not common in the general population. There was a talk with Kathy about final adult height, and I think Ruben will talk a little bit later on. One of the really big studies about that early on, when we, for a long time we didn't really transplant many Alagille patients, was that many patients do not grow to what you would expect to be their full genetic height after transplant. And they had a big paper out of UCLA that showed that. But part of that is due to the fact that the growth and the remodeling of spine and long bones is probably abnormal. We also see things like shortened finger bones. The shape of the chest in a number of people is a little bit more barrel-shaped. Not that that's specific for Alagille, but it's not uncommon. The angulation of the femur, and when you watch a number of children run, particularly in the early years, you see those abnormalities. There is a defect called congenital radio-ulnar synostosis, which you can see here. You end up basically getting one bone instead of two. They're connected at this point, and these are children who can't flip their hand over. And that is, we've seen that now in a number of patients with Alagille syndrome. I think the most important single clue about the whole notch pathway is that there are a bunch of diseases in that pathway, of which Alagille is most common and most important. But in the ones that have spondylocostal dysostosis, and there are a number of those, they really have tremendous bony abnormalities that are genetically encoded. So this whole pathway is active in bone development and in bone health and remodeling for the rest of your life. And then this is a one slide from a paper that Kathy Loomes published over 20 years ago, just showing, this was right in the beginning of understanding things, just a year or two after the gene was identified, showing that this gene is actually expressed in the embryology of bone development in areas that very much correlate with what happens with patients later on in life. So there's a genetic component here that is absolutely not relevant in biliary atresia or the Fick diseases, but it makes what we're doing in Alagille syndrome markedly more complicated. This, of course, over here is a butterfly vertebrae in between two normal vertebrae. But the bones can actually be abnormal in a number of other ways, and Kathy talked about some of these. Mineralization, so here is a spine, and you see a butterfly vertebrae, but the other thing that's striking is there's very little bone mineral in this spine, and it is the calcium and the calcium salts that are the connection that makes bone stronger than tendons or muscles. And vitamin D is a key part of that, and vitamin D not just in infancy but throughout life. Malnutrition makes bad bones. Low albumin is correlated with bad bones. Poor protein intake, and so certainly many of our children have unique intake early on in life, spicy carbohydrates and things like that, and some have a protein aversion that has a negative effect. Sorry. Protein catabolism. So when you're undernourished, you eat your own body protein when you're stressed. For patients who are not as active, weight bearing is one of the major things that causes bone accretion or bone building. And so when people aren't feeling good, they don't walk as much, they don't put as much weight on their spine, their hips, and their femurs. And so the bones don't get as strong as they do with physical activity. But also decreased muscle mass has an effect. when you have low bone density, you can have vertebral collapse, which is a general problem in osteoporosis in adults who have low bone density without Alagille syndrome, just in the general population. And then we have this issue of long bone fractures and what is that about? So a number of non-genetic or not directly genetic ways that bones can be abnormal. So I did want to give a shout out to one of the very early surveys that we did with the Alliance. And we did it for a totally different reason. We were working on genetics and phenotypes and variability and so on. But there was one little question in this growth study that had one checkbox, history of fractures. And we were totally struck by the number of people who checked that box. And, you know, one by one with patients, you don't necessarily think about it. But when you have a large data set, Tina Bales led this and looked at this and said, you know, we need to call these people back. And the surveys had, you know, the right to communicate with the families and so on. And it turned out that not only were there a large number of fractures, but there was a very unusual distribution of the fractures. Little kids break bones all the time, but they're usually the kind of bones that kids break: wrist, ankle, hand, you know, and this was very different. So the families were contacted, and Tina and the group set up a study. And here's what they saw, just even on the first results, was that leg and leg, so the tibia and the fibula, the smaller bones of the lower leg, and then the massive bone of the upper leg, these breaks were really strikingly common. And when they compared that to biliary atresia or to cystic fibrosis or other things, these are the bones that like kids are supposed to break, but not these bones. So it made us really think, is there, in addition to all those other things I talked about, are there other things about the bones in Alagille syndrome that are different? And Kathy gave the results of one of our newest studies, and I won't belabor that, but the answer very definitely is yes. So what are other ways that bones can be abnormal, and what are other ways to look at it? So we do a DEXA scan on pretty much everyone that we follow longitudinally, and we've published a couple of papers on that. I'm going to show you some pictures of the cortical bone, which is the sleeve. It's like the pipe edges of bones, and then the cancellous bone, the wires and the cables in between that sleeve that sort of make up kind of what some people might say is the marrow of a bone. But there's a very significant bony structure in there. And then people can have things like avascular necrosis, which is a hip disorder, happens in other diseases, certainly, but can really be a significant problem for Alagille. So this is a DEXA. This is a DEXA machine right here. It's a quick, easy test. This is our person who's done our DEXAs for a long time. And this is a picture of a DEXA scan. And you basically, you have your feet are taped together with a little piece of tape so that your bones show up. And then the technician or the nurse draws perimeters around bones and hips and other areas. And it gives you a reading of how much bone you have and how dense it is. And in Alagille syndrome, each of those numbers is commonly much lower. You also can get measures of lean body mass and body fat, which for those of us who occasionally get a DEXA at an older age, sometimes a little motivating. But it really helps with understanding patient composition and patient disease. And then, as Kathy said, we have some other machinery. We have a very big bone research and bone study center for a lot of diseases that are different than and more common than Alagille syndrome. But over here, I don't know if you can see my arrow as easily. Basically, the bone has an inner area and an outer area, and it's the length, the thickness, the angulation, and the amount of connection that makes strong, long bones. And so, as she said with the Gindler study, we were looking at this by a technique totally different from DEXA. So DEXA shoots a beam all the way through the bone, and you can't tell regional variation. But this tells the regional variation and gives us a very good idea about why the bones are not as strong as other bones might be. So this is an area where we're still learning and still doing things. So then there are other issues and problems around bone pain, ligament pain, joint pain. So here is a toddler who has very significant xanthomas. And you can see even at the level of, getting her into shoes that allow her to walk, you can see that the shoes that she came down in just did not fit. And so she would not weight bear, as well as has xanthomas, on the soles of her feet, probably has them, definitely has them in the, like the Achilles tendon that is supporting her, foot and helping her to walk. And so these are also very painful, may not exactly be bone, but maybe more subcutaneous tissue, tendons, and then the things that we do around them, including the fact that many xanthomas result from traumatic areas, but many of them cause trauma, or trauma makes them significantly worse. So, a minor bump on an elbow that's covered in xanthomas can be incredibly painful, whether it's actually the bone or the joint is maybe not quite so clear. And then there are other things that we have to consider. And I think one of the most important ones is rickets. So rickets is, for the most part, a low vitamin D status where the bones become undermineralized, and so they become soft. And you can sort of Google pictures of people who have this incredible bow-leggedness, where the bones then are bowed outwards, and weight bearing is very abnormal. It puts a stress on the bones. Not only are the bones weak, but it puts a stress and an angulated stress on the bones that is very difficult to deal with. And some parts of rickets you can improve by giving vitamin D at an early age. It's a reason why we are a little bit crazy about vitamin D. But there clearly are some patients who need to have like a bone operation to change the angle of the bone. And one of the other things that we'll talk a little bit about is if bones are supposed to be straight up and down like this, and if they're bowed and the one bone is like this and the other bone is like this, what happens to the joint is that what should be a union, I don't know if you can see my hands well, like this, then suddenly becomes a union like this. And so the cartilage and the joint space are tremendously stressed, because when the bone does this through the joint, it's not touching correctly, and it's not doing what it should do. And so you have an added factor that then limits mobility and other things, and it's a vicious circle, but it also destroys the joint. So then we talk a lot about bone pain, but a lot of bone pain is actually joint pain. And so we just gave an example of the angulation of the bones, some of which might be genetic, some of it might be acquired, and cartilage erosion, which is a problem of degenerative arthritis in all people who don't have Alagille syndrome as well. But then we've seen a couple of patients with swollen joints that are either due to microfractures around the joint space or inflammation that acts like rheumatoid arthritis. Sometimes medications can cause problems in the joints. But also we've seen a number of patients, small number, but way more than we would see normally in kids, of uric acid crystals and gout in joints. So all of these things cause abnormalities in the fluid, which basically either hurt a lot or actually can hurt and destroy the joint space. And then of course you can have damage to ligaments that are either in the joint, like in the knee, or around the joints, like in the back, or in the discs between the bones. And so back, shoulder, and knees are susceptible areas for us for those kinds of damage, made worse by having abnormal bones or less strong muscle. And then we have to remember that there are muscular causes of joint and back pain. And there are many people, for instance, in adults, who believe that they have back pain that's due to either the bone in the back, the vertebral body, or the disc, but it's actually the muscle that is the problem. Nonetheless, extraordinary pain and incapacitation. But some of the muscle issues are either overuse or misuse or underuse of muscles, and sometimes it's a muscle balance issue. I mean, for instance, for many people with back pain, by strengthening the abdominal muscles, you can improve the back pain significantly. Patients with Alagille syndrome, though, definitely have poor muscle mass, and that is out of proportion to what you might see on a growth curve. So as Kathy was talking about, you know, some children who don't tolerate stomach distension because they have a spleen on one side, they have a liver on the other side, they're both big. Those organs also weigh significant amounts. And so the growth curve may say we're doing pretty well, but when you look at the buttocks or you look at the thighs, they're kind of stick-like, and you know that you're not putting good nutrition out to the periphery. And so those have problems. And then those kinds of problems lead to muscle damage, tears, and strains. So a whole host of different things. There isn't one overarching single problem of bones the way there is in some other diseases. There's a disadvantage at the level of the musculoskeletal system diffusely in many different areas for many different reasons. Now, in general, and certainly in specific in Alagille syndrome, these are really hard problems to deal with. And I'm very impressed that the rheumatologists have a great overarching view. And over the years, they've made diagnoses and recommendations that would not have really been in my wheelhouse. So we really appreciate the rheumatologists, and certainly when you have things like gout or rheumatoid arthritis or inflammatory effusions, they're the best. We use our orthopedic surgeons for that elbow fusion problem. An orthopedic surgeon really has to take the bones apart at the elbow, separate them, and so on. It's an extraordinary sort of operation. They're also our go-to for rickets, and also for scoliosis, spine problems. I think for a long time, we felt that the butterfly vertebrae lesion itself was of no consequence. I think now we're thinking maybe that's a little bit over-optimistic. And certainly some patients do have, you know, significant scoliosis and so on. Sports medicine specialists can do some incredible things, and chiropractors as well. There's a role for them in certain abnormalities. They do have to remember that the entire bone mineralization in Alagille syndrome might be much less, and some of the things that might be tolerated by normal bones might not be tolerated in Alagille syndrome. I think the world of physical therapy and occupational therapy, they are really spectacular, and a good group that really pays attention to you can get you through a lot of different acquired problems and probably some of the congenital problems as well. There are now a lot of exercise specialists who can help you get back to full activity. And sometimes we need to use pain control specialists because weight-bearing bones that are not normal can really, really hurt. And you know, the correct use of multimodal therapy, it's not all narcotics, but clearly there are some times where narcotics are necessary. The fact that there are so many different people who focus on so many different things is kind of like a sign of and a guarantee of there's no one solution for any problem. And sometimes you do need to go through different groups to see what they can do, you know, and what they can offer to help to get you to suffer less and be more functional. So, you know, I think in summary, there are a huge number of abnormalities, and it most matters in your family, what's the specific issue that we're dealing with. There are many spine abnormalities. They seem to have less consequential effect in the first 15 or 20 years of life. There is no doubt, whether you were severely affected or less severely affected, that starting third, fourth, fifth decade, they have more and more effect because they're added to the effects of chronic use, old age, other, you know, the stresses and strains of life. But the vertebral bodies, the bone, the disc, we don't have any good idea about neurologic disease with the spine, but it's definitely a possibility. And then the bone abnormalities of shape, length, angulation, mineralization. You know, we really, really try to push the vitamin D levels high all the time. Fascinatingly, interestingly, there's some data that says that vitamin D decreases risk of COVID. Not that that's going to be the motivation forever, but it's certainly made the news now. And then jagged and notch clearly are involved in remodeling. So as our bones grow, they change, and jagged and notch are involved in the balance of those changes, as well as in the healing of bones. And there are a number of people who had major fractures of their long bones, like their femur, the big bone in the upper leg, that just took forever to heal. And probably now, as we look at it, that healing is not right. So joints stressed by angulation, different diseases that are seen at what we believe is probably an increased frequency in Alagille syndrome in terms of inflammation and gout, as well as destruction, ligamentous stresses. We don't really know much about cartilage. There was just a paper that came out that suggested that some people were able to grow cartilage stem cells that they might be able to inject into a joint. Maybe, but it gives you an idea that the joints are living and remodeling things, and those joints, the joint cartilage needs to be slippery and adequate for a joint to be able to slide with the right amount of the right kind of fluid between them. Tendons, ligaments, skin from the xanthomas, and muscles all may be involved. So there's not a single problem and there's not a single solution, but I think this is kind of an overview of you know, the bigger picture of what are the different things that contribute to musculoskeletal health and musculoskeletal symptoms. And while I ask for questions, I'm going to put in a plug for Philadelphia.
Thank you so much, Dr. Piccoli. What we see time and time again in the support groups, especially with Alagille adults, is the continual misunderstanding of where the pain, whether it be bone pain, muscular, xanthoma related. A lot of times our adults are reporting that they're being treated like drug seekers, that the pain management is just not there, that when they have severe pain, they go into, let's say, an ER to get it addressed, and they're basically turned away and sent home with Tylenol or something over the counter. And it gets to a point where many of the adults just throw their hands up and they give up. And I think one of the main objectives of this session is to really come up with some management tools as part of, an adult plan of care as to how to get this in the plan of care early on, make sure that there's early interventions for pain management and care as well. Even with some children, we're seeing pain, the leg pain, surrounding breaks or just in general. What are your thoughts on how an adult would address going into an ER and explaining any kind of pain, and what do you foresee the future holding with potential tools that we could use to circumvent this issue at the door?
Yeah, so it's a really, really good question. And, I think that it's very unfortunate because we've gone in a big and really crazy circle around narcotics. So, we used to have mediocre narcotics when I was out of the 60s. And they weren't that lovely, and they weren't easy to get. And but they were a mainstay of pain control at the time. And then we had this explosion, and you could read about it in the papers or now the lawsuits, of having these more designer pain medications that were originally promoted by and even branded by the companies as being non-addictive. And then it turns out they're tremendously addictive, but tremendously expensive. And so people, and not a small number of people, more people than die in auto accidents, becoming accidentally addicted, and then flipping to street meds. A tremendous amount of the hepatitis C came from people using IV, or subcutaneous needle injection meds. And then instead of sort of understanding this, and you could get on the web and you'd have somebody, willing to write you, 100 oxys for $50. They don't ever have to see you, So everything kind of like just went in a terrible direction. And so now we've reacted to the point where everybody who needs a narcotic is an addict. And even more complicated. So I'm pediatric, I'm in Pennsylvania. Our state and many states now have registries, and every single time I write a narcotic, I have to query the state database. I have to go through this whole sequence. And a lot of times for me, I'm dealing with a 6-year-old kid who can't possibly get into the medicine cabinet. But we've gone to that point where I think there's a paranoia about prescribers thinking that everybody who wants these meds wants them because they're misusing them. So it's very hard to get significant pain control from emergency rooms anymore for exactly that reason. I think you go to the people that I had listed on that other slide. These are people who understand pain control and who you can have a relationship with, and they can talk about, we want to use multimodal pain control. We don't want to just use narcotics. I mean, most people don't want to get a bunch of narcotics and just sleep all day and do nothing. You know, they need to be functional, they need to get better. So I think those people, you'll never be able to control all of the thought of all of the people about all of these things, but you need to have expertise and access. And so I would say, you know, a rheumatologist knows exactly what these are for, knows the risks, is going to help you employ them in your life for good and not let them become a tool for the slippery slope. And there are so many other things. I mean, we have an integrative health center here. We do acupuncture for pain. We do hypnosis. We do mindfulness. We, you know, motivational, you know, all these different things, as well as there are a whole bunch of medicines that are not narcotic that can help, you know. So, and some of those are not so, like some, you have to really, that person has to pay attention to you. If your bones are bad and you have inflammation, you don't really want to go on steroids because that is just going to make your bones much worse. If you have a lot of portal hypertension, you don't want aspirin, and you might not want Advil and those kind of medicines. You know, if your platelet count is really low, you know, so it really, it I think takes a relationship. The internists, the adult physicians are pretty willing to work with people when they know that they have real disease. The problem in an emergency room, and particularly if they can't see your medical record from somewhere, is they don't know you from Adam. And, you know, maybe they'll give you 3 pills or something, but they're not likely to make an investment in your long-term success, because that's not what emergency rooms do. And now they're just more and more anxious and paranoid than they've ever been before. I don't know if that really helps, but.
Thank you so much. Now, tomorrow we'll have a deeper dive on bone pain from 9:15 to 9:45. And I'd like to introduce the first family presentation on bone pain, Shammy.
Hi, can you hear me? Am I audible? Okay. So I'm Shammy. I'm on the board of the Alagille Syndrome Alliance, and I've been here for 3 years. I started off as a junior board member and kind of got the lay of the land. I wanted to talk to you about a person that I live with. It's taken me time to understand this person and appreciate and respect and find ways to work with this person. She's like a shadow. She kind of just appears and disappears as and when she feels the need to. Very little consideration for whether I actually want her around or not. Let's call this person Ah. So my recollection with Ah was her kind of entering my life at the age of 12. My earliest recollection of her was when I was in school, just kind of walking around doing my thing. And she just started appearing in my lower back. As I grew older, I started noticing her in other parts of my body. I started noticing her in my shins, in my fingers, especially the last 2. Trying to do a show and tell here. I noticed her in my knees when they felt like swollen, soggy bags. I noticed her on my shoulders. And I noticed that she would just appear, you know, and dictate everything from what I wore to what I ate to what I would do, what I would avoid doing, the places I would visit, the people that I would hang out with. She would even affect my mood. I cannot tell you the number of times that I have snapped at a friend, alienated myself from my family, felt like I need to curl up in a ball and bawl my eyes out simply because I have no control of the intensity and the time and situation in which she decided to turn up. Before I tell you who or what is, though I'm sure you kind of figured it out by now, I wanted to thank the Alagille Syndrome Alliance. for letting me share this complicated relationship that I have, and for letting me introduce you to this person who has now become my friend. She is my daily companion. She is my daily source of anxiety. And off late, as I've gotten older, she's become my check and balance. She's become my way of stepping back and questioning myself on whether I had taken care of myself that week or not. Is my body pain. I'm sure you guessed it by now. She is the feeling of fire in some parts of my body. She is the feeling of stiffness in other parts. She's the feeling of absolute heaviness that radiates outward from a central point and causes the surrounding area to feel numb, spongy, and sometimes dead. Is the pain that I experience on a daily basis. I used to hate and I used to resent her. The way I have dealt with is not just a reflection of myself and my personal abilities, but also the complete lack of guidance and interest from the doctors that I've had to deal with in the last 28 years of my life, and from the people around me. But this is not just my story. This is a story of anyone who's had an And if you go through the rare disease community and the Alagille syndrome pages and groups, you'll see that everyone at some point has had this You'll also know that all of these people that have gone through an has been told at some point or the other to get out of the house more, to be more active, to try yoga and stretching, to avoid certain clothes, to avoid certain situations, certain forms of transport, to limit their life, but to also get their vitamin D and B and B12 checked, because that's probably what's causing the flares to come up. If you also speak to anyone within the ALGS fraternity, they will tell you how their heating pad has become their best friend and their only source of comfort when rears her ugly head. They will tell you that they have tried every pain balm, every ointment, anything that can be ingested, inhaled, or lathered on you. They've tried it, and those things are band-aids at best. They will also tell you how they've given up, how they have completely surrendered themselves to the variability in schedules, the absolute randomness of their individual behaviors when shows up. On any given day, I don't know at what time my body pain will come up and in which part and what frame of mind I am in to deal with Am I going to deal with it well? Am I going to deal with it badly? And who's going to come in the line of fire when I'm dealing with her? Which relationship am I going to destroy? Which situation am I going to eject myself from just to manage her symptoms better? I can go on and on about how affects me physically, but I can also tell you that she's changed the way I think. Initially, she made me an angry, cussed, causatic person who was just upset because I was unable to deal with her and corral her in a way that was constructive. But over time, she's taught me patience. She's taught me that life isn't always just. But most importantly, she's taught me to advocate for myself and for others in my situation. She gave me the strength to speak up about the need to make pain management as much a part of the overall ALGS care from the time we're diagnosed. It's as important as the liver, the kidney, and heart disease. It shouldn't be that in order for a doctor to order x-rays or suggest physio or blood work, that you need to be dying with pain in front of them. It shouldn't be that you are self-medicating or self-regulating the activities that you choose to do and the things that you choose not to do, and for them to believe that you are in pain 24/7, 365 days a year from some part of your body or the other. I have had so many people across the rare disease spectrum tell me that this is the biggest challenge they struggle with, and I have too. I had one patient tell me that for 20 years, her doctor told her she belonged in a psych ward because she was imagining the pain she lived with. And it turned out when a scientific paper was released somewhere in the early 2000s that proved the linkage between chronic pain and her disease, she just felt complete relief. Her disease was multiple sclerosis, by the way. I've had parents from the ALGS community ask me, how do you manage the pain? What do you do? Does it go away? I never have good answers for them. All I have is generic boilerplate statements. You have to be tough. You have to hope that tomorrow will be better. You have to write it out. But what use are those statements when you or me or an ALGS child is struggling to do everyday activities like feed themselves, clothe themselves, play, study, work, dream, aspire? It just, I know the variability that chronic pain causes, and I know what it does to you mentally. That's why in the rare disease fraternity, we have a term, a phrase, good days and bad days, hashtag spoony life, because we're constantly giving spoons to how much we can do and deducting once we've done those activities. We're constantly limiting ourselves in the hope that that will reduce the frequency and intensity of these pain flares. And more than that, we also break our own hearts. We shatter our own dreams, and we tell ourselves that things that normal people aspired, they're not for us. At least that's what I did. I told myself that I will never drive my own car, I will never have my own house, I may never earn enough money to be financially independent and travel the world and read the books that I love. I told myself, I convinced myself that I have to be okay with living with a subpar life, or a subpar life in my eyes. I just needed to lower my expectations and keep my dreams in check so that I was always ready to deal with whenever showed up. And this is the reality of many patients I know. I don't know how long I can view my relationship with with such magnanimity and how long I'll be able to work with her. There may be a point when I just can't and I have to put a complete stop to most things that I'm doing. But I do know this. Until you have learned to respect and work with she can ruin your life, your relationships, and limit your choices. Older warriors had warned me about this. I didn't understand it when they did, but I do now, which is why I'm so glad that the ALGSA has decided to recognize that bone pain is as much a part of ALGS as any other aspect of this complicated, messy disease. Because now, maybe doctors will listen and believe. Maybe scientists would want to research this and speak to patients like us, who can tell you things about when we experience it, why, what did we do before. We're willing. But most importantly, this is for warriors and their families to know that they're not alone, that they're not crazy, that they're not abnormal, that all of us go through this and that we're here for each other. The ALGSA has their back, and that I'm always here to answer your questions. So thank you for letting me share my story. There is hope, and I'm sure of that. And the proof of that is in this year's research roundtable. So thank you.
This is the story of so many Alagille adults. And there just are not clear answers or clear path. Thank you so much, Shami, for that. Hannah, Craig, are you ready? Go ahead.
Can you hear me? Oh, I don't know what I can say after that one. I love you so much, Shami.
I'm sorry, I love you too.
I was like, hold on, like, I'm coming next. Please don't do this to me. So a lot of times, like even through the symposium, itch is one of the huge things that comes to us. But when I saw this on the survey, I was like, oh my goodness, I was kind of excited to see it on here because honestly, like we've actually made some nutritional changes that have completely changed his liver function and itch. So between nutritional and meds, we've actually been able to manage the itch a lot. But pain is one area of our life that is just literally wrecks our life every day. And just like Shami said, it's so almost episodic. You never know when it's going to come. You got 6 months and it's just a terrible 6 months, and then you're doing good for a few months, and then it's like, oh, here you are again. And you just can't predict your day or our life. And, you know, we start making plans to have fun and go out, and then it's just like, we meet again. It is like this friend that you love and you hate, and you just can't get rid of them. They're like a leech to just get away from me. But like right now, we're dealing way more with abdominal pain with no direct cause that we're trying to find out. But about 2 years ago, my son's 9. My name's Hannah Craig, even though they introduced me. My son is Damien. He is 9 years old now. And about 2 years ago, it did start more in the evening and at night. And he just got this intense, like, he has a strong sense of pain management normally. And he just got this huge, intense to tears pain. And it actually was in the middle of his humerus. It was so random, and it lasted for a while. And we tried ice. They, you know, try ice, try heat. They told us to try all kinds of little things. And, you know, it faded away. And we're like, okay, there goes that. A couple days later, you know, it came back and lasted longer. And next thing we know, we're having pain in the mornings and in the afternoons, and it's starting in the middle of his arm, and then he's got it in his femur, and, you know, it goes from left side to right side, and, you know, switches sides, and no rhyme or reason on time of day or where it's at or intensity, and it's intense, it's deep, it keeps him up till 2, 3 in the morning, and then he's supposed to wake up and start school or do whatever. We've changed our life. We homeschool, and even then we do school on the couch some days. I have to give him questions orally versus written, because he's just in pain and he hurts, and his whole life has been changed. And yeah, watching this, there's so many causes of, if there's bone pain, we've had swelling on the knees, and we've had all that too, and we've had joint pain, but we've just had so many random pains, like in the middle of the arm, like it's not growing pains, like we've just had a little bit of everything. And especially being younger, it's like, well, maybe part of this is growing pains, or, you know, like other things. And but we've had a lot of times where we're at, we love our team, and then personally, you only know the information you know. And I cannot discredit his team, because they care so much. But if it's not in their wheelhouse, if that knowledge doesn't exist to them, they can't help, because they don't know it exists. And a lot of times we go to the doctor, and Alagille is associated with the liver and the other things, but it's so multi-systemic. And so just looking at this, you know, slideshow of just how many causes could be of bone pain, like our x-rays, our bones look great. We actually haven't had a lot of fractures. And yet he still is constantly having bone pain in and out. And just that alone, when I go to the doctor, it always feels like, it does feel like a mental health thing. Like, am I a hypochondriac? That's how I'm treated a lot of times. And it's not purposeful. Like, sometimes it comes off as care, but I do feel a lot of times like I'm seen as a hypochondriac. And there have been times where they've wondered if his pain is psychosomatic, or if it's a nerve pain, or like, what else could this pain be? Because they can't explain it, and they don't know what it is. And when you're going just to advocate, like, how do you advocate and navigate if there's so many causes of just bone pain alone, and so many different doctors or PT or OT or chiropractor, or so many places you can go? That alone, to be honest, sounds exhausting. And then we're still dealing with, you know, heart and liver and neurology and so many other things, that it almost seems, how do you navigate that, as if the systems are fighting for priority? Because a lot of times when we see the doctor, we may have a list of things that need to be dealt with, but let's deal with the highest priority thing right now, you know, like weight or liver. If the liver numbers are going up so high, we need to focus on, you know, getting those liver numbers down, or do we do transplant? So we tend to look for what's the highest priority, but sometimes several systems are high priority, and it almost does feel overwhelming and how to navigate it. And like Shami said, distractions and grace are probably the only reasons we've made it this far. When he's in pain, there's nothing we can do. We've tried ice, we've tried heat. He can't take Tylenol or ibuprofen because of where his liver and his kidneys and things are. So more times than not, we just are never given meds, and we don't ask for meds. So distractions and all the YouTube videos and shows and music and anything we can, like you're saying, and meditation and calming things, and, you know, can we relax in the bath, whatever we can do to distract ourselves from what we're dealing with. And it just involves lots of days or nights curled up and snuggling and watching TV or doing music or whatever we can do to get through the day. And just having grace on, it does stink to lower your expectations and to just wake up every morning and just not have any expectations of what your life should look like, what your day should look like, what your child should experience or should not experience. And you really have to just, as a parent and as a person, pretty much throw every expectation you ever had about life out the window and just give yourself grace for what you can do right then in that moment. What you're physically able to do, what you're emotionally able to do, and just really just wrap yourself in grace and love for where you're at right there in the moment. And that's pretty much the only reason we've made it this far. But pain has literally, every day it seems like his pain is just the one area that I can't take away and I can't fix. I don't know how to advocate anymore for. It's just the one thing that just wrecks our life lately.
Thank you so much, Hannah. Cher?
Before we take questions, and I know there will be some, I just wanted to give a little history of how we got here. On the main surveys, those initial surveys, the Measuring What Matters and the adult, there were high percentages of pain that came out of it. And we thought we would see this, but as Dr. Piccoli talked earlier, the surveys have been really eye-opening, even more so than we thought. You know, over half of the adults talk about chronic joint pain, and almost 40% of the kids are having this chronic joint pain. I know I'm going to tell you a lot of numbers here, but I just think they're important, you know, for everyone to know. The highest percentage of the part of the body that's affected is the neck and lumbar area. That's about 70% have pain in that area, and then that's followed by knees and joints in general. And there are about half of the people who responded to the surveys have had the pain for more than 10 years. So it seems like, you know, something that doesn't necessarily just come and go. It does look like it changes over time. And then about 70% also feel it every day, throughout the day. It's like Shami was talking about, there's not a time of day, there's not a specific trigger. Just like Alagille syndrome, how variable Alagille syndrome is, so is this. We did ask if there was anything that triggers the pain, and standing too long, walking too long, sitting too long, cold weather, hot weather, changes in weather, lack of sleep. It's just across the board. What pain, and it's different for each area. The one thing that we think is interesting is the question was, has the ALGS patient ever had pain in a certain area and then suffered a break or a fracture as a result? and 81% no. So that is interesting, and I think maybe down the road for looking at research, why is that? I think there's just a lot that we can learn from this. And then the last thing, I just wanted to read you one last thing that someone wrote when they were asked to let us know if there's anything else that would help us. And this person responded that the pain in all areas for me leaves me feeling raw, like if some parts of the body should be there but are not there, and that's where the pain is. So it's just some insight that I wanted to pass along before we ask for any questions. If you have a question, just go ahead and shout that out there. Question for Dr. Piccoli or Shami or Hannah or us.
I'd just like to thank those ladies for sharing that about pain, because that's the story we have. Some of those things were just so touching. My problem is my son has had rectal cancer, and it was removed. And even coming off the theatre table, he was rolling around in pain, even with the ketamine and fentanyl drip. And then they took him off that pretty fast and put him on a buprenorphine. And then they said, well, then they looked at him as if to say, well, that's a drug addict, opiate, whatever it was. And so they had a lack of understanding all the way through his recovery from surgery, and it was just so hard. So is there apart from the doctors not understanding, is there a high pain threshold or anything that we can say to the doctors to say to them, it's not just, he's not just a druggo, he's got actual pain?
Dr. Piccoli, what can we say? What can a parent say to the doctors, or even the young adults? Until we find that doctor that does understand pain, like you were saying, what's the best way to talk to someone to get them to understand? Oh, you're on mute. Oh, let's see. There you go.
It's a tremendously difficult problem. And again, it's the difference between having a person caring for you who's an episodic caregiver versus someone who's really dedicated to your care. I'm surprised that right after an operation, usually there's a tremendous ramp up in pain control. The problem is, or a part of the problem is that we do face a large number of people who are narcotic seeking, and there is no magical way to tell between the person who really needs it and the person who is seeking for reasons that are other than acute pain. I was trained a very long time ago by an emergency room doctor who told me that if a patient can come in and tell you the name of the medication they want, that they're narcotic seeking, as opposed to I have pain and what can you do? I think it's a real challenge, and in the short term, I think at least in pediatrics, we always aim on the side of treating the pain. We have no monitors that can measure pain. And so different people bring their own, the practitioners bring their own experience, anecdotes, and baggage about what they feel when they meet someone who has acute pain. I think the pain control people, so we have a luxury here, I think a lot of centers do. We have a whole group that are specialists in pain control. For Mrs. Craig, I would say, don't give up on all medicines, because there are all these different classes that aren't narcotic and aren't acetaminophen that might have a beneficial effect. I had one patient who was having knee problems, went to our rheumatologist and is on Humira because she developed what is, for all the world, rheumatoid arthritis, juvenile rheumatoid arthritis. There's not an easy way, though. If somebody comes in with the bias that you're pain seeking, there's almost no way to easily talk them out of at least narcotics. I've never really seen anyone kind of like build a relationship around that query in the short term, So I don't really have an answer for that. The best way to convince someone is to have your primary person call them and say, this person never seeks narcotics, so give some. I mean, it's an interesting thing. In many of our systems, I can't call a narcotic into the pharmacy, so the person who is with you in the emergency room or whatever is the person who can provide that medicine. They want to have some reassurance, in a way, if you look at it from their point of view. They want to have a reassurance that they're doing the right thing and not contributing to a problem.
Sure. And what's interesting is, even though there's such a high percentage of individuals struggling with this, for the adults, only 3% of adults that answered the survey see a pain specialist, a pain management specialist. So that was very interesting to us. Maybe that's not something that's well known yet. Maybe we need to really educate. Shami, do you have any thoughts on why the adults and young adults may not seek out a pain management specialist?
I think from my perspective, I didn't know that existed at all until a few years ago. I didn't know it was an option. But more than that, when you go to speak to such professionals, like I did go through sports physiotherapy, I did go to see a special physiotherapist, and that kind of understanding that my bone density might not tolerate certain kinds of exercises or certain kinds of pressure levels was not there. So I had to do a lot of work trying to educate them and tell them, don't do this, or don't make me do that. This kind of exercise hurts my neck. Because also, full disclosure, I have had spinal surgery. So it took a lot of time for me to see physiotherapy and pain management through a specialist as a viable option, simply because they themselves weren't well trained. Now, that could also be because I'm not, say, in the US, where pain management is a thing. It is, like you're not going to hesitate to refer someone to a pain specialist. I really wouldn't know.
Hannah, does Damien see a pain management specialist?
He does not. Okay. And I guess part of that is because it's so random and you never know what to predict. I've heard of pain management clinics. In fact, I have a family member that goes to one. They were in a really bad car accident that damaged certain parts of their body, permanently. And so I know that they've been to that because it's just a constant pain, but I don't really think of pain management clinics in that aspect of just, I hurt Monday, but then maybe the Friday from next, I don't really think of pain management clinics in that aspect. And because I know he has so many different types of pain and in so many different places. And so I guess I just don't think about managing it in that aspect, because I know it comes from so many different sources and areas and possibilities and no rhyme or reason, that when I think pain management clinic, I think more constant, I wake up in pain, I go to bed in pain. I don't think of, this hurts on Monday and this hurts on Tuesday, or I don't think of it in that aspect. So I've never really asked about that, and it's never been presented to me. In fact, treatment in general, like none of his pain, we've had conversations and I've brought it up and I've tried to advocate for it. but because no one knows what it is or where it's coming from, treatment in general hasn't been addressed whatsoever, because we can't address something that we don't know what it is kind of where we've been dealt. So medication, we've never been given medication for any of his real pain management. And other aspects, like say right now we're dealing with abdominal pain, they have tried to figure it out and find different GI meds to deal with some of our GI issues that go along with the pain, like nausea and stuff like that. But we've never been done as a general aspect with broad spectrum, body-wise pain.
Okay.
If I could say one thing that I'm sure someone will not agree with me on this, and that's okay. Part of pain is the way you feel about the pain and the fear of the pain and the acceleration of the pain once it starts. And there are some tremendous techniques with cognitive behavioral therapy, psychology, that allow you to deal with that pain in a way so that you don't become dysfunctional and that it doesn't take over the minute or your life. And so I really, really, really believe in this. And in our division, where we deal with a lot of pain, although the bone pain we give to our rheumatologists, but for chronic abdominal pain, for instance, and nausea, we now have a team of 8 psychologists within my division, and the majority of what they do is to make people functional with pain or to resolve pain. It's not going to work if you break your femur, but for chronic recurrent pain, they can be magicians. And we so believe in them that we just keep hiring more and more, not because it helps our business, it doesn't, but because they're effective. And so for things like chronic abdominal pain, and it's different from back pain or bone pain, but there are studies that show that at the end of a year, the patients are better with CBT than they are with medication. So I would say keep an open mind about it. 9 is not too young to have those things be effective. It has nothing to do with craziness. It's about the stimulus, the response, and your reactivity. And for us, it's not true for every GI group in the country. There are a lot of places that have no psychologists at all. But for us, we found that it's a very effective way to make many patients get better.
What we'd really like to move into now is the emotional health aspect of living a life with Alagille syndrome. And, this is one of the #1 day-to-day issues that families deal with. It becomes very heavy. There's a stigma behind getting emotional support sometimes. And so I think it's a real important topic that we move into, just getting a better understanding about the options that are out there and how families are affected and what they can do to just help themselves in that aspect. I would like to introduce Dr. Lauren Fussner and Muzna Gulamali, and they will be presenting from 12:15 to 12:35. And welcome. Lauren, you're still muted, by the way.
Thanks. I'm actually going to get us started, so hopefully everybody can hear us. So my name is Muzna Gulamali, and I am a social worker in the Division of Gastroenterology, Hepatology, and Nutrition at the Children's Hospital of Philadelphia. And I will be presenting today with my colleague, Dr. Lauren Fussner, who is also one of our psychologists in our division. So we're excited to talk to you about emotional health and touch a little bit on the challenges of having a child with Alagille syndrome. So it might have a little bit of a delay on my screen, but I will continue on. Can anybody see the specific slide, or are you all seeing the whole PowerPoint?
Whole PowerPoint right now.
There we go. So can you go back one slide? Thank you. So this is our overview of our agenda today. We'll plan to discuss different tips and strategies to make things a little easier and help reframe some challenges. We'll end our presentation with some resources that will hopefully be helpful for you. And our hope is that you'll feel validated in your challenges and experiences and maybe even learn something new. So I'm preaching to the choir here, but parenting is of course hard, and parenting a child with a chronic condition brings up unique challenges. So here are some common themes that we've heard that people experience. Overwhelm is a big one, and as you all know, managing appointments and therapies, trying to stay up to date on research can be quite overwhelming. Guilt is a big one that we saw. It's a theme that we really saw in the surveys that a lot of you filled out before attending. And that's the guilt of passing along the condition to your child, the guilt of your child struggling with this, the guilt of if you have multiple children, the time that that takes away from your other children, and just the guilt of like losing touch with friends and family because you're so preoccupied with something else. Shame is also a big one, not feeling good enough or worthy, and kind of having difficulty connecting with a partner and friends because it's like difficult to connect to somebody that, you know, doesn't maybe understand what you're going through. And another big one is worry, wanting to provide the best for your child in their future, just worrying about their future, what that looks like, appointments, all of that. But I also want to flip the script a little bit and talk about a positive emotion, pride. It's hard for the worry and anxiety to not take over the positive experience, but it's something we wanted to highlight because there is some pride in watching your child succeed and navigating such a difficult experience that it is something we wanted to bring up and hope that some of you can pay a little bit more attention to that positive emotion.
Now we're going to transition to talking about some strategies that foster resilience and really promote a growth mindset for your child and your family. Most of your kids are probably already very resilient, which is wonderful. But we also know that resiliency is not a fixed trait. So it's definitely something that we can continue to foster and promote both within our children, our family, and our larger community. So we have some strategies here to continue your kind of journey to promote resiliency within your family. So most families of children with medical conditions have a very large treatment team, and hopefully those providers and physicians are helpful and serve as a support to you. It can also be sometimes challenging when providers have so many treatment recommendations that you're expected to follow. And so we want to remind you that you know your child best and to trust yourself as a parent. One thing that can be very helpful if you have a co-parenting partner, or even just to kind of take some time to yourself to think about what your goals are for the next week, 6 months, 12 months. And hopefully that can even free up some cognitive space, some brain load when you go to all of these different medical appointments, and again, are given kind of this handout with lengthy recommendations on them. So related to that, there's a lot of uncertainty about future care and future treatment plans for families with Alagille syndrome. And it can be, a lot of parents can feel pressured to have all of the answers and to kind of take that uncertainty away. And hopefully many of you, and I'm sure you are, kind of serve as your children's rock and their safe space, which is wonderful, but it's okay to not have all of the answers. And it's okay to sit with your child in that uncertainty. Related to that, it's okay to share in their frustration and sadness about similar things. That can be really healthy to model the range of emotions, even kind of the emotions that Muzna just touched on. So again, we want to be mindful not to just stay in that uncertainty and kind of frustration and distress, but it's okay to acknowledge that and then kind of join with them from a problem-solving perspective. Okay, so again, at times when our children have a lot of different things going on, maybe it's a week where they have so many different medical appointments, as parents, we can feel the urge to take something off of their plate and to make things a little bit easier. And that comes from a really wonderful place. But we also know that it's important to encourage normalcy with routines and household chores. That can also be really helpful when navigating just sibling relationships, that everyone has a different chore and those types of things. We know that structure and predictability increase your children's sense of control, which is really helpful. So again, things might need to be modified based on development and those types of things, but as much as you can continue to incorporate normal routines and normal tasks into your child's routine, that can be very helpful. And then these last two on the slide are possibly just maybe more of a gentle reminder to keep on your radar. There are periods of transition that are really common stressors for all children throughout development. So the transition to elementary school, middle school, high school, puberty, these are known transition times for all children. And for children with medical conditions, sometimes these transition periods can be a little bit more rocky. So if we're able to kind of proactively look forward and think if any of these common transition periods or common stressors might be on the horizon for our children, it can be really helpful to take action kind of sooner rather than later. And that can look a lot of different ways. It can be more informal with maybe that's when you're scheduling more play dates and doing more social activities, even if they're virtual right now. Or more formal with consulting with a therapist or a psychologist. And related to that, it's very helpful to model asking for help. So all of us need help, and the research on social support is tremendous, that when children know that they have a community that's behind them and supporting them and there to help them problem solve, they do much better across a range of outcomes, not just from a mental health perspective.
So we're going to switch a little bit and talk, going off of Lauren's point, talking a bit more about taking care of yourself as caregivers. As you've all maybe heard this before, you can't pour from an empty cup. And I really want to highlight that self-care isn't selfish. So not only is it important for, modeling that for your child, but it's also really important for you and your well-being. And it's important to find what works for you. So handling chronic illness is about learning to live in balance. And that is finding something that is a good stress relief for you, or something that you find to be enjoyable, and really making time for those things. And that, find what works for you. So for some of you, that's spiritual. If that is not for you, and something more like mindfulness, physical activity, just kind of finding what your outlet is. And it's important to know that not everything has to be weighted equally or given similar importance. So we kind of wanted to show here that what works for you might not be what works for the next person, and it does not all need to be the same. So whatever is important for you. And for that, if social is pretty important for you, and making time for a happy hour, even if it is a virtual happy hour with friends, is kind of what you need for some normalcy in your week, make time for that. If physical activity is more important for you, kind of just figuring out what works best. And I'd like to note that it's hard to work for 10 things at once. So it's important to prioritize what's important, and short-term and long-term goals in coping look different. So you might need to figure out what works for you today. How am I going to get through this day? Today's pretty stressful, and this is what, you know, I'm going to go for a run, or I'm going to go to a yoga class, or I'm going to meditate today, because that's how I'm getting through today. And then also making more long-term plans, and like long-term coping. An example is like sleep. I'm really sleep deprived, and I think it's, you know, I really need to work on a better sleep schedule. I just want to piggyback a little bit on what Muzna just shared and touch on some of the behavioral strategies we know can be really helpful for making measurable change and progress. So again, similar to what Muzna just shared, we want to be cautious not to work on 10 things at once. I know that life doesn't stop. So even if we're working on relaxation, the kids still need to get fed and everyone still needs to sleep and those types of things. But it can be really helpful, again, kind of going back to the beginning of our presentation, even to use your values as your compass to identify your priorities and your goals. Related to that, it's very important to take an honest assessment of where things are at now. This can really inform us in setting reasonable goals. As humans, sometimes we can be very ambitious and think that we're maybe doing a certain behavior more than we actually are. And we want to take good stock of how things are going now so we can make gradual change that's more long lasting. So we have some sample goals up here. And again, I think some of these goals might be geared more towards caring for yourself as caregivers, but it's also very reasonable to set specific manageable goals for your child's care as well. One thing that's worth noting, there's a lot of research on keeping a gratitude journal. So sometimes families keep or write down 3 things that they're thankful for each day or grateful for, which can be really wonderful. There's actually kind of a spin on a gratitude journal as well. That's a little bit more active. So it's kind of the last sample goal here. So writing down 3 things that you did that day that maybe make you feel proud or just to help you get through the day. So that's a little bit more of an active way of keeping progress. So again, similar, just some behavioral strategies here. Sometimes it can be helpful to add some weight to your plan. So research in adults often includes like exchanging money. So if you don't make it to your workout class, maybe you owe your friend $5 or you owe each other coffee or something like that. That can be really helpful for adults. Children, obviously, there are different ways to motivate them with a variety of incentives. So both social and tangible and privileges and those types of things. And again, just really being diligent about tracking progress on the goals that you want to be prioritizing right now. So as we wrap up, we want to mention a couple resources that might be helpful for your families. A really wonderful place to start is asking if your child's hospital or treatment team has a social worker or psychologist. I think these providers can often be very plugged into the community, and they have a little bit better knowledge of the medical condition as well, which can be helpful. For more community resources, there's a variety of types of treatment and therapy options that families might not know about. So there's individual treatment, there's family treatment that often includes most members of the household, and then there's marital and couples counseling, which usually involves primary caregivers or co-parenting partners. A really great place to start for finding a provider is your insurance carrier's website. That website is up to date with in-network providers to reduce the out-of-pocket cost. PsychologyToday.com also has really wonderful filters. You can even filter through insurance, which can sometimes be a little bit easier than reading through the bios on your network's website.
One thing that I think sometimes gets overlooked when trying to find a provider is interviewing the therapist or psychologist first. As a psychologist, I am never offended if families reach out to me and inquire more about my practice style and those types of things to make sure that I'm a good fit. I think in the long run, this saves everyone time. And especially when we're thinking about care for our children, sometimes it can be tough if we're going from provider to provider to really try and find that good fit. Sometimes kids can start to internalize that transition to provider as something that they're not doing right. So it takes a little bit of extra work from the parenting perspective, but I think it can be really helpful to have that phone consultation with the provider first. We have some phone apps here for relaxation and mindfulness. Many of these are pretty well known. I think maybe Stop, Breathe, and Think is a little less well known. It's my personal favorite. All of these are pretty kid friendly, and there are also child specific apps too. And then the Alagille Syndrome Alliance has really excellent support groups and Zoom Hangouts, which I'm sure many of you are already plugged into. And we have some websites here for parenting guidance and support with school resources, which I'm sure is a hot topic here currently. So we want to thank you very much for allowing us to share with you. We're really excited to hear your specific questions and comments towards the end of this chunk of presentations. Hopefully you were able to take something away from our presentation, even if it was validation of your experience as a parent of a child with Alagille syndrome. Your children are very lucky to have you all. You're doing a wonderful job and taking time out of your day today and tomorrow to attend these presentations really shows your dedication. So we're excited to talk with you all more.
Thank you, Dr. Fussner, and thank you, Muzna, for that. We will take some questions toward the end, but you know, like you just said, validation is so critical, and you know, we really appreciate you coming on and speaking to us. We will share for the group. We will share some of those resources and links, you know, after this meeting if you didn't get a chance to write those down. But before questions, we do want to go ahead and bring on Dr. Ruben Quiros, who is going to also talk to us about mental emotional health and more from the research side. So if you are ready, Dr. Quiros, I think Roberta is on standby to hand it over to you.
Hi there. It's a pleasure to be here. I just go into, my name is Ruben Quiros Tejeda. Basically, I'm a pediatric gastroenterologist. I have worked with Alagille for a good while. I started as a fellow, and obviously over the years I have been spending more time in other areas, or including the Alagille, but areas of liver disease. What I'm going to try to do today is in 15 minutes, very short, I'm not a psychologist by training. I'm basically a doctor that has been working for many years. I don't want to say how many, but 20 plus or so, that you know, give you a perspective of what I see as a GI provider and the things that we try to recognize early to get the right support for the families with a child with Alagille syndrome. Then most of the stories start with a couple that is expecting a child, and the child is born, and that kid is recognized to have what we call jaundice, or sometimes could have a heart condition or something in their kidneys that led to more studies. And at the end, after several studies and testing and even genetic assessment, you are left with the diagnosis of Alagille syndrome as a couple, as a new couple. It could be, if it's your first child, is going to obviously bring some stress, a little bit different than if it's your third or fourth, but again, it's usually something unexpected. And I think immediately as a practitioner, when I break the news to the couple, if I'm that person, then immediately is that question is just a very short why. And obviously, who has that answer? I usually try to explain, I go in the pathway of initially as a young physician, try to explain all the genetics and all these things that could have led to that. But in all honesty, the why is not to understand too much of the genetics at that given time. It's more to understand why that happened to me. I get questions like, it was something I did during my pregnancy from the woman, or the guy asking if a couple of beers could do it, or what was the reason? Why is the genetic disorder just show up, or the genetic defect show up in my child? And we know, now I can explain. Okay, listen, about half of the time is a de novo mutation or a large proportion, and you can go through all that, and you don't carry it sometimes, or one of the couple, one of the father or the mother has the problem, or the genetic defect, and all those. But why is in my child different? Because I just have a little murmur, it's not a lot, and try to go through the pathway of explaining, how the genes kind of behave and change. But the guilt comes right away, and then sometimes, we have to be careful, because sometimes that guilt can become a burden, and we have to recognize when it becomes a burden to the patient, or start burning out the person or the couple. Also, the blame comes right away. That was already mentioned of, and the blame is just to try to get rid of that guilt from one side or the other. And those are things that I personally try to recognize. The earlier you intervene in this kind of problems, the better. I mean, genetic counseling or counseling in general is usually something that should be offered right away, as has been presented just in the previous presentation, and try to understand, if how can we help that couple? How can we also understand, what is the likelihood of having another kid with the problem? If it's a young couple this is just the first child, then you have to recognize that. And sometimes as a doctors, we tend to go through the lengthening explanation of this is what happened, the genetics and so forth. But I think at some point also, and sometimes we forget about also just the emotions that are going in that room when you are talking to the family. As time passes, there are things that start happening. We talk about some of the things. Shame. I think one that I also like to try to. I think it's important. The stress, recognizing the stress in the family, because this is going to change the whole dynamics. If there are other siblings, it's going to bring a different dynamics that we have to understand and pay attention to. The stress can lead to a lot of problems like depression, anxiety, irritability, anger obviously comes, and also the feeling of isolation and trying to take care of the child that has a new diagnosis, with a lot of medical visits and a lot of different things and a lot of tests happening to try to understand the heart. Is there something in the heart? What is in the heart? Is going to need a surgery? And all those things, sometimes as a physician, we kind of overlook a little bit what is happening in the emotion of the family. I feel that we as a physician have to, and I train my fellows and train everybody to also understand the emotional aspects of the family, what is leading to to something, forget about the background noise. I mean, obviously people have personalities and cope with things in different ways, and we have to be there to help and understand that this is something that changed in the life of this family, and we need to recognize those things and be able to send it to the right resource, to have a psychologist right there, a social worker. I think also it's important to offer has been well saying that early intervention is always more impactful in the it will have a better outcome in regard to emotional stress and emotional health. I think the other part that as a physician sometimes we fail to recognize is when the parents start being isolated, isolating him or herself from the rest of the world, for their family. I mean, all these different feelings that have been mentioned and start putting themselves just no one can take care of this, my child better than I do, or because of the guilt, or because there's all this. Then sometimes the person doesn't recognize that need help, and I think we have to actively offer that help to be successful. I think the analogy I always use is the airplane, where they tell you you have to wear the mask first, put the oxygen first on you, and then you help someone else to do it. I think if you are healthy, you can take care of anything, and you have to, as a caregiver, you have to remember that this is a disease in one child in your family, but obviously impact your whole family. And the sooner you recognize all these issues, you're going to be better off in trying to being able to maintain your family intact during a stress period of time. As you don't recognize the stress, you start talking about it and getting the right support and the right network. I think as finding your network, you have to get rid of the pressure. You have to look out for the people around you. You know, yes, no one can do things like you do. I think we all have that feeling, but taking a break is so important. Finding someone that will help you, someone that will be there, even if it's just for a couple of hours. Finding the right resources to find some free time, because that's what will keep you healthy. Finding the free time will help you to do some of the things that have been talked about in the previous presentation, such as doing yoga or exercising your belief, if you are a believer, or spiritually, or doing something that will release that stress using some of the tools that have been already mentioned. I think it's also looking at people that have the same interests that you do. You know, this is a good platform, and that's why I enjoy so much to come here. And sometimes I'm challenged with topics that are difficult or a little bit outside of my box, because I understand how important it is for you as a parent. I mean, I have learned so much throughout the years by sharing times with the families, you know, outside the office of the examination room, because that's when you really learn what the real life is in someone with a chronic illness. For us, if you don't pay attention, it's just a 15, 20 minutes, half an hour follow-up visit. If you don't pay attention to it, I think, but you have to make those minute counts and be sure that you address all the things, because the health is not just the physical part. You know, I can take care of the pruritus, and we talk about that. We can take care of bone health and all those things. But I think something that at times we forget about is the emotional, the emotional health. And I think we have to recognize those issues. I think that always remember, and as you establish your network, that this is a two-way street. This is not just one that you are going to get something or someone will get something from you. If you have a networking, a good relationship, I mean, you should help each other and keep always an open mind as you try to establish that networking. Breaking that isolation is always, you gotta get into this curious status where you're open-minded, trying to understand others. And I think when you find someone that has this, going through some of this and these difficulties, and sometimes can be someone with a chronic illness. Obviously, Alagille, it will give you the advantage of sharing a lot of different things. And Alagille, as a process, also have a spectrum of presentation that varies from one kid to the other. But I think those things are things that you have to usually kind of keep in mind, that there are things that you can share, you have in common. And the last thing is that you know, like one mom one time told me, you know, I don't expect thank you every day. You know, I do it because I this is my child. But it was interesting one day when she comes after almost 10 years and tell me he came finally gave me thank you. Because I think sometimes you also have to take into consideration the emotions that are going through the child. You know, it's always like, why have to thank you if I'm the one with the problem? That's what the child told the mom. But at the end of the day, as he grew up, he understood all what this mom did for him. And I think, you know, even though you are not being thanked on the daily basis, there will come a time, thank you will show up in some point through your child, him or herself, or sometimes through someone that watch you doing it. And I think those are things that are going to move you toward a more positive set of mind. I think at the end of the day, what we talk about is also feel proud of it. And I like how we call our Alagille warriors. They are warriors. They are always kind of against something, but overcoming it. You know, and those are the times to celebrate. When something good happens, I think you also have to find ways to find something positive about the difficult situation. In any rate, I just want to give you a little bit of the perspective of a PDGI, and I don't want to take more time because I want to give you enough time to ask some questions about this.
Thank you, Dr. Quiros. You know, on the surveys that we did, especially the guilt survey, so many people that responded, 84% feel guilt, and 80%, it affects them every single day. And just for the reasons that Dr. Quiros touched on, you know, I passed it on to my child. What did I do during pregnancy that caused this? You know, but then it kind of goes into, you know, Dr. Quiros was speaking about caregivers having to be healthy to be able to take care of other people. But we heard on the surveys right here, I need time for me, but that's selfish. And that's how people are feeling. So we really, you know, this is a very important topic. Also too, adults, you know, adult ALGS warriors are dealing with a whole other set of emotion, you know, and mental health when it comes to survivor's guilt. And, you know, did I hold back my siblings and my family from experiences, or, you know, how did I change the direction of their lives? And then they feel guilt for always having to ask for help. You know, there's just so many different aspects of this. And then when we go back and look at the main surveys before we even got to guilt, you know, over half of their respondents have been bullied. And of course, that's going to carry along with you for the rest of your life. So, you know, this is such a great opportunity here today to really talk this through. And, you know, thank you to Dr. Fussner and Muzna too for some of those resources. Roberta, do you want to go ahead and talk, or do you want to take some questions? I think you're on mute also.
Am I on mute? Can you hear me?
There you are. There you are. Okay, so I'll turn it over to Roberta and then we'll take some questions.
Sure. The emotional impact of Alagille syndrome in my family really was what led me to the Alagille Syndrome Alliance. So I'd like to just kind of tell you my story and what we deal with here at the Alliance and what we hope to achieve. The emotional impact of Alagille syndrome on the family dynamic as a whole can be extremely difficult for a number of reasons. I've experienced firsthand the emotional struggle from within the ALGS diagnosis, and what's important to understand is that not only does the diagnosis bring about a serious heaviness of stress, of course, frustration, confusion, and worry, but it can also exacerbate already difficult circumstances within a family dynamic, and it's something that we don't really talk about a lot, like a history of drug or alcohol abuse, mental health challenges, additional health conditions, financial strain, a lack of resources, unemployment. There's so many things. These issues compounded with Alagille syndrome can then become sources of extreme depression, anxiety, emotional turmoil, relationship strain, continued drug and alcohol abuse, low self-esteem, low self-worth, and beyond. These high-stress circumstances that's seen throughout our support groups as well can, and not always, but do lead to divorce, doom about ALGS and life with the syndrome, a loss of friendships, a loss of goals, obsession about symptoms or care, loss of self-needs, and a lack of the ability to build a sound support system, which is critical, for our families. My personal story includes this very situation. My children's father was a recovering alcoholic who had struggled with alcoholism and drug abuse for many years. When we were ready to start a family, we were excited to move forward and thrilled to find out we were going to have twins. My children's dad was between jobs at the time, but we were doing okay financially. Immediately, when they were born, we were thrust into an extreme schedule of appointments, lab work, imaging, multiple specialists. This tight schedule decreased my ability to work full days, and it decreased his ability to find work. And ultimately, I had to resign from my position after fighting the union with HR, with my company, where I appealed for unpaid time off. Their response, after having multiple letters of support from clinicians, was, based on our needs of service, we cannot approve the unpaid time off. I was their top customer service representative on their sales side and in their bill collection side, and had an excellent attendance at work. That doesn't matter sometimes. Losing our only source of income made the ALGS diagnosis helpless and hopeless. We then turned to the state for financial support, and doing this felt like we were failing to support our family and support our children as parents. It shook our self-worth and then put us in a terrible system we found added additional stress to the already difficult situation. The tremendous amount of paperwork, the additional appointments, and extreme irritation for very little support in return. The stress is now terribly intense led to my spouse's increased emotional decline, our ability to communicate or make decisions together, a terrible weight of guilt that we just couldn't pull out of, and ultimately separated, and his ability to plug back in has yet to come. I've been a single parent since 2012. Many ALGS families connect, and the members carry one another through the journey. But more often than not, we see extremely difficult circumstances that become sometimes unmanageable. Treatment for the whole family, early intervention, it's critical to the survival of the precious family dynamic. Through our surveys, we've seen comments like, I feel guilt that I have passed this on to my child. I don't know how to help my husband. I feel reckless for not looking into Alagille before I became pregnant. This feels like my fault. I could have done something to prevent it. And this has had an effect on my relationships romantically and otherwise. I find it hard to fully connect with people. Sometimes I cannot even get comfortable with the people I've known for decades. The ALGSA is built on the mission to bring families and resources together. As the president, I feel we are falling short on bringing more options to families, and it's heartbreaking. We watch the emotional turmoil tear apart our families over and over and over. And it's our hope that one day there will be a deep understanding that early intervention, immediate intervention, be the gold standard for care for ALGS families. I'm an example of someone who was stuck in the system because the diagnosis did not allow me to continue to find work. I'm an example of so many Alagille parents who lose touch with their spouses or deal with other issues that are now compounded by the stress of an Alagille diagnosis. And I never want my child to feel like she caused these things. And so that adds an additional guilt to me to ensure that I never make her feel that this journey we were on and are on is a burden. And that guilt alone is extremely heavy within our community. So it also makes it difficult to talk about this in the support groups because families don't want to admit, one, that they've lost their job, that they need financial help. They sometimes don't want to admit that they could use emotional support. There's a stigma about getting therapy. We see people, I can deal with it by myself. We see support groups that are tattered, or support systems that are really tattered and not strong enough to help. And in turn, children are growing up negative and dealing with their own depression and anxiety. And I think a lot of that comes from, you know, early life and childhood, watching their parents suffer. And so I hope that, you know, in this discussion that we can, you know, step back as clinicians and you know, pharma and biotech, and just understand the individual emotional toll that this takes, as a person, as someone trying to achieve their goals. And we see many times the families, they don't finish college, they don't move on in their career, they're stuck, and there's no guidance to come out of that. And, you know, we put a lot of pressure on ourselves to always have the answers, but we have to be okay with getting help and opening up the discussion on this.
I think when we were going through all of the 300 responses, I think this was probably the one that was the most difficult. You know, Roberta, having lived through it, you know, just caused so much to, you know, kind of come back up to the surface. And then for me, you know, seeing it firsthand, you know, it was really, really difficult. And, you know, we were committed to helping families and, you know, trying to get our community through this. Are there questions or things that anyone wants to add? We still have Dr. Quiros, Dr. Fussner, and Muzna are all still on here. And then, of course, Roberta is always here to talk.
Can I throw something out there?
Yeah, sure.
So Roberta, I just private messaged you, but I just want to tell you how much I appreciate you and everything that you do for all of us. I had actually, Julia and I, a couple weeks ago, we had a little wine virtual night, and she was saying, you know, that we're trying to come up with some new topics and things like that. And it hit me the next day. I was like, we need to start really talking about the impact that Alagille's and having a child with a rare disorder is having on marriages and on families. And it's a hard topic. I mean, no one likes to get on and say like, hey, y'all, my marriage is falling apart. Like, woo, you know, this is terrible. It's, you know, so I think that's probably one of the most private, especially with two adults or, you know, anything like that. It's got to be one of the most private experiences to talk about. And so to be open and raw about it is, I think, very, very difficult for most people in general. And then you throw on, you know, all this extra stress of having a child with a disability and stuff. So I wanted to thank you because I feel like you do such a phenomenal job of bringing up those hard topics and being open to talking about them. And it needs to be done. And it's the only way that as a group, I think we can grow and support one another. And that's the reality of the situation of where we are at. So I wanted to say thank you and that I appreciate you.
Thanks, Stephanie. Does anyone else have questions or anything that they would like to add? I think this is, again, such a difficult thing to talk about, but there's a couple of other, Roberta and I both sort of touched on some things that came out of the survey, but you know, even so much as itchiness, you know, one of the quotes that came out of the survey, I feel guilty not being able to prevent his itchiness. You know, why didn't I notice the jaundice before all the other symptoms started? You know, it just keeps on going, you know, for so long. And it's just really a difficult topic.
You know, when we talk about the weight of the family dynamic, you know, being under such stress, it really stops someone's parents, for example, ability to see all the opportunity that there is in treatment in clinical trials, and getting a second opinion, and furthering their understanding and education about the disease. And a lot of times we see, in the support groups, sometimes the only place families feel comfortable to talk about any of this is in this support community. We have families who have not even talked to their extended families about Alagille syndrome because they just, they don't feel that they could explain how complex it is. Two, on the outside, their family looks completely put together and they don't want to, show anything other than that. And there's a real heaviness in every aspect of the emotional weight that this puts on. And, I'm just really touching on the parent side. When we look at the child's side, the teenager side, we see a tremendous, hill and valley of when a teenager transitions, that they unplug from the community and we may not see them again, until they're a young adult dealing with their own challenges and now trying to build their own support group. And, we find it difficult sometimes to bridge that gap for teenagers and young adults, to connect them to the resources that will help them, but also, the emotional side of, how do we help them or lead them to answers on how to get the emotional support, or get, feel comfortable getting a second opinion, or dealing with the stresses of trying to get a job, being itchy at your job, low performance, low focus in school, bad grades, can't get into college because they don't feel like they have the strength emotionally to move forward into that. And, as an organization, we're just really want to open up this discussion and talk about this terrible, terrible, infectious thing in our community. It's tough. It's tough.
And I think one thing to mention too is, if those of you that are kind of veterans around here, we had the message board so long ago, and we've kind of moved into the support groups on social media. We are trying to make an effort to move away from social media and back to our website as much as possible. And with the new website coming up here pretty soon, we will have more of a discussion board on the back end, where these kind of topics can be asked and discussed, and we'll have, specialists on that can help us answer those questions, help moderate. That's one of the things that we're trying to do from the Alliance standpoint. And I think we see, just like with the other areas of Alagille syndrome, we have, guilt with the kids, or emotional health with the kids. We have emotional health with young adults transitioning, teen and young adults transitioning, and then we have caregiver. But, honestly, it even goes past that. We had several grandparents and other family members that came on and answered some of the surveys, and so we have that perspective too. And it just like Alagille syndrome itself, this, the mental health portion of it really affects the entire family in so many instances. And Roberta obviously talked about that. And does anyone else, we're a little ahead of schedule. So does anyone else have any more thoughts or questions that they want to bring up?
I can provide a quick amount of comic relief if everyone wants to laugh at my huge mom fail whenever Bryce was little that I still carry today.
Of course.
So whenever Bryce left the NICU, I was pumping and we were fortifying. And so the NICU nurse was like, this is a teaspoon. You use the, you don't use the scoop, you use the teaspoon, and that's the formula that you put in, blah, blah, blah. So then fast forward like 4 months later, we were because of Bryce's lack of weight gain, we were having to put him on only formula. So then they're like, you do 4 scoops or whatever. Well, I continued using the teaspoon instead of the formula scoop. So his weight went from like horrible to even worse. And they're like, what is going on? And I was like, well, he's hungry all the time. This is fantastic. Like, we're making progress. I was starving my already very underweight child. So there's always that. You got to laugh at yourself. And I felt absolutely horrible. And I'm like, teaspoon. So there's my comic relief for everyone.
Stephanie. That's good. Okay, so I think what the best thing to do, we have a break coming up before our next section, which is itch. So I think what we'll do is just take a little bit longer of a break. And if anyone has questions or thoughts that they want to send us offline, we can circle back around on that tomorrow. And again, think about, after you leave here today, think about everything that we've talked about in all of our different sections, and maybe try to come tomorrow with some ideas. We'll certainly come with some ideas and, some things that maybe we can do to help impact all these challenges. Dr. Quiros or Dr. Fussner, any last things that either one of you would like to say before we go to break?
I can. Lauren, go ahead. Lauren, yeah.
Oh, I was just gonna say that I think, Roberta, you brought up a very good point about stress and problem solving, and I think maybe a little bit of a shameless plug to encourage you all to reach out as needed. I think sometimes therapy services can feel lifelong, especially with a lifelong condition. But again, and I can only speak for how we practice here at CHOP, but I know many providers are very comfortable playing more of a short-term problem-solving consultation role in your lives. So I would encourage you all just to think about that, or think about finding out what your benefits are. Behavioral health carve-out within medical plans are generally improving. And so it might be worth kind of looking into that for your specific plan and just trying to get a name of a psychologist or a therapist so that you have them kind of on standby. And that doesn't mean that you'll need to meet with a provider weekly for months or years. I think they can really just serve as another person to bounce ideas off of and help you problem solve. And then, if the provider has some medical specific knowledge, they can offer some behavioral strategies to kind of help the medical side as well, but really can be there to address all of the various needs of yourself, your child, your family at large. And I think it's wonderful that there are such great support groups within the Alagille Alliance. That said, I think some people feel more comfortable sharing one-on-one. And just maybe one other quick comment of, no one else needs to know that you're in treatment or therapy. That's not something that you owe anyone. It's a private, confidential relationship. So I hope that is not an additional barrier to already seeking care, because there are enough barriers as part of that.
Yeah, I was going to make a quick comment. Lauren talked some of the things I was thinking also to stress. I think the things that I think develop your network is extremely important. And the reason why you're here today is because you believe on this. You believe on family supporting each other. That's the main reason you are here today. Then this is a good venue to get support. It is a good venue to understand what other people have gone through. There are laws that may protect you that you may not be aware of. There may be certain things that you could do, program or things that in your particular state you could do, and then there may be resources there. Network also close at home is also important. Someone that can physically be there with you. And I think most of the time that start with you, because sometimes it's that you have created all these barriers, and I think the isolation sometimes comes from within. And I think just look at the people that are around you. They may not do things. I think the first thing is just step back and say, okay, you may not do things in the same way I do, but they can help. They can help you get a break. I think it's important. There's also here in Omaha, we have resources like, social work will be able to point it out to you in here, and I'm sure that there is in some other cities. But that there are volunteers, families that sometimes just give you a break for an hour or two, that you can have some of that me time that people talk about. Those are important to keep mental health. And I think you have to understand those resources as well. There may be someone that lives in the same area you live that belongs to the ALGS, and that's a good place to start, but also recognize that sometimes there are other families that may have, even they may not be quite the same, but if they have a chronic illness, they may have certain experience or certain areas that will be shared by anyone with a chronic problem.
Yeah, thank you for sharing that. That's actually something I meant to mention. That is a common role of social work. And even though that might not be advertised anywhere, we do have families that reach out to us to do it. And so I'm sure your local social worker would be able to do that too. Connecting with another family that is local to you and has kind of experienced what you have or is currently experiencing it as you're experiencing it is definitely a great outlet that I would definitely encourage. So thanks for bringing that up.
Good, thank you. And one last thing, I just wanted to point this out. We do not have right now, I was just scrolling through the list, we do not have any families on right now that are currently going through the grieving process, but we are still very committed to our families that are bereaved right now, and mental health extends into this. And I know that even though there's none of those families on here right now, we're all friends with those families, and we do still support them. They're still a part of our community, and we're very committed to that. So I just kind of wanted to mention that is also something that's on the top of our minds right now.
Okay, welcome back to our second annual ALGSA Virtual Roundtable. We are thrilled to have all of you here. We have amazing speakers, and the Virtual Roundtable is something that we started at the 2019 Symposium on Alagille Syndrome. We had a Eugene Washington Piccoli Award that allowed us to really organize and plan this amazing roundtable that Cher had pulled together a survey for our families, and through that survey, we were able to pluck out some really important pieces that we felt were, pivotal to the knowledge on Alagille syndrome, areas of concern that still needed to be addressed, and so on and so forth. So this virtual roundtable is based on 4 different surveys. Cher, do you want to tell them which surveys they are?
Sure. So now I'm going to go off memory because now my notes are gone. Thanks, Roberta. Now we had the Measuring What Matters, which was that really big general survey of, oh my goodness, there was 30 pages or so on that thing. And that was primarily pediatric answers on that, but we did have some adults and young adults take that one. But then we did have a separate adult assessment, which was fantastic. I think that was probably the most adults that we've heard from. It's kind of hard. We've never had one that is that was targeted for adults, but it was fantastic. We had well over 30 individual adults that took that one. And then we had the one on guilt, which really centered around, emotional health. And then at the end, we came up with a bone pain follow-up survey that we targeted to anyone that had mentioned joint pain, bone pain, or anything in the other surveys or on the support groups. So over 300 individuals, took these surveys, and we're just thrilled about that. Thank you all again for taking the time to go through them. I know it's labor intensive sometimes. We get really wordy on those, but that's just because if we're going to do it, let's do it. So thank you again for taking the time to do that and share your experiences. It has led to the content of this meeting, and then also some other focuses that we're going to have moving forward as well.
Thank you, Cher. So our next session is about itch, and we have some really great insight for this. First, I'd like to tell you the speakers are going to be Dr. Binita Kamath. We also have Ed Tucker, the CMO of Mirum. We have Ron Cooper, the President and CEO of Albireo. And we also have Tara Jaques, an ALGS mom. So I'm going to let you take it away, Binita.
Okay. Thanks, Roberta. Okay, Roberta, just checking that everybody can see my screen.
Yes.
Okay, excellent. So thank you, Roberta, Cher, everybody on the Alliance board for this invitation. I'm very excited to participate. So I don't have a lot of slides. I have a few slides, really just to kick off this session to talk about itch. I think the really exciting aspects of itch are coming in the next talks after mine, to hear from our partners in Mirum and Albireo to talk about what's really going to change itch. But I think at least here I can provide some overview so that we're all on the same page as we start to think about this important problem. So here are my disclosures. And, sometimes you'll hear physicians give talks and they're embarrassed about their partnerships with industry. I'm not embarrassed about these partnerships. I think these partnerships that I have been really productive and are really changing our field. So I'm very excited about that. But I do have a really important disclosure, and that is this. I'm going to come here and talk about itch, but really, I have not experienced or lived with cholestatic pruritus. And that is something that many, I would say perhaps most of the people on this call really know better than me, and better than some of us who are giving talks. And I think that really is an important disclosure. So when I start to talk about things like the impact of itch, I'm speaking from experience of working with patients and of reading the literature, but I don't want to underestimate for a second the real experience of living with somebody who has itch, cholestatic pruritus, or with somebody who has personally experienced it. So just for an overview of what I thought would be important to cover today, I'd like to talk about causes, or what we know about the causes of itch in cholestatic liver disease, the impact, a little bit about how we can measure and assess it, and then really to end with treatment, which is really a setup for the subsequent two talks. So what causes itch in cholestasis? This really is one of the biggest unsolved problems, because really we still don't really know. One day I hope that we will be able to say for sure that we'll be able to know exactly what the agent is that causes itch in cholestasis, but the truth of it is we don't fully know now. We have some clues, but we don't really have the actual answer. But this is a little bit about what we do know. So a little bit of science, I think, and I think this is fairly simple schematic, which I will work through. So hopefully people can see my pointer. So when you have cholestatic liver disease or a cholangiopathy, and you have buildup of bile in the liver, for sure we know that certain agents or certain factors that should be dealt with or by the liver should either be detoxified or should be put into the intestine to be put out in stool, or should basically be lost from the body, build up, and then end up in the circulation. And some of these are what we might call pruritogenic cofactors, and I'm going to talk about those, and they're listed at the bottom in the box: bile acids, autotaxin, lysophosphatidic acid, also known as LPA, and we'll go into more details about those. And these are certain agents that we know are elevated in the blood in cholestasis, but there is probably still an unknown factor, and I'm going to call it factor X here, which is somehow associated with these factors, something that's elevated during cholestatic liver disease that really is that agent, that factor that seems to be causing itch. And it probably acts on receptors in the skin that via itch receptors then signal to the spine sending further signals up to the brain. And probably that agent factor X and some of these cofactors may actually directly act in the spinal cord also, to then send signals up to the brain. And that's how we can then, the brain then senses the sensation of itch. And there are specific itch receptors and neurons in the skin. Previously, it was thought that itch was sensed via pain neurons, but we know now that there are really itch neurons. So we have a sense of how people feel the sensation of itch, how it's signaled to the brain. But what we're not sure about is what is actually signaling there. Is it, these cofactors are certainly part of the story, but there's probably something else that we don't yet have our finger quite on. So this is a little bit of thinking now about what these putative or hypothesized agents could be. And probably the most of what's been written about and the most of what we understand is about bile acids. Bile acids are clearly crucial. They're clearly very elevated in cholestasis, of course, in Alagille syndrome. And during cholestasis, they diffuse into the skin. They're found at elevated levels in the blood, but they're actually found in the skin as well. And we know that treatments, surgical and medical, that are directed towards lowering bile acid levels definitely reduce itch in many patients. So bile acids are clearly crucial, but they're not the whole story, because we know that bile acid levels do not correlate perfectly with itch severity. We do know that if you inject bile acids into mice, you can induce itch in some models. So they're clearly crucial, they're clearly important. They may be associated with this factor X in some relationship that we don't fully understand, but they're not the whole story. In recent years, probably about the last 5 or 6 years, there's been a lot of data about this LPA and the enzyme that produces LPA called autotaxin that was also thought to be the potential factor X. Could this be our smoking gun in pruritus? Again, studies that show when you inject LPA into mice, they itch. These levels of LPA are elevated in women with intrahepatic cholestasis of pregnancy, which is a transient cholestatic state. But still, the problem with this, the levels don't correlate perfectly. And that's also been something that's been harder to target from a medication standpoint. Opiates, or endogenous opiates that the body makes themselves, are always also thought to be implicated in itch in cholestasis. And we know that some agents like naltrexone, and some of our families on the call may have had experience of using that, can help to at least modify itch. And maybe what's actually happening there is that we're modifying the sensation of itch, or how the brain senses itch, rather than dealing with the underlying mechanism of itch itself. But they seem to be involved, at least in the way that the body senses or interprets or perceives itch. And then this big other. And there are other things. People have talked about the effect of bilirubin itself, but we still don't know. And whenever you've got a list this long, it means essentially that we're not sure. And just to summarize that, bile acids, LPA, opiates are all increased in cholestasis, but their levels in the blood do not perfectly correlate with itch severity. So what about the impact of itch? As I said at the beginning, really, this is something that our families know better than anybody else, but we know the impact of itch really has tremendous impacts on sleep disturbance and leads to sleep deprivation. Clearly, there's daytime fatigue with impact on learning in school for our children, and daytime attentiveness. There are physical manifestations associated with the impact of itch, specifically excoriations in the skin, breaks in the skin, which can become infected, and of course are disfiguring, but of course distressing as well. And I think the thing that I always want to emphasize is that having a patient, particularly a child who itches due to cholestasis, this is something that impacts the entire family. And we've done some research on that, looking at that. When you look at the impact of itch or cholestasis in a family, you look beyond the proband, meaning you look beyond the patient themselves, and you look at the impact on family functioning and a parent's ability to work. Or even one of the questions we asked in a recent study was the ability of a parent to do the things that they like to do, things that they need to get done. We know that all of these things get severely impaired and honestly devastated when there's a child that itches and doesn't sleep overnight. I just put in brackets at the bottom the impact of itching in adults. Probably this is really taken from other diseases, not Alagille syndrome, but other adult diseases like primary biliary cholangitis, where there are adults who itch, where clearly in that group, the itch associated with cholestasis is really can lead to severe mental health impacts such as depression and even suicidal ideation. And I put that there not specifically because I think our young children experience suicidal ideation. I'm not trying to scare anybody, but I think that adults can sometimes articulate better the impact of itch than children. And so this really brings home to me how awful cholestatic itch and pruritus can be. So how about measuring or assessing itch? The first thing I'm going to say to you, it's really difficult to do. It's difficult to measure itch, and it's really difficult to quantify it. And there are sort of, we have seen the use recently of patient-reported tools. Often these are observations of a caregiver, usually a parent, of how a child is experiencing itch. And these are best collected when you collect measurements on a daily basis. They're collected at home, they're best collected in the home environment, and they've been used in clinical trials. Any families that have been involved in our ongoing clinical trials will have had experience of filling in these on electronic diaries or handheld devices. Really good tools. I think they capture real life data. They're not really that helpful for us to use in the clinic though, because as you guys know, in the clinic, what you get is 15, 20, 30 minutes with your doctor in the clinic. And it's really hard for us to understand in that, or not to understand, we can understand, but to measure or quantify how bad itch is. And so often in the clinic, we rely on assessments of the skin or assessments of physical manifestations of itch. And for that, we've used something called the clinician scratch scale that basically scores on a scale of 0 to 4 manifestations on the skin. So looking at redness or abrasions or actually deep gouges or deep breaks in the skin. I'm not saying that physician assessments are better than patient-reported tools. I don't think anything can replace the value of a patient-reported or a caregiver-reported tool. But I think in a clinic assessment in the hospital, in our offices, when we're trying to assess the impact of itch, it's hard to use those patient-reported tools. And that really highlights what some of the gaps are. We don't have good ways in the clinic of assessing itch, the impact of itch on the quality of life, and we don't really have a good way of assessing sleep. And I think I should say we don't have it, and we don't have it yet. I think we're increasingly aware of how important these things are, and I think we need to get better about doing this, not just in a clinical trial setting, but actually in clinic, so that we can look back on our notes in a year and have maybe a score or a way, a more objective way of measuring the impact of itch. So thinking a little bit about the treatment of cholestatic pruritus, this is like a sort of very standard approach of what we may do. You know, one of the, almost all of our patients will be on ursodeoxycholic acid and will, in conjunction with some of these drugs or on their own, use antihistamines such as hydroxyzine or Benadryl. But most patients who itch know that ursodeoxycholic acid and antihistamine is not really going to hold the itch. And probably one of the first drugs that we will often consider will be cholestyramine. Cholestyramine, people will know, is difficult to administer. It's frankly unpalatable. It binds with other drugs, making its administration throughout the day difficult. And even when it's not binding with other drugs, it does lead to fat-soluble vitamin deficiency, which can be quite profound. So it's a tough drug to deal with. I think I found that it can work well when you have a patient that has a gastrostomy tube already, and so that you could administer it via a gastrostomy tube. But generally, it's not really my go-to drug, even though I think conceptually it should be helpful. There's just really major issues with using it. Rifampin is probably the most effective drug we have in a not great toolkit, I would say. We know people who've used it will know that it turns your secretions orange. That's not a major issue, but it's something to be aware of. So like tears will turn orange. But it does really seem to have, I would say, a moderate to good effect in cholestatic pruritus. There's always been a concern about rifampin having leading to some elevated liver numbers, so that's always more concerning in patients who already have elevated AST and ALT. That could rifampin increase that further, and it's something that we have to watch for, and is certainly possible, though I'm not sure it's a reason that I've ever had to stop rifampin, but it is something that I would keep an eye on. So that's would usually be a sort of a reasonable cocktail in a patient with Alagille syndrome who's starting to have moderate itching, would be ursodeoxycholic acid, plus or minus an antihistamine, and then rifampin. Now, the last two drugs that they've put more limited data. Probably naltrexone has much more data than sertraline. Naltrexone is, as I mentioned, it's receptor against opiates, a receptor antagonist against opiates, and I think it does give some benefit, sometimes as a combination with rifampin on top of the urso and an antihistamine. You can get some benefit with naltrexone, though it is can be associated with some adverse effects which mimic opioid withdrawal. Sertraline, sort of relatively, not a new drug per se, because it's a known drug used as an antidepressant, but a new drug, I would say, sort of being thought about now for pruritus and cholestasis, and there's just a small amount of data in pediatrics for using it. I don't have a vast amount of experience of using it. I've used it in 1 or 2 patients. I have not seen a significant benefit. I think the thing to emphasize when I look at this list is that it's all additive as well. We're not replacing one medication with the other. We're adding them in, adding. And I really sometimes look back and think about the tremendous burden that this puts on families, first of all, in administering this number of medications, the cost of this number of medications, and it really just strikes me that it's not easy. And there's clearly a major gap in our management plan or in our toolkit for how to approach pruritus. And that's where, of course, the new kid on the block and the new exciting kid on the block are the IBAT inhibitors, which we'll hear about more in the next 2 presentations, so I won't go into detail about them now, but just to say that I have great excitement because I think that these are going to really elevate the approach that we have to treating itch in cholestasis. I put this slide in just to mention some other things. These are things that are sometimes done in adults, occasionally in kids. They're sort of like what I would call experimental approaches. Not that they're in clinical trials experiments, but they're things that are sometimes tried when we're desperate. None of which I think are particularly effective in children, other than maybe nasobiliary drainage, which is putting a tube through the nose into the gut, into basically the bile ducts to drain bile, not as a permanent procedure, but occasionally you could use it as a proof of concept that reducing bile acids could help itch. But these are just up there as potentials, but not something that we seriously or regularly do in pediatrics. And that, of course, because when we get stuck, and you can see that not having so many choices with medicines to treat itch, we get stuck pretty quickly. And that leads us to think about surgical options, which are biliary diversion or liver transplantation. And it always strikes me that it's pretty devastating to have to consider a surgical option for a symptom such as itch. It strikes me that we should, as a field, be able to do better. And hopefully now with the IBAT inhibitors, we will, so that we can have less conversations about surgery, because I think that that's a huge step to take for a symptom like itch. And the interventions that we have, so of course, biliary diversion, several approaches to do that, but broadly categorized into a partial external biliary diversion, where bile is diverted from the gallbladder using a small piece of bowel to the stoma on the skin, so that on the abdominal wall, and so that leaves the patient with a permanent stoma, or permanent, it can be reversed, but you're left with a stoma that's there all the time. Or ileal exclusion, another approach which doesn't leave you with a stoma. I think the bottom line is that it's probably effective in about 50% of Alagille syndrome patients, some type of surgical diversion procedure. When we've looked at this recently in the Children Network, which is a network of 14 major pediatric liver centers across North America, it's very interesting to see that far fewer diversions are being done in the last few years, whether that's driven by physicians thinking that they're not as effective, or it's being driven by families who don't want to have a stoma, both of which I think are legitimate reasons for not doing a diversion. But I do think it is worthy of conversation, and certainly should be considered prior to liver transplantation, which is in the next whole order of risk. So I would certainly rather consider a diversion, offer a diversion to a family if the next step had to be transplantation. So liver transplantation, it's certainly 100% curative for pruritus, that is for sure, but it comes with a substantial risk of morbidity. So when I say morbidity, I mean a substantial risk of a number of other potential complications. And perhaps if any families have chatted to physicians or transplant physicians about this, they will always say, if you get a liver transplant, you're exchanging one disease for another. So yes, you can take away the liver disease of Alagille syndrome with a transplant, but you now have a liver transplant, and that in itself is almost like a disease state, because it can come with significant complications and issues that have to be dealt with, which are lifelong also, not to mention the risk of mortality. So I do think that itch is an important indication that should be taken into account when you're thinking about liver transplantation, but I think it's less rarely the only indication. There are usually other complications of cholestasis as well. So there's usually also perhaps xanthomas or poor growth or other evidence of end-stage liver disease rather than just itch alone. So I think a patient who is otherwise well, growing, has good liver function, but itches, that would be a really tough sell to a transplant team because of the risks that we've talked about. So just to summarize my take-home messages, I think it's fairly clear, and this audience needs to know, not to be convinced, but pruritus and itch are extremely debilitating and impacts the whole family. I think it's important to understand that the mechanism for pruritus and cholestasis has not been fully worked out, but clearly targeting and reducing bile acid levels really does help many patients' pruritus. But we still need to keep looking for factor X, and if we can find that unknown pruritogen, then we could have even the next new class of drugs where we could have targeted therapies against that factor X. And that's where I will leave it. Thank you.
Thank you so much. We're going to go ahead and move right into Ed Tucker's presentation. Ed?
Good morning or good afternoon. I just want to thank Cher and Roberta for an incredible meeting so far. I did not have really an anticipation coming into this meeting how incredibly rich the insights would be from the attendees here at this meeting. So thank you so much for sharing so much of your experience today. It's been hugely enlightening for me. And I'm just so impressed with the engagement of the scientists, the families, but in particular Roberta and Cher for bringing this together. So my sincere thank you for that. It's my pleasure today to introduce Mirum to those that don't know us, and also the progress we're making with maralixibat. I know that several of the members of the Mirum team have been in these meetings in the past, and we look forward to continuing that collaboration as we move forward with maralixibat. So you all seem very familiar with each other, and I'm really the new kid on the block, really choosing some of Binita's terms there. And I think maralixibat is also a new kid on the block. But let me just allow me to get to know you a little bit more and share a little bit of my experience. So I joined Mirum as the Chief Medical Officer about a year ago, almost a year. And my job is to oversee clinical development, safety, and also quality. And my other job is I'm a father of 2 children. And bringing those 2 things together really came to an apex when I joined Mirum. And what I began to understand was the challenges which you as parents have with supporting children with Alagille syndrome. But I can only just begin to imagine the challenges that you have. And today has been hugely enlightening for me to have a deeper knowledge of those challenges that you face on a daily basis. And so one of the opportunities I have is to really bring that to an apex, is to bring a team that can appreciate the challenges which you have in managing Alagille syndrome, but I can lead a team that maybe finds a solution for you in terms of delivering a pharmacotherapy that could potentially avoid liver surgery or serum bile acid diversion. So I'm a physician by trade, and I started way back in England quite a number of years ago. I worked in the industry for almost 30 years, and I hope that the experience that I've developed over the last 30 years is going to enable us at Mirum to deliver that treatment that these children really deserve. So a little bit about Mirum. You'll see here that we put patients in the middle of everything we do and everything we think about. We're trying to find transformative medicines that can really make a difference to your children's lives on a daily basis. We want to challenge some of the norms of how we develop drugs. On the right-hand side, you'll see some of the cholestatic liver diseases which we're trying to tackle. Alagille syndrome, which we're talking about today. But I'm also going to talk a little bit about progressive familial intrahepatic cholestasis, which is an adjacent disease in children that also causes significant pruritus. I'll also touch on a little bit about biliary atresia, which we're starting a clinical program to explore the use of maralixibat in treating those children too. In our adult program, we're also looking at primary sclerosing cholangitis and a really interesting indication of intrahepatic cholestasis in pregnancy. We're based in Foster City, but we're also based in Switzerland, in Basel. So in Mirum, we have a huge commitment to our patients. It's not just a job, it's really about passion. We have a lot of talented people in the organization who bring a lot of experience in developing products and also in the rare disease liver space. And many of you have collaborated and worked with many of my colleagues in the past. And the picture on the right-hand side of your screen here shows a visit to the FDA where we brought along, really pleased to see Binita here today, but also the collaboration with the Alagille Alliance as well, where we see Roberta here on the picture. And I think that's a really important part of how we approach finding solutions for our patients, because we want to get those dimensions and really understand the disease. We want to understand how we can shape our clinical trials to understand the disease and find a solution. And we can only do that by listening. That's really key for us. And while we do take the business of finding a new drug very important, and we take our job very, very seriously, there are times where we like to blow off a little bit of steam. And here you'll see the support of the Roar Like a Lion, which is the previous Alagille Alliance program. And we will continue to support the new programs, such as Shining the Light on the Fight, which we're going to do this year. So just a high level on our pipeline. I mentioned about Alagille. We are now in the process of submitting a new drug application for maralixibat for the indication of Alagille syndrome in the United States. In addition, we've just opened an expanded access program, which will allow patients access to maralixibat before a planned approval of maralixibat. And I'll give a little bit more detail about that in the later slides. In Europe, we're planning a submission. We are in the process of a submission for PFIC. And so we will do a similar submission to the European agencies in the fourth quarter of this year. I also mentioned that we're exploring biliary atresia, another cholestatic liver disease in young children. And we'll be starting that trial later this year, now that we have IND clearance from the FDA. So we're super excited about making a big change in pediatric cholestatic liver disease over the course of the next few weeks and the next few months and the next few years, showing how very committed we are to this high unmet medical need in your patients, in your children. I did mention the adult program again, and as I said, we're progressing very nicely with the primary sclerosing cholangitis and the intrahepatic cholestasis in pregnancy with our other product, which is called volixibat. So Binita called the molecule an IBAT. We also call it an apical sodium-dependent bile acid transporter, or an intestinal bile acid transporter. So IBAT and ASBT inhibitors are an interchangeable name. So how do these work? Well, bile acid, as Binita showed earlier, is secreted into the intestine. And the bile acids progress through the intestine. When they get to the end of the intestine, where the little X is on this slide, they usually are absorbed back into what's called the enterohepatic circulation, into the bloodstream, and then return back to the liver. Now, in patients with Alagille syndrome, there is a problem of getting those bile acids out and staying out. So you see the cholestatic appearance of jaundice, and that's due to the serum bile acid accumulation in the body. What ASBT inhibitors do is to prevent the circulation and recirculation back to the liver at the little X there. And as a result, these free bile acids continue to progress around the intestine, and then they're actually passed out through the feces. And what's really interesting about this product, it is minimally absorbed. So as a result, we don't see any systemic effects of maralixibat in patients, which is unusual for a drug, because usually we're looking for systemic effects. But in a drug which is contained within the gut or the intestine, we do not see those systemic effects. So it's a really interesting molecule, a really interesting treatment. And we've tested this treatment in over 1,600 individuals throughout the course of the clinical development of maralixibat. And of those, about 120 children have received maralixibat in our clinical development program in the Alagille trials and also in the PFIC trials. And some of those children are now treated beyond 5 years. So we can really start to see both the efficacy, the durability, and of course, what's important is the safety of this molecule. So we're really thrilled, and I'm going to share some of the results with you in the later slides. So this is the ICONIC study, which I think a number of you have participated, or your children have participated in this study. And some of the clinical investigators are also on the call today. And this was shown at ASLD, the liver meeting in Boston last year, 2019, when I just joined. And this was presented by Emmanuel Gonzalez. And what you're seeing here on the slide is patients started, if you can see my cursor, patients started at a baseline of pruritus. And then they were treated with maralixibat. Both lines, the pink and the blue lines, are treatment with maralixibat. And at 18 weeks, you'll see there is a very significant reduction in pruritus. And to Binita's point, this actually was very similar in tracking to the serum bile acids. We saw a reduction in the serum bile acids and a complementary reduction in pruritus. But I'm only going to show the pruritus here today because that's the most important thing for families and for caregivers, and of course for those children. So it's making a very big impact in the quality of life here. At 18 weeks, we then took some of the patients and placed them back on placebo. And those patients on placebo followed the red line in the 4 weeks. So in less than 4 weeks, they actually returned back to their baseline pruritus. So we could see there was a clear difference. We could see a treatment gain in the first 18 weeks. On withdrawal of the treatment, we saw a return to the baseline for those patients on placebo. And then when we return those children back onto maralixibat, they return back to the level of the other children who were continuing on maralixibat. So we were really pleased with this data. And actually that was the discussion which ensued with the agencies with regards to a potential filing. And as I alluded to, we are now filing for Alagille syndrome in the United States, and that filing is ongoing, and we look forward to completing that in the first quarter of next year. But what's also really important is how patients remained on drug for several years, all the way out to 5 years and beyond. And you can see we still have a significant reduction in pruritus burden for these children. And you know, when we look at the course of every day that these patients are experiencing itch, your children experience itch, 80 to 100% of the time, your children are not experiencing itch or have very little itch. And that's really important because we want to try and get to a point where children are having minimal or no itch, because we know how important that is for the quality of life. And then we also saw some additional benefits here. We saw a reduction in serum bile acids, which we are now understanding that serum bile acids contribute to liver fibrosis and potentially driving towards liver transplant. So lowering those serum bile acids is very, very important for patients with Alagille syndrome. When I saw the pictures earlier today, which David presented on xanthomas, it really brought home to me how important xanthomas are to children's development, their ability to stand. I was absolutely stunned by the pictures which Dave showed. In our trial, we showed reductions in xanthomas. So it made me feel even better coming into this meeting that we're making a difference with xanthomas. So those patients that came into the trial were treated, we saw a significant reduction in xanthomas. Interestingly, we also saw an improvement in height. And I'll show that slide a little bit later. And then overall, as you can probably start to feel, that if we're improving pruritus and we're improving these other endpoints, we're actually improving quality of life. And we really want to improve quality of life for children. And we believe that we're improving quality of life for parents. I'm going to touch on the safety side in another slide in a moment, so I won't forget that. But I wanted to show you those two other important endpoints. The xanthomas, you see a significant reduction over the course of over almost 200 weeks. And then what's really interesting is to see how our patients are responding in terms of height. So this dotted line along the bottom, the 0 line, is the 50th percentile of an average patient without Alagille syndrome. So what we're seeing here is we're seeing growth catch up. So these patients are not only following their own course in terms of their growth, they're actually catching up, which is really important for us. So we're really thrilled to see this, and you can see it's sustained out to almost 200 weeks, so almost 5 years. So we find this really encouraging and hopefully making a big difference to children. I did mention safety. So in a non-absorbed or minimally absorbed product that increases the amount of bile acid which is secreted, one can anticipate just from the physiology that there would be some disturbance in the GI tract. What was surprising for us was actually when we looked at the data in that 4-week period of randomized controlled data in the ICONIC study, we actually didn't see a difference. And then when we looked at another couple of studies, ICONIC and IMAGO, ITCH and IMAGO, we actually saw very similar performance or very similar GI effects between placebo over 13 weeks versus maralixibat. So this is very reassuring for us, because the one thing we don't want to do is to introduce a new problem for our patients. I did mention about the expanded access. So Mirum has now opened an expanded access for maralixibat with patients with Alagille syndrome in the United States and Canada. We're really thrilled to offer this opportunity for patients to be treated with maralixibat ahead of an anticipated approval in the United States. As I mentioned, we launched it just 3 weeks ago, and we're going to provide maralixibat to eligible patients up to and beyond the approval of maralixibat. So there's more data or there's more information. If you reach out to this website, we'll be happy to provide that information later. I think one of the questions we've had is there any out-of-pocket costs? And Mirum will carry the out-of-pocket costs, and no insurance is required to participate in this extended access program. We also have a website which is contained here, and you can look at the details and register online. We'll be happy to take other questions if there are others. I think there's quite a bit of interest in our EAP program. I'm going to take a little bit of a diversion into PFIC. This is PFIC 2. This is really a really interesting graph here in the PFIC 2 patients, which was presented by Professor Richard Thompson from King's College London at the recent Digital Liver Conference in August. And what we're seeing here is the normalization of serum bile acids in patients in the blue line, which is at the top here. If patients are normalized in their serum bile acids, we see them avoid liver transplant. And you'll see here the number of weeks, we're already out to almost 6 years. And patients who did not achieve that control of bile acids, they actually followed a line which is obviously more disappointing for patients and for caregivers, which resulted in transplants. And this is something we're trying to avoid. So what we're really, really pleased about is demonstrating and correlating a recent publication from NAPED, which really validates the serum bile acid theory that control of serum bile acids actually avoids transplant. And so we will share this data with the agencies, and this is part of our submission into the European agency for what we hope is going to be an approval in Europe for the PFIC2 community. So I hope by now you're getting the feeling that we put patients in the middle. We put patients in the center of our thinking. We love engaging with the Alliance and gaining the insights in terms of how patients are needing our help, finding a new therapy, and avoiding some of the challenges of Alagille syndrome. I'm just going to walk through a number of things which we're trying to do to try and help the wider community. So we want to understand the connection between the people who are afflicted by Alagille and the disease itself. So we've engaged now for over a year with the Emory Genetics Lab to diagnose through genotyping those patients who present to their physicians. And I think what I heard in earlier presentations was sometimes diagnosis is very challenging and sometimes there's misdiagnosis. But genotyping really gives you great insights into which diagnosis is the correct one. So there's a little bit more certainty about diagnosis. We're also exploring the natural history of these diseases. I mentioned NAPED, which is the PFIC consortia, accumulating an enormous amount of data on how patients are diagnosed and then followed for long periods of time. And we're looking at that data very closely, making comparisons with our own experiences in the clinical trial setting. We're also partnering with Binita and the GALA consortia as well, again, to obtain new insights into how patients are diagnosed and what some of the challenges are that we can see in that data. Binita alluded to factor X, and we're doing a lot of work in the subspecies of bile acids, which we believe that changing the subspecies of bile acids with an ASBT inhibitor could be that missing factor X. And so we continue to explore that, and we presented some data at EASL just over a month ago. We want to advance the science. We're very active in peer-reviewed journals, and we try to publish as much data as we possibly can as we acquire it. We have a good presence. We're a small company, but we have a good presence in terms of the posters we present, our abstracts. And we're very proud to have a number of late breaker orals that have occurred both at the ASLD presentation, but also the recent EASL conference. And we continue to engage with many of the leaders who are on this call today to get greater understandings into the rare liver disease space. And we'll continue with our clinical development program, and we won't rest until we find new molecules and we develop the molecules that we have in front of us, maralixibat and volixibat, to try and drive the highest amount of benefit to our patients. And we want to take those new therapies to the agencies. As I mentioned, Alagille syndrome, we're going to complete the NDA in Q1 next year, and we're going to prepare for launch of maralixibat in the United States in the second half of 2021. And we're going to be submitting in Europe in Q4 of this year. So we're really thrilled, we're very excited, and we've got a lot of work to do in terms of getting that delivery to our patients. And we want to ensure access to those therapies as much as possible. I mentioned the EAP program. We're still enrolling into the March PFIC3, which is a phase 3 study examining our PFIC patients. And as I mentioned, we're opening the biliary atresia study, which is called Embark. And on an anticipated approval, we will also be launching a patient and family support service, which after listening today, I really appreciate the support that patient families really need in this space. And so there'll be more information about that will come over the next few weeks and months. And we want to help ensure our patients are safe. So one of the commitments I have as a CMO is to make sure that we're equipped to analyze all of the safety data, liaising with some of the external safety management boards, and engaging safety experts as needed. And finally, our support to our communities. So this is a really important meeting for me personally. It's fantastic to be really brought in here and experience all of the stories and experiences that you shared very openly today, and I really appreciate that. And we will continue to support the patient communities. So with that, I'd like to thank you on behalf of Mirum for your continued support in our collaboration to help patients have a better life and benefit from the therapies that we potentially can bring through our pipeline. We are committed to providing access to maralixibat, and we're committed to transforming liver disease for your families and our patients. With that, I'll hand over to Ron.
Great. Well, thanks very much, Edwin. First of all, I'm absolutely just delighted to be here with you all today. I really appreciate the opportunity to dialogue with all of you and spend a little bit of time. I'm actually having a flashback, back to that patient symposium many years ago in San Diego, and I have to say that that had a profound impact on me. To that point, I'd had little interaction with children with Alagille syndrome. I had little interaction with parents, and we really enjoyed those listening sessions. And so I think many of you are probably on the line today. And I have to say those listening sessions really informed what we're trying to do at Albireo and how we interact and approach the community. So I want to thank you for that. And for those of you that are on the line that I get an opportunity to say a big hello to once again, hello to all of you. I'm going to flip through a few slides and give you a sense of what we're trying to do at Albireo, to serve the needs of this important community. But I'd start by saying that we are absolutely committed to those children with Alagille syndrome, to you, the parents, to the researchers, to the grandparents, to all the advocates in this community. And at the end of the day, I think that research is good, right? Research is good. Research is going to get us answers, and the investigators that are on the line today, the parents that are kind enough to put their children into these studies, and to all of us that are doing research, I'm just super grateful. Let me see if I can share some slides here with you, and we'll kind of go from there if that sounds okay. All right, let's hoping that you can see that, right? So a little bit about our commitment to research. Let me see if I can flick to the next slide. There we go. All right, super duper. So first of all, at Albireo, what is our mission, right? So we live by a credo that's called hope for families, right? And what we're trying to do is provide hope for the children, the parents, the grandparents, uncles and aunts, that we're hoping that our medicine will make some positive changes in their lives. Our lead asset is odevixibat. It's an ileal bile acid transport inhibitor. As you know, it's a mechanism where bile acids are removed through the body, through the stool. So beautiful once a day drug. It's in a little capsule or a little sprinkle, so nice and convenient, and a real powerful little agent. I'm coming to you on the back of probably the most exciting time that our company has ever experienced. 9 days ago, we announced positive results from the very first phase 3 prospective study in cholestatic liver diseases with the study called PEDFIC-1, which is in PFIC. But I'll talk a little bit about what that means for Alagille syndrome. And then a little bit about our planned initiation of a pivotal phase 3 in Alagille syndrome by the end of this year. Yeah, I think that our approach to Albireo for development of IBAT inhibitors is different approach. You know, our company was born in 2008 when a big company, AstraZeneca, came out of this area, and our company was actually born in Sweden. So our scientists have been working with IBAT inhibitors now for multiple decades. And the nice thing about it is we've had some good success. We have the world's first IBAT inhibitor, ALGSA, which is approved in Japan for another disease, chronic constipation. But we really wanted to bring odevixibat into pediatric cholestatic liver diseases. And it was interesting when I reflect back on that meeting in San Diego and how much we learned. I really wanted to take odevixibat into Alagille quicker, to be honest, right? But our scientists at that time were struggling to find a gold standard approach where we thought that odevixibat would be successful in a phase 3 study. You know, we know that our drug can be effective in Alagille syndrome, but getting a design we were struggling with at the time. And we've taken an approach that let's get a gold standard study, let's get a phase 3 prospective study up and going in an area where we think we can be successful first and build from that. And so that's why I'm delighted to share with you this great news about odevixibat working in PFIC and how that translates, you know, to Alagille syndrome. So remember, I'll just take you back to a little bit to our approach. So in phase 2, so the preliminary stage before phase 3, we did what was called a basket study. And some of you may have been involved in this, where we looked at a number of different doses of odevixibat, and we studied a basket of different cholestatic liver diseases, PFIC, biliary atresia, Alagille syndrome, and some other diseases. And what was great is what we saw was, first of all, a wonderful reduction in bile acids, a good dose response with our oral once-a-day medicine. And then you see on the right that we were able to have, you know, a nice impact on Alagille patients as well. So we were pretty excited about the results of this study. This study then allowed us to go to the FDA and the EMA, where we had agreement for them, for both the FDA, the EMA, and other regions in the world, to create the world's first randomized placebo-controlled prospective study, phase 3 study in PFIC. And we looked to enroll 60 patients. We landed up with 62 patients. As you can see here, we used 2 different doses, odevixibat, a low dose of 40, a higher dose of 120, and placebo. And this study was run all over the world. And the endpoints that we're looking to are very similar endpoints as you would think about in Alagille syndrome, being pruritus and serum bile acids. And then after people were in this 24-week study, patients had the opportunity to move into an open label study at the higher dose. And then we have another cohort of patients, of individuals who didn't actually qualify for the study. So a real commitment, you know, to this area and to generating important information in cholestatic liver disease. As I said, this information is hot off the press. So 9 days ago, we announced that we actually had really, really great results. When you do a study like this, in this case, we had 2 different primary endpoints, both pruritus and serum bile acids. And you can see here that we hit the pruritus primary endpoint with a p-value of 0.004. For those of you that are sort of new to p-values, you know, if you can get a p-value with 2 digits in it, you've done really well. But a triple-digit p-value is sort of unequivocal that odevixibat can improve pruritus. And if you look at some secondary endpoints, it shows that it can do that in a clinical manner. It shows sustained over time. So we're very excited about that information. Then what about bile acids? Well, the same thing occurred there. We were able to demonstrate a profound reduction of bile acids, and that reduction of bile acids, again, triple-digit p-value, 0.003, which unequivocally proves that odevixibat can actually reduce bile acids, you know, as well. So pruritus, bile acids, what about, what about through different patient populations? So many of you may not be aware there are different forms of PFIC, the PFIC 1, 2, 3, and others. And what was beautiful in our study is that odevixibat was effective in a wide range of different types of PFIC patients. And here you see the data looking at both PFIC 1 and PFIC 2 patients. And you see that both for the pruritus endpoint and the serum bile acid endpoint, you had a similar effect. So we anticipate that odevixibat could be very effective in a wide range of pediatric cholestatic liver disease patients. So then, of course, you're wondering, well, that sounds like really good efficacy. Those are very high P values. What about tolerability? And so we had beautiful tolerability. So in terms of first treatment emergent adverse effects, you see here that the placebo patients had about a 15%, odevixibat a little over 30. So about a 15% difference. And then if you look at GI disorders, which are, of course, an important part of this mechanism, you see that for total GI disorders, placebo had 10, odevixibat had 11.9. And if you drill down to diarrhea, very low single-digit 9.5% rate of diarrhea for odevixibat, and for placebo, 5%. So hopefully what you see here, it really is a great picture of excellent efficacy for pruritus and bile acids and tolerability. So you say, well, it's PFIC. This is really interesting. What does this mean for the Alagille community? I think what we've been able to show is that we've got an agent that has a powerful reduction of pruritus, powerful improvement in bile acids, that it works not just in one type of patient, but a wide range of patients, that the tolerability profile from a diarrhea perspective, low single digits. And as a result, we plan to file in the US and Europe. We plan to complete those filings by the beginning of next year. And we hope that we would have approvals for odevixibat around the world in the second half of next year. But what we've created here is the first and largest randomized placebo-controlled database in pediatric liver diseases. And I think what we've been able to show is that with a once daily, non-systemic, highly potent drug like odevixibat, we get the combination of really great tolerability, but really great efficacy as well. So what does this mean for the Alagille community? Well, in particular, we've made the commitment to move into a study. We announced earlier this year that we will be undertaking a phase 3 study in Alagille syndrome. The nice thing about this study is that we've had a discussion with both the FDA and the EMA and other jurisdictions around the world. And we have agreement on a single pivotal study for all of these parts of the world. The FDA has given us what's called an IND, which allows us to do the study in the US. And we're planning on starting the study by the end of this year. There's a lot of work ongoing. So if you look at the approach that we've had with odevixibat, the idea was, let's get something across the line as quickly as possible in an area where we think that we can design a study to win. We were able to do that with PFIC. We spent some time talking to many of the physicians on the phone and many of you as the patients to understand the differences in patients. And we think we finally found a study design which we think would be very successful for Alagille syndrome. And we're pretty excited to run that right across the world to seek approval in the US, Europe, and US. And then the third thing that we're doing is, I know many of you know patients and children who have biliary atresia. And we've already started a phase 3 study for biliary atresia. We have sites open across the US and soon around the rest of the world. And we're excited about that because that's a single study that should result, if it's successful, result in approval in the US, Europe, and the rest of the world. So what I hope you see from Albireo is a real commitment to these diseases with PFIC, Alagille, and biliary atresia, with 3 gold standard phase 3 studies that will give us a lot of data, which should give us approvability, hopefully in the US, Europe, and other regions across the world. And that we've demonstrated in the PFIC study that odevixibat, in fact, as a once-a-day drug, has the ability to reduce bile acids, improve pruritus, and do that with a very low diarrhea rate. But coming back to the Alagille community, what are we going to do to try and continue to work with the Alagille community? I go back to that meeting in San Diego, meeting many members of the team. I met Roberta for the first time then, and it's just been a pleasure. The professionalism that this organization has is unbelievable to me. I said after that meeting, I've been to lots of meetings before, lots of symposia, a lot of corporate types of things, but the level of professionalism and engagement from this community is just very impressive and very high. So we're absolutely committed. We continue to do research, and we're going to work hard on that research. And we'd like to partner with all of you, and particularly for those of you that are willing to put your children into these studies through our global pivotal trials where we should get approval, multiple regions around the world. We continue with our partners to support genetic testing, which we think is important, and as well, we continue to partner on education awareness programs, and I guess and getting understanding of the disease, as we are sponsors of the Gala project as well, working with Binita and her team. But more importantly, I would just like to reiterate, there are many of the Albireo team members on the line today. We consider ourselves to be part of this community. We believe that continuing to dialogue with each and every one of you, listening to what you have to say, doing good research, trying to provide you things that are useful, is really part of our mission. So I just close by saying, the Albireo focus is to live our mission of bringing hope to families, and we do that through collaborating, with many of you, patient advocates, to the parents, to the children, and to the physicians on the line, and to our industry partners. And we're really delighted to be part of this partnership. And I'm delighted really to have the opportunity to address all of you today. So thanks a million.
Thank you so much, Ron. Really appreciate it. Excellent presentations. I'd like to open up the floor for questions if we have any, and then once we're done with those, we'll move into our family presentation on itch. I know Katie Temple had a question. Katie, are you there?
Yeah, I'm there. Sorry. I don't know why it's so dark. I'm not sitting in a dark room, I promise. Thank you, like Ed and Ron, like your presentations are incredible, and this just sounds maxed out on all of the itch drugs that there are available for him. So these things sound amazing. Ed, you're talking about maralixibat submission in Europe, the Q4 of this year. Realistically, when does that actually mean that my son will be able to get the drug?
Ed, I'll jump in and say that Katie is in Scotland, and her concern then would be, will it be opening up in that area?
Yeah, thanks, Katie, for the question.
Sorry,
oh
yeah.
Katie, did you want to? Your internet was just breaking up a little bit.
I'm not. Yeah, I'm just gonna. Yeah.
Yep. Okay.
Yeah, so I think I've got the question. So Katie, we are looking forward to making the submission for our PFIC filing with the EMA. With regards to the UK, we're still exploring the results of Brexit, which adds an additional complexity. But in the interim, we want to continue to expand the access for PFIC patients in Europe. With regards to patients who have Alagille syndrome, we will continue to try to expand access there, and that's an ongoing project, an ongoing dialogue, which I don't have additional certainty on that at this moment in time, because it has to go through a number of discussions with the agencies.
Ron, could we open it up to ask if clinical trials will be available in that area?
Yeah, we would anticipate that we will have a UK site for the Alagille study. So, I think we're still in progress of getting sites that open and approvals, but I would be fairly confident we would have a site, at least one site in the UK.
We do have a question that has come up as well. Would anyone take a stab at explaining the difference between the two medications? Are they different mechanisms? Are they different, routes of pushing the bile acids out? For families, how do we explain that?
I'll take a shot first, Ron, if you don't mind. So I think in my diagram, the ASBT inhibitor, essentially you're blocking at the end of the small intestine the ability of the bile acids to be reabsorbed. So maralixibat blocks that transporter that prevents the serum prevents the bile acids going back into the systemic circulation and back to the liver. So as I mentioned, that then results in the serum bile acids being passed through the feces when one passes stool. I'll let Ron talk about odevixibat, but that is the mode of action of an ASBT inhibitor or an IBAT inhibitor. Our product, we have it in liquid form, which is it's a dispenser or what looks like a syringe, and you just pop it into the side of the cheek of the infant, and therefore you know that you're getting a good dose that usually is swallowed. And we heard earlier that vomiting is a challenge, etc. But we've had very high compliance rate with the liquid formulation. So hopefully that answers the question. I don't want to steal any of Ron's fire, so over to Ron.
Yeah, thanks, Edwin. I think that, as Edwin has described, mechanistically these compounds are similar. In our case, we have multiple IBAT inhibitors. So we have ALGSA and we have odevixibat. And if I compare odevixibat to IBAT to odevixibat to ALGSA, and odevixibat's the one that we're bringing forward in pediatric diseases, that's a more potent compound than our ALGSA, so it's one of the more potent compounds. It's given, so these compounds are all different structurally, so they're all different, and odevixibat is given differently than it is for ALGSA. So odevixibat is a once-a-day preparation. It is for the young children. You sprinkle a little bit on the end of a teaspoon and you give it with your favorite puree, whether it's applesauce or yogurt, and then it goes into little capsules. So I would just say that mechanistically, the way that as Evan has said, these compounds work by taking bile acids out of the body through the stools. That is similar, but they are different structures. They are different, and they work. And the preparations are a little bit different as well.
Could I say, so first of all, those were two phenomenal presentations, and as a clinician, I couldn't be more excited about having new and better options for pruritus, which is really, everyone on this call knows, a tremendous source of suffering at all different levels. If I could just step back for a second, cholesterol, which the body makes and is good for some things, becomes bile salts, and bile salts are really complicated, important molecules. So if you believe in this kind of stuff, a long time ago, we made these compounds. They're critical for absorbing fats. They're like detergents. They are detergents. And then the body says, we spent so much energy building these that we are not letting these go in the feces. So there is an uptake system in the bowel, which is really active and aggressive, that tries to bring these, that does bring these back into the body, and it recycles them. You heard about the enterohepatic circulation, because we don't want to waste these. These are tremendous molecules for everybody except for people with these diseases. So, for instance, in Alagille syndrome, some people probably secrete only 10% of the bile acids, the rest back up in their liver and their blood. But then these molecules down at the bottom of the bowel in this one area absorb them back 100%. And you would like to tell them, stop it in Alagille syndrome, and maybe we'll be able to do that. So each strategy that we have in this part of the pathway kind of does the same thing, but these molecules would be the most elegant with the least downside. So for instance, we talked about cholestyramine. As Binita said, tastes nasty, you can't hide it in chocolate, orange juice, whatever. And it was developed originally to drop cholesterol by binding bile salts. But it's a big, like tar, it binds all kinds of things, and it doesn't bind them that great. So if you excrete a lot of bile salts, it's pretty good. It certainly helps. It has a place, and it's as old as many of us are. A second thing would be if you diverted the bile so that all the bile came out in a bag, obviously the liver would not be able to reabsorb very much. So that's at the other end of the spectrum. That's a huge, it's a big operation, but it works really well for patients because it stops the body from reabsorbing. So then in between, there are people who have had the bottom part of their bowel removed for different diseases, and they lose bile salts in their feces because they've lost the piece of bowel that reabsorbs this. So for diseases like Crohn's disease, they get a bile salt diarrhea. So you heard a little bit about side effects. If bile salts go into the colon, it can cause a diarrhea. Honestly, I think in our experience, it's not much, but it is something that gets reported. So one other operation is to exclude that area surgically. Sometimes that works, sometimes not so great. And it's also a big surgery. And then this is, so every one of these strategies is to stop you from inappropriately reabsorbing the bile salts that you've been able to push out into your system. So these all fit along a continuum of strategies to overcome the fact that the body, however many tens of thousands of years ago, decided that bile salts are like the greatest thing in the world and we have to keep them. The other thing to think about, which I think is pretty clear to everyone, is that the liver is like a kidney. The liver gets rid of a whole bunch of things that are bad and it puts them all into bile. And so some of those things are medicines, some of those things are metals, cholesterol, other lipids, all those things. The liver knows how to get rid of those, but the one that it really wants to reclaim back later on is the bile salts. So there are two different mechanisms in this sequence: how to regulate it, how to excrete it, and then how to reabsorb it. So like in one of the PFICs, they can only not excrete bile salts. Everything else works. In Alagille syndrome, all the different things that travel through the pipes can build up in the liver. So you get a buildup of cholesterol, you get a buildup of bile salts, you get a buildup of copper and other things. So I don't know if that helps, but that's the big picture. Obviously, the science team understands all of that perfectly, which is why this strategy is really elegant, because it works right at one point and it has the potential. If your liver can put something out, this strategy could help it go to the feces rather than back up into the portal vein and back up into the liver.
Thank you, Dr. Piccoli, for that explanation. We have one more question, then we'll move into the family presentation by Tara. Nicole Stuckey asks, with the two promising drugs in development, I assume facilities or hospitals will align with one or the other through either the EAP with Mirum or Albireo's clinical trial. Can anyone speak to that, how the hospital plays a role, or the clinician, and what families should do if they want to get involved in either?
Maybe I can just jump in on the Mirum side, how it's Chris Peets from Mirum. For the expanded access program in the US and Canada, it's really physician driven. So any physician can reach out and get registered and enrolled to open up access to the expanded access program. And I'd just add a note also to the earlier question that Katie brought up, is outside of the US and Canada, we are working on the expansion of this program, either through under the label of an expanded access program or other clinical formats. So if you go to the website, ALGSEAP.com, there's a place to register to get updates. That's the best way to stay up to date with next steps once we have it lined up.
Roberta, I wonder if I could, I think, talking to the families, I think it's complicated for the families to navigate this. I think, as Chris said, this is going, in general, institutions or groups are not aligning with one company or another. I don't think that's a productive approach to the field or to our community. In general, we are partnering with both companies. And so I think that individual families should have a discussion with their physician about what's available in their country, in their city, in their site. And it's our job to do the best for you. And that's what we will do. And that will involve partnering with both. I think the best thing that we can do is partner with both companies and therefore offer our families options. Yeah, and so I think that's what I would say. We're not aligning with one or the other. I don't think that's the right philosophy for physicians to do that.
And I would just reiterate a little bit of what Binita said. Look, it's a pretty small community, right? Most of the people I see on the screen, I know, right? And we know each other, right? And at the end of the day, what are we really trying to do is to provide options for the children, right? And patients are different, right? And agents are different. So I would agree with Binita. Talk to your healthcare professional. There will be availability of these drugs through EAPs, through studies. Your physician can help you navigate what's the best. At the end of the day, I think we're trying to do something that can help children, right? And different children need different medicines. Having options is a really good thing.
If I could say, I mean, the perception of limitation is real, but it's not at all at the level that was just suggested. So there are insurance companies that will cover one medication in a class, but not others, or they will cover it as a preferred med. But if you don't take that med, you might have a copay that's significant. There are countries that have limited the panel of what they will provide. And if you're outside of that, there's significant challenges. Hospitals don't generally align that way at all. But from a hospital panel where you're only really talking about inpatient care, you can't necessarily have 40 meds in a class that you've got stored in your pharmacy for inpatients, because it's just prohibitively expensive. So they do have what are called formularies. So there are limitations, I think, way further downstream. I think at this stage, everyone is hoping we have as many options as we can have. And sometimes the limitations, not necessarily for these meds, are things like, does it come as a liquid? We have a lot of medications that have an encapsulation around the medication that protects it from the stomach. And so you just can't use them in kids because you have to crush them or turn them into a liquid. So there are those kind of things, and there are insurance company things, but I think we're all just hoping for as many good options as possible. And then downstream things, I always feel a little bit out of our control. We spend a huge amount of time arguing with insurance companies that the medicine we've selected is the best medicine for the child, and then they have some restriction against it, which drives us crazy. That's not a surprise. So.
Thank you. With that said, I would like to move in and introduce Tara Jaques. She is our family presenter on itch.
How's that?
Better.
So as Roberta said, I'm Tara Jaques. I live in Ontario, Canada. My father, my son, and I all have Alagille syndrome. However, we only discovered this about 6 years ago when my son Cord was diagnosed. And while my father and I have Alagille, we did not experience a life with itch the way Cord does. It's quite different. Cord's itch is what led to our Alagille discovery. We can pinpoint when his itching began to about 3 months of age, because he continually made this circular motion on his torso in his crib, this body wiggle he did all the time. And we understand now that that was his way of scratching when his body just didn't have the ability to do so yet. Today he has a scratching routine that he follows almost to a T every day. He wakes up, has a big stretch, and then scratches the arms that just had the big stretch. He goes about his day and it's pretty good. Once he starts to get tired in the afternoon, his stomach and his back become the more bothersome spots for him. And bedtime is the same every night. From 7 till 9, he scratches his legs and he scratches his feet. This might go back and forth 5 or 10 minutes, but it's generally 2 hours of him going at those feet and legs constantly. His skin on his legs are hard from years of scratching. And he'll even rub his legs together at night and kind of toss and turn, and wake up occasionally going into a big scratch. Last night was a doozy. It was one of the worst nights he's had in quite a while. I think he might have known that I needed today to get some stuff prepared, so I should probably wake up at 2 a.m. He couldn't get back to sleep. And the second time he woke up and he was saying, he was almost in this whiny cry voice, I need more hands, I need more hands. And I thought he was having a bad dream. So I snuggled in and tried to comfort him. And then he turned and said, no, Mom, I need more hands. I need more hands because these ones are tired and I have itchies I can't get with 2 hands. I have to get more hands to help this. And that's one of, the funnier things that we've had him tell us. That's much better than, Mom, make it stop, and those types of things you hear from those little voices. He did fall back asleep around 4. I did not. Morning comes and we start his scratching routine again. Do you remember as a child when you would swim in a lake or an ocean and or go to an amusement park and go on rides for the day, and when you'd lay in bed at night, your body still seemed to feel the motion of that? That's what the sound of Cord scratching his legs does in my head. The sound of his nails on his skin it's this grinding, hollow sound, like his nails are dragging across sandpaper. And that sound stays in my head. It feels like hours afterwards, just like the feeling of the waves used to. I know this sounds very familiar to many caregivers, and I've picked up a lot of tips from caregivers along the way, and from trial and error, of course. But the best tips that I ever found were from Alagille patients who lived through the itch. And I remember one saying, I think it was the first time I had met an Alagille patient in Washington. And she said a comment along the lines of, you wouldn't tell someone to stop blinking, so don't tell me to stop scratching. And that has always stayed with me. and really gave us a different perspective when it came to Cord and his itch. Your instinct is to try to stop it to help him, and that's not at all what he needs. The other thing that has been very helpful is keeping the house as cold as possible. We keep a basket of slippers and sweaters at our front door back when we used to have company over, and they all knew when you came into our house you needed your slippers and you needed a sweater on. And keeping the house cold and his temperature lowered makes a big difference. Our humid summers here can get quite draining. So if we can find a way to keep him cool, it definitely helps. We were actually even able to get a classroom air conditioner put into his education plan at school, and that's been helpful as well. We did create an itch kit for him that he takes to school as well. He has one at school and one at home. He just has a little kit, and it's full of all different things that he himself picked out. So he would go around the house and find different textures and try them on his skin to see what they were like. And there's different hair brushes in it, all that kind of feel a little bit different. I know this is a favorite one for his foot. There's a toothbrush for in between his toes. There's a cotton soft pad just to rub after he breaks the skin and it hurts, and that makes him feel better. There's everything. He found a lace headband, and the texture of the lace, he said, gets the itches better. All kinds of things that you can find. Silicone brush, exfoliation gloves. There's tons of stuff in here that are very helpful. The other thing that we did, which doesn't necessarily help with his itch at all, but it makes him feel better. If you have a child that is doing a bravery bead program at their hospital, what we did was on the days when we would be at the hospital and we would go down to the library and let them know what tests and procedures he had that day, they would pick out the beads for him that he earned, and then we have our own bag of beads, and he gets to pick one for the itching he had. And just having that little bit seems to help. He's fairly positive about it even. He said, "Remember that one night, Mom, and it was so much itching, I had 4 Band-Aids. Can I have 4 beads for that one?" And it's just something you can do to sort of make them smile if you can through one of those moments. And I really think little tools like that can help. They may not help everyone, and they may not work all the time. Cord wouldn't touch his itch kit for about 6 months. I don't know why. He just decided not to. But if it's something worth trying for sure for a little one that's itchy. I spoke with other Alagille parents this week. All of us had children with different ages and different stages of their itch. And I asked everybody what the itchiest part of their body was, and they all responded that it was their feet. One little warrior even struggles with her itchy feet so much that she will pull out her toenails when the itch underneath her toenails becomes too intense. Having never experienced that immense discomfort myself, I can't speak to how tormenting it must be to have a spot on your body that you can't bring relief to. I can, however, speak to what it feels like as a parent to watch the person you love suffer. The itchy person is not the only one affected in the household. Exhaustion, frustration, ache, it all flows through the household. Anyone that cares for the person suffering has these emotions that they carry. Cord's kindergarten teacher had a tough moment with him once. She found him in the closet of the classroom sitting on the floor, and he had his socks and his shoes off and his feet were bleeding, and she she didn't say anything. She just took off her socks and her shoes and sat with him on the floor in the closet of the kindergarten room until he was done and was able to put his shoes on and carry on with his day. And, you know, she expressed how she thinks that moment will haunt her forever. And it's been a few years since she taught him, and now she still carries that with her as a way of how simple it can be to connect with any child in her class, because she saw what sharing that moment with Cord did for him. You know, teachers, grandparents, friends, anyone who loves your child will be affected by them scratching. No matter how articulately you can describe what it's like when they're scratching, they don't understand until they see it happened. An example of this for us was Cord was going to have a babysitter. Up until that point, he'd only had grandma as a babysitter, and he was about 2 years old. And the babysitter that we hired was a university science student, and she was on her path to becoming an oncology nurse. My husband had known her since she was born, and he was having a great day that day. Our plan was to go get groceries together for 2 hours and come back. And 20 minutes into our drive down the road, my phone rang and she was hysterical. We turned around and we're back home, and she was drenched in tears and she was shaking. And Cord had started crying and scratching right when we left. And the cry that comes from a toddler age, there's just nothing quite like it. It's somewhere between sad and anger and just distressed because they don't know what's happening. And within 20 minutes, he had broke her down. It was sad, and she will carry that with her forever. We know that. The sound of it reminds me of, you know, if you see someone on fire and they're screaming that scream from their soul, it's like that, but there's nothing you can do to stop it. I'm not an expert like the amazing speakers we've heard today. I do know about washing bloody bedding each morning. I know what it's like to have a stranger tell you you should get rid of the cat that attacked your child because he's got scratches all over his face. And these are all things that we've all experienced and can share, which is incredible. Another thing that I heard across the board from Alagille parents was, my child didn't sleep well for 6 years. My child is 4.5 and has never slept through the night. Oh, I'd give anything for my child to have a full night's restful sleep. I strongly feel that itch is a more serious health concern than it's treated as sometimes. While it may not be a major physical issue, it's causing big emotional and mental issues for the whole family. There's children that are having tantrums, behavior issues, or delays simply because they feel awful all the time. And something that I think doesn't necessarily get discussed enough is why the itch doesn't necessarily correlate to the health of the child. You know, an Alagille warrior could be having a terrible itch week and health-wise, number-wise, be thriving. And it can go the other way too. A child could be having a medical emergency and not be itchy. And I think that's still something that a lot of parents don't completely have their mind wrapped around. As many of you know, my son wore only footed pajamas until he was 6 years old. He wore them to school, appointments, he even wore them for family photos. And that's how we protected his skin. He would still scratch, but his skin stayed safe. our local community where we are called him Pajama Boy, and people knew of Cord from his pajamas. There, of course, were the comments that get under your skin. You know, people would say, oh, what lucky parents you have that don't make you get dressed, or must be laundry day, or, oh, it must be nice to just be lazy all day long. And even with comments like that, we still had a really positive experience by having Cord's skin protected with something as simple as footed pajamas. And I know that that is shared by a lot of young Alagille kids that have nothing they can do. The parents can't do anything to necessarily help, but putting them in those footed pajamas and having that become an accepted way to keep them comfortable is a big deal. An adult in Cord's life wrote him a poem, and it was when he was about 3 years old, and it was called A Hero Disguise. And I'd like to read it to you in closing because it's just one of the best memories I have of someone sharing their love for our special little guy. A hero disguise. There is a special boy I know. His smile is deep and warm. He is no ordinary child. He battles the biggest storms. Zippered up to keep him safe, some may not realize. His unique armor, his very distinctive clothes, complete his superhero disguise. Watch out, world, 'cause here he comes. He's the boy in the pajamas. He wears them proudly and knows he's safe in his PJs with purple llamas. What is his superpower, you ask? Sit back and he will show you that a caring heart and endless courage can help a community grow. So that was his pajama poem. Thanks very much for listening, everybody.
Thank you, Tara. Thank you for being so relatable to so many people, and thank you for always being willing to share Cord with us and share those experiences. It just really helps others to know that that they're not alone in this. Really appreciate that. I want to say thank you to Ed and Chris from Mirum, and also Ron from Albireo, for bringing hope to families like Tara's. And as an organization, we know what a blessing it is to have companies like yours dedicated to finding treatments for this terrible symptom. I also want to thank Binita. Binita, you've led the charge on so much for so long. We're just indebted to you. And you mentioned at the beginning that you are proud of the partnerships that you have with these companies, and so are we. So thank you all so much. We're a little over on time, but it was worth it, to be able to hear Tara. So thank you all so much.
I'd like to introduce Dr. Jeffrey Feinstein with the ALGS Care Clinic at Stanford, and I'll let you take it away.
So as with everybody else, I'm going to start with my disclosure, and I must admit that I think that the pulmonary arteries in Alagille syndrome are in fact the coolest component of the syndrome. I might get a little pushback, but I may be the only one, but that is in fact what I believe. Now, I will say that as a cardiologist in the world of Alagille syndrome, I am one of few and far between. So this is a picture back from the 2018 Gala Investigators meeting that was out here in San Francisco. To prove that I was there, I've underlined my name as one of the presenters, but if you look carefully in the picture, they waited until I left in order to actually take the official photo from the event. So I will say I will continue to try to force myself into the club, but as of right now, they are doing a nice job in pretending that I'm not one of them. Now, that being said, I will start by saying a gigantic thanks to the Alliance, not just for today, but for everything that they do for the kids with Alagille syndrome, the way that they connect families with providers, the way they teach the providers, the way they get everybody into the Alagille family. I think it's just spectacular. And a special shout out to Anna, who was my first introduction to Alagille about 1,000 years ago when I started taking care of her son. A huge thanks to the patients and the families, not just for how they interact with myself and all of our trainees, but how great they are about letting us learn as part of their family. A big thanks to CHOP for setting the standard of what a true Alagille program looks like. In the setting of It's a Small World, Jack Rome, who's at CHOP, was actually my mentor about 1,000 years ago. And Jack was actually the one who, quote unquote, introduced me to the fascinating world of the pulmonary artery. So a thanks to him. And a particular thanks to the folks out at Sick Kids, Binita and Shannon. They actually have let me join the exclusive Gala Club. I am thrilled to be working on the cardiac portion of that with them. And so a thanks to all. I did want to say like 30 seconds of thanks in a different direction. We've got a number of calls and sort of check-ins from folks, some on the call, some around the world, just making sure that we're okay with all of the fires that are going on. Fortunately, we are in a safe place where we happen to be sitting about 30 miles or so south of San Francisco. But certainly a lot of our friends and families, quite frankly, Alagille families, are dealing with the fires. And at the same time, I want the folks, obviously, who are dealing with Sally to know that we're thinking about them and hope that they are all safe as well. So after hearing David's talk this morning, the advantage of going late in the day is that I then went back into my slides and deleted about 8 of them because they would have covered a lot of the same things that he had talked about. And I probably would not have covered them nearly as well. So I simply deleted the slides and will simply say that he did an amazing job. But I did want to start with sort of this slide, which talks a little bit about what we out here, and I think what CHOP has demonstrated is the true definition of a program. I think the program actually requires more than just a name. It really requires a carefully developed approach to a very specific challenge. The program also requires a champion, or in our case, 2 or 3. And I will simply say that caring for patients, for example, with Alagille syndrome, is not the same as having a program. And I will say that we have been caring for Alagille patients for decades. But to truly create what we felt was going to be a comprehensive program took us quite a long time. And as the Alliance was nice enough to announce, we formally launched the program only this summer. So I think it's also important, as David mentioned, that programs not only provide care, but they also engage in research and education and in advocacy. And all of those pieces combined, in my opinion, are truly what make up a program. And that is what we have strived to create here at Stanford, again, very much in the model of what CHOP and Sick Kids have already done for many, many years ahead of us. I'm going to focus a little bit more on the cardiac pieces of this, as David did such a great job on the liver part. But one of the things that I wanted to start with was just by showing where the speakers today hail from, right? So 1 in Philly, 1 in Toronto, 1 in Omaha, and then there's us sort of way out here on the left side. And I would simply say that while there's a lot of folks who take care of Alagille patients, the concept of a program and the number of people who can actively speak on this topic start to frame the context of why programs are important, why families should look for programs, and why, in fact, maybe some programs do things better than some other places. So the big question that everybody always asks is, my child is getting great care locally. Why should I come to or work with Stanford or work with CHOP or work with Sick Kids? In Stanford's case, I think one of the things that we offer is the cardiac component of the Alagille care. We are, in fact, the largest, and we certainly hope, the most respected pulmonary artery reconstruction program in the world, as I'll talk about in the second half of my speech here today. The pulmonary arteries are a critical component in Alagille syndrome. We're actually one of the few programs in the country, and in the nation for that matter, that's quite frankly used to dealing with kids with overly complicated pulmonary arteries and overly complicated liver, and the interactions between the two of those. And I think it's important, as also as David mentioned, that we will always, always, always work with the local providers. They play an absolutely critical piece in our management of the patients, or in the joint management of the patients. As again, as David alluded, it is incredibly hard for us to be able to manage the day-to-day issues when we're nowhere near the patient. We can't lay hands on them. We can't always communicate with them in the same time zone, for example. So the local providers are absolutely critical. And I will tell you for sure that we have essentially no patients in whom we are the only provider. I'd also suggest that it would be important to engage us in your family, because there is so much to learn in the cardiac world as it relates to Alagille. The understanding of these pulmonary vascular abnormalities is in its infancy, to sort of understate that. It was only 4 years ago when we actually first described what the PA abnormalities look like in Alagille. People have often known that there were PA narrowings or stenoses, but the fact that they actually had some sense of pattern hadn't been described yet. So as you can see, the liver team is way ahead of the cardiac and pulmonary piece of this, but we will work hard to catch up. I think the other question that David addressed this morning that I'd like to sort of point to as it relates to the program is the question as to whether we provide what we consider educational opportunities. They're educational opportunities for us, they're educational opportunities for the families, and they double, if you will, as a second opinion. So we do provide second opinions, especially for the cardiac pieces of this, both in person and virtually. I will second and even say a little bit more emphatically to please, please, please let your local providers know. It's critical to have them involved. It's also imperative oftentimes to get the information, but more importantly, it's a little embarrassing when the providers call us and say, hey, I heard you were, but they didn't hear it from the family. So a perfect example, and again, it's a very, very small world. We had one family reach out to one of our former trainees, ask for their opinion, and the trainee said, well, you do know that I trained at Stanford, so my opinions are likely to line up with theirs fairly well. That trainee called me and said, family called me, they found me in a different way, they found them through social media, and this is what I told them. And I said, obviously that's absolutely fine. The family then came back to see us another time, and they were quite embarrassed and quite uncomfortable. And you could tell that they were starting to hedge around the concept that they wanted to get a second opinion. And we were sitting quite honestly and just waiting for them to tell us, because obviously we already knew. It was at that point that they told us that they had reached out to a third provider. So it was actually not even the person that we knew about, it was yet another provider. We have literally no issue with that. We are encouraging people to get as many opinions as they think would be helpful. And we, when the information is obtained here, we are happy to send out the information to other providers. So please, let the local providers know, and we would love to work with them. The one thing that's sometimes a little bit different in the cardiac world than in the liver world is that we do tend to need to see the actual images. So sometimes we can get away with reports, and I think the liver teams can sometimes get away with reports, but when it comes to cardiac, and if it comes to neurosurge in the world of Moya Moya, we have to be able to see the images, and these can all be uploaded electronically. Here's a couple of examples of some of the recent queries that we've gotten. So one was a local family who had just been diagnosed at 2 months of age with Alagille syndrome. They're doing all of the workup with their local cardiologists who are literally 10 miles down the road. But once that workup is completed, they'd like us to take a look and offer an opinion. The second is a family from the Netherlands who's having trouble getting a second opinion. And while they've struggled with both liver and cardiac pieces, they've come to us to ask us to help them potentially look at the current cardiac status and see if in fact there are things that can be done. And in this particular scenario, again, very small community. I know the cardiologist in Groningen in the Netherlands and will be happy to actually have a conversation for them to educate me on what they've done so far. If you're nervous that you're the only one looking for a second opinion or trying to learn more about your child's care, I would say you're not. This is just a quick look at our cardiac families alone with Alagille syndrome that we care for. These are the patients that are currently co-managed with some of the local people. I will simply like to point out that even from the very small program in Philadelphia, we do share patients. It is important for us to be able to care for the kids when they need our expertise. As you guys all know incredibly well, there are a lot of questions as it relates to Alagille. Many organ systems involved, many different diseases within those organ systems. And I always have lived by the credo that a smart person is not one who knows the answers, but who knows where to find them. And with that in mind, we built an Alagille team so that when we need answers or we have difficult questions, we have people and we have experts with whom we can consult. Our care delivery model is both an outpatient and an inpatient model, both local and by telehealth. And we actually provide the entire spectrum of care, from inpatient and outpatient care, initial visits, specialty and subspecialty visits, and then long-term care as well. Even, for example, when the cardiac treatment is quote unquote done, we continue to follow long-term so we can learn and best optimize the family's care. From the cardiac perspective, the term that you'll hear thrown around as it relates to the Stanford program is the Pulmonary Artery Reconstruction Program, or the PAR program. As I mentioned, many of the kids have pulmonary issues, and so this is the program through which they often enter the system. There's a number of individuals involved in the program. It shouldn't surprise those of you who have dealt with the medical system that the nurses are up on top, because in fact, they are the critical link. They are the people who most make the system function best. The CT surgeons, I know many of you are familiar with Dr. Hanley. We also have two other surgeons who are training with Dr. Hanley and have been doing this for years. And so the CT surgical component of the pulmonary reconstruction program is continuing to grow. For those of you who are paying attention, you may have seen the name McElhenney in David's presentation this morning. So in Small World Phenomenon, Doff is now actually running our pulmonary artery reconstruction program, and he is helped by Dr. Asija and myself. On the liver side, Danielle is actually the Alagille program coordinator, and then Sarah and Allison help with all of the coordination. We have a number of liver and kidney transplant surgeons that are heavily involved. Dr. Gallo is the co-director of the Alagille program. Dr. Esquivel is internationally renowned for his work in solid organ transplant as well. Introducing the director of the Alagille program, that's Dr. Ebel. I am delighted to say that we work incredibly well together. At times, she seems almost as excited about the heart as I am, and I will tell you that I am almost as excited about the liver as she is, and that obviously works quite well. We also obviously have expertise as it relates to neurology and neurosurgery. Moya moya is not quite as commonly found in Alagille as some of the other components, for example, liver and cardiac, but it is a not uncommon issue for the families to deal with. Gary Steinberg, who is one of our adult and pediatric neurosurgeons, is felt to be the world's expert on moya moya. And so having him as part of our program is obviously exceptional for us. In neurology, we actually went out and recruited 3 neurologists with different areas of expertise to assist with our program. We have Bill Galantine, Maura Rezikov, and Sarah, who have expertise in epilepsy, neurogenetics, and in stroke. Unfortunately, as you all probably know, each of these areas is critically important to have expertise in, and we are fortunate that they have agreed to join us. In nephrology, Cynthia Wong has a ton of experience in Alagille and in the abnormalities associated with it. In the ophthalmology and genetics area, Anne and Dina have joined us, and finally in endocrine, Dr. Backrack and Dr. Grover. From our perspective, since we work as a unit, many of our patients come in through the various different doors, and whether you come in through the liver door or you come in through the cardiac door or the neurosurgical door makes no difference. Most of the patients who come in through their local physicians, for example, tend to come in through one door or another, and then our coordinators link the other services. Most of the families who find us actually come in via email or through the website, and this is the email that links in to our program. There's what I would consider to be sort of seamless interactions between all of the different programs, and so however best for you to engage, we are happy to have you do it that way. And I'm going to leave it with that, short and sweet, because I think my cardiac program may run a little bit long. Happy to answer questions or continue to move forward.
Thank you, Dr. Feinstein. If you just want to continue on, and then we'll save questions till the end.
Perfect. Happy to do that. So I was asked to provide a brief overview of the cardiac care for kids with Alagille syndrome, and I am going to try to keep it brief. I think everybody has a little bit different story, but some of the themes I suspect are common, and so I will try to touch on some of the common themes and get into the details only a little bit, quite honestly. I think the first thing for everybody to understand is just how common congenital heart disease is in Alagille syndrome. At least 75% of Alagille syndrome patients have congenital heart disease. And that is quite honestly probably an underestimate. Some studies now suggest that as many as 90% of patients have congenital heart disease. So the first take-home message from this talk is that if you or your child have not been seen and evaluated for congenital heart disease, please ask for a referral. Why do we care about congenital heart disease? Well, I think the simplest way to put it is that treatment for congenital heart disease in and of itself, regardless of the Alagille syndrome, leads to an improved quality of life and life expectancy. If treatment for some forms of congenital heart disease in Alagille syndrome is not undertaken, what I would call quote unquote in time, liver transplant may not be an option. Congenital heart disease, even when repaired, can complicate liver transplant, so it's important to have your cardiologist on board. And liver disease can complicate the congenital heart disease surgical treatment. So having a team that works together, or more importantly, having both systems evaluated as you're working through the issues in one system is critical. I'm going to give you a brief sort of walk through normal so that we can talk a little bit about what is abnormal. I'm going to start by showing these two little children. And even though this is right on my screen and left on my screen, this is actually the patient's left and the patient's right. And every time we show images and every time we talk about images or heart disease, things will often appear what quote unquote backwards. But if you think about it as if you are looking at the patient or the person or the child, it will make a lot more sense. So the heart in general can be broken up into top and bottom, or left and right, side to side. The two top chambers are called atria, and the two bottom chambers are called ventricles. The walls in between the two chambers on each side are called septum, the septum, like a deviated septum in your nose. The pulmonary arteries take the blood from the heart and send them to the lungs, and the aorta takes the blood from the left side of the heart and sends it to the body. The deoxygenated or blue blood comes back to the right side of the heart, and the oxygenated blood comes back to the left side of the heart. Obviously, this is a bit of an oversimplification, but for the time being, I hope that's sufficient. The thing that's not usually shown in this picture or many others is the rest of the pulmonary artery as it gets past sort of the center, if you will, of the chest. And this is oftentimes the area or the portion of the cardiovascular system that's most involved in Alagille syndrome. So I add this to this diagram to explicitly point that out. The way we often refer to all of the pulmonary arteries is as a pulmonary vascular tree. And if you think about the image of a tree, it has a trunk, it has a number of branches. Those branches continue to get smaller and smaller and smaller, and eventually, in the case of the pulmonary arteries, transition into the very small vessels, the capillaries, and then the pulmonary veins. But for some of the kids with Alagille syndrome, and a particular syndrome, these branches become incredibly important, not only because they may have issues with them, but in fact, they may not have formed properly and may not even form some version of a tree. Turns out that 3/4 to almost 90% of the congenital heart disease that is associated with Alagille syndrome is related to the right side of the heart. And the two areas that are shaded show the areas that are most commonly invoked. The main sort of pulmonary artery or pulmonary valve, and the branch pulmonary arteries. Some of the simpler defects that can be seen in Alagille syndrome in 5 to 10% are what are called septal defects. So they are just holes in the wall of the heart. So this is a hole between the top two chambers, atrial septal defect, and this is a hole between the bottom two chambers of the heart, a ventricular septal defect. I know that a question had come in before about a patent ductus arteriosus. Patent ductus arteriosus is not particularly common in Alagille syndrome, occurs probably in around 1% of the patients, whereas a patent ductus arteriosus is quite common in kids without Alagille syndrome. Tetralogy of Fallot is quite common in kids with Alagille syndrome, and tetralogy is a combination of lesions. One is the ventricular septal defect, as I showed you in the previous picture, but this is combined with a very small or blocked pulmonary valve. And this prevents some of the blood from getting to the lungs as easily as it would. And when the blood goes across this hole and out to the body, sometimes the kids will look blue or cyanotic. The most common lesion in patients with Alagille syndrome, however, are problems that are isolated to their pulmonary arteries. This is called pulmonary artery stenosis. It's called branch pulmonary artery stenosis. It could be called peripheral pulmonary artery stenosis. They all, in essence, refer to the same thing. And if you remember, when I added that little picture of the tree, there is more to the pulmonary arteries than is what is seen in this picture. There's a great deal more of the tree, what we call downstream, and a lot of the issues actually lie much further downstream than this picture. There's a number of tests that we use to diagnose and follow kids with congenital heart disease. I suspect many of you are going to be familiar with at least some of these tests. The one that most people are probably most familiar with is an echocardiogram. This is an ultrasound. It's a diagnostic test. This is an ultrasound or echo machine. The diagnostic tests allow us to take pictures, look at blood flow, and make measurements. But it doesn't actually see the portions of the pulmonary arteries that are affected in Alagille syndrome particularly well. This, for example, is one type of picture that can be taken by echo, another type of picture, and a third type of picture. I want to just focus on this one, and everything is labeled very nicely. A little bit difficult to see, but this is the main pulmonary artery that I showed you in the other images. This is the right pulmonary artery, and this is the left pulmonary artery. If I flip back to this picture, you're basically able to see this portion of the pulmonary arteries. You are not able to see anything downstream. And so while echo is incredibly helpful and incredibly important in the diagnosis and management of kids with congenital heart disease, in patients with Alagille syndrome, it may not be enough. There's our second take-home message. Echo is often not enough to fully evaluate kids with Alagille syndrome, and it often underestimates the degree of the disease. So in our patients, we will often add additional tests. One of those tests, and again, many of you may be familiar with this, is a CAT scan. The CAT scan also is a diagnostic test, but it allows us to look, for example, at the pulmonary arteries with a lot more detail. So, for example, this is a picture of a main pulmonary artery right here. This is the right pulmonary artery here, and this is the left pulmonary artery. Hopefully you can see my arrow. Somebody yell if you cannot. The other parts of this that you will notice, however, in this third panel with all of the arrows, these are all additional narrowings in those vessels. And you would never in a bazillion years see these narrowings by echo. They just can't be seen. The echo just doesn't get far enough out into the lungs. And in this last picture, the fourth picture, you can see the difference between the size of the main pulmonary artery, the right pulmonary artery, which runs horizontally, and then this small left pulmonary artery that runs towards 6 o'clock on your screen. A test I suspect not as many of you are familiar with is something called the lung perfusion scan. In this particular type of test, a tiny amount of radioactive material is put into an IV, and then the very small blood vessels in the lungs, the capillaries, catch some of this material. They then take a special picture, which is quite honestly a glorified Geiger counter, number of these little particles that go to each lung. The picture in white is fairly normal. The gray area that blocks a piece of the lung on the left is the heart. If you look at the two pictures on the right, this one shows obviously a lot less.
Jeff, you may have just gone to mute.
I'm back. I don't know how that happened, but thank you for pointing it out. So in this picture, for example, if this patient had simply had an echo, you would never have known that the narrowing or the stenosis was bad enough to only allow about 20% of the blood to go to the left lung, whereas normal is about 50%. And in this particular case, even though the echo showed that the narrowing was quite mild, the rest of the lung had not developed because there was not enough blood flow to that lung. By going in and repairing that narrowing, this patient now has about 40% of their blood flow going to this lung. This patient here has about 90% of the blood going to the right lung. This patient then underwent a series of repairs to try to get the lung to grow, and this patient now has about 45% of blood flow to the left lung. So simply relying on echo and not having additional testing may cause the providers to miss some important information. A little bit more invasively, and again, I suspect many of you have been through this procedure or have had your kids go through this procedure, is a cardiac catheterization. This is minimally invasive. It doesn't require surgery per se, but you are inside the blood vessels. And this allows us to measure pressures to help us estimate what potentially the risks might be, for example, for a liver transplant, or whether anything needs to be done at all. It also allows us to take pictures, and these are two examples of patients with Alagille syndromes who have had pictures taken in the cath lab. You can see the narrowings in these pictures. They're fairly obvious, even for folks who don't do that for a living. In this particular picture, and it may be a little bit hard to see, there's a stent in place. We are not particularly big fans of stents, and the reason for that is simply because they don't work particularly well. They may help when things need to be temporized, but kids grow, stents don't grow, and quite frankly, Alagille vessels, they don't like to be pushed around. And stents quite often will not be able to fully open those blood vessels. So we tend to prefer surgery. I will tell you in all honesty that not all centers around the world have the technical expertise to operate on these patients and get all of the narrowings. So some centers around the world do use balloons and stents. And if it is able to alleviate some of the work that the heart has to do, then sometimes that is in fact what needs to be done. The surgical approach here is quite unique, and we are incredibly fortunate to have the team that we do. And the approach, quite frankly, is just to leave no stone unturned and to leave no stenosis unattended to. So our surgical team literally addresses every single narrowing and every single stenosis that they believe will help add tree, if you will, add branches to the tree and lower the pressure overall. So if you take the patient that's shown here on the left with all of these narrowings, they will literally go one by one, open up every single vessel and put a patch on that vessel. And it is not at all unusual for our patients to end up with multiple patches in multiple places. There's one particular subgroup of tetralogy patients, and they have what's called pulmonary atresia. And in this picture, you will notice, here's the normal. You will notice that these kids only have effectively one vessel leaving their heart. The pulmonary artery itself does not connect to the heart. These patients who have what are called MAPCAs, major aortopulmonary collateral arteries, they have the pieces of their tree scattered throughout different portions of the aorta. And these are just two examples. And if you remember, the rest of the tree is connected to these sort of central pieces. So these are two different patients that have two different versions of MAPGAs. Here's a couple of pictures. These are catheterization-based pictures or angiograms. This here is the aorta. And you can see the vessels coming off the aorta and the rest of the tree. Different patients have different MAPGAs. In a recent study that one of our former fellows actually undertook, they looked at over 500 patients with MAPGAs, and essentially no two of them were exactly the same. When our surgical team goes to repair these patients, they do what is known as a unifocalization procedure, and they try to literally unify all of the pieces. So they take all of the pieces that are attached in various places, they do some cutting and some pasting, they put the puzzle together, and they end up with a full tree. This process in the hands of our surgeons can take anywhere from 10 to 14 hours, all in one setting. Those of us who don't do this say it's as easy as simply cutting and pasting. I'm going to stop sharing this screen, and I'm actually going to share my other screen and show you what a little bit of this process looks like. And for those of you who like this, you can go ahead and do this by yourself.
The heart works less efficiently. Because the pulmonary artery is blocked, the heart has to push blood to the lungs the long way, out the aorta and through the collateral arteries.
That's Dr. Hanley, by the way.
The procedure we do, called unifocalization, lets us rebuild a normal connection between the heart and the lungs. We do that by gathering up all of these collaterals and surgically combining them into a unified, functioning pulmonary artery. That way, the heart can pump blood directly to the lungs. But first, we need to find all of those collateral arteries. Days or weeks before the surgery, we bring the patient to the cardiac catheterization laboratory, or cath lab, where we use video x-rays to create a roadmap that helps us locate each one of these collaterals. Each patient is different. Some only have 1 or 2 collaterals, others can have 5 or even more. So we really do need that map in order to plan the unifocalization surgery. We've created a simulation so you can see how unifocalization works by performing it yourself. In the operating room, the procedure can take more than 12 hours to complete, but you can do a simplified version here in a couple of minutes. Start by pulling one of the larger collaterals away from the aorta and attaching it to the blue-colored pulmonary artery above it. Sometimes the collaterals are a little small, so we make them bigger by sewing in some extra patch tissue. Grab one of the tissue patches and add it to the smaller collateral.
That's me doing that, by the way.
Now, attach the enlarged collateral to the pulmonary artery above. Nice work. Now repeat the process with the 2 collaterals on the other side.
I think you guys get the general gist of what it takes for Dr. Hanley and his team to reconstruct these. I'm going to flip back. To my PowerPoint presentation. In just enough time to give you a couple of take-home messages. So first of all, congenital heart disease is quite common in patients with Alagille syndrome. If you have not yet seen a cardiologist, please do. If you hear pulmonary artery stenosis and an echocardiogram is the only test performed, politely ask if more testing, for example, the lung perfusion scan or CT scan, might be helpful. And last but not least, we're here to help partner, confirm, nudge, treat, and optimize the care for kids with Alagille syndrome. Thanks very much.
Thank you so much, Dr. Feinstein. We'd like to open up the floor for questions, if anyone has any.
Hannah had a good one that's in the chat, just FYI.
Okay, let's see. Should a patient with pulmonary stenosis automatically have these at least once for baseline or periodically? If so, do they need both of these extra image testings?
So the way that we would generally work up a patient with Alagille syndrome is they would start with an echocardiogram. If the only issue that they have is, for example, an atrial septal defect or a ventricular septal defect, that would be addressed the same way that we would address it in any patient with those types of defects. If we look at the echo and we notice that the pulmonary arteries are narrowed, at least the pieces of them that we can see, then we would tend to move to the next set of tests, which is in fact the lung perfusion scan and the CT scan. Sometimes, quite honestly, the echo would suggest that the pulmonary arteries are completely normal. There's a particular finding in kids with Alagille syndrome and peripheral pulmonary artery stenosis, a particular murmur in a particular place that would suggest that they have other narrowings further out that can't be seen by echo. So in general, yes, we do tend to have any of our kids with Alagille syndrome and pulmonary stenosis undergo at a minimum an echo, a CT scan, and a lung perfusion scan. We then will sometimes use those tests to follow them both pre-op, or if they don't need surgery, longitudinally. They're also quite commonly used post-op. So for example, our patients who have MAPGAs, tetralogy with MAPGAs, they get repeat lung perfusion scans multiple times over the first year after their repair, and then generally once a year or once every other year after that until things are stable.
Thank you. We have a couple of really good questions coming in. Anne-Marie Wheeler from Canada asks, would you recommend getting a CT scan or a lung perfusion before a catheterization?
That is a great question. And in our algorithm, the answer is yes. I'll give you a number of different reasons for that. One of the advantages of the CT scan, for example, are those beautiful three-dimensional pictures that we can then generate. Cardiac cath has its own advantages in that it can go into each of those different pieces of the lung and measure pressures, which is actually quite important for Dr. Hanley and his team. But if you're trying to get an overall look at all of the narrowings, it's quite a bit easier to do it by CT, the way that we do it here and the way that obviously many centers are capable of doing, than to simply go and take pictures of every single vessel within the lungs. Now, that being said, for the patients with the MAPGAs, those arteries are often better delineated by cath, and those patients do not generally get CTs, as we would say, for a roadmap. So if you have tetralogy with MAPGAs, we tend not to do CT all the time, though in our newborns we do it, but for a very different reason. But for kids who have pulmonary stenosis, isolated pulmonary stenosis, essentially every one of our kids will get that before they head to the cath lab. Lung scan as well.
Ana Cifuentes asks, are any experience with COVID-19 in kids with PA reconstruction? And she also asks, once PA reconstruction has been done, is there any experience of more stenosis developing years later?
Okay, so a couple questions. So the first one, I can't see them, but I'm going to try and remember these. So the first one was COVID. So as best we know, there is not a particular increase in the risk associated with COVID in patients who have congenital heart disease or pulmonary artery stenosis. The good news is that the numbers are incredibly small. As I suspect the other providers on the line can attest, there are not a lot of kids being hospitalized with COVID. We've had a number of kids who've gotten COVID, but fortunately have had very mild cases and not needed hospitalization. But as best we know, there is nothing about having pulmonary stenosis that puts you at an additional risk. And then I've already forgotten the second question.
The second question is, once PA reconstruction has been done, is there any experience of more stenosis developing years later?
Yes. So the short answer is we know for a fact that it can develop even in the most experienced hands. And that is one of the reasons that we follow the kids so closely and why we do repeat testing. So for example, the protocol that we follow after, for example, the MAPCA patients are repaired, they get serial lung scans throughout that first year, and every one of those patients gets a repeat catheterization 1 year after repair, specifically looking for recurrent areas of narrowing or stenoses. So it is without a doubt possible for stenoses to develop. Now, that being said, many patients who have narrowings in their pulmonary arteries can remain stable for quite a bit of time, and some may not ever require any intervention, but they do require longitudinal follow-up so that they can be tracked, so that if they do develop pressures that are too high or blood flow that is too discrepant, that intervention could then be done.
Excellent. Joanna Palinchuk from Florida asks, when should we stop relying on our local cardiology team and start getting serious with the program at Stanford? Is it age-based, symptoms-based, or health history-based?
So the short answer to that question is you should never stop relying on your local cardiologist, because he or she will in fact provide far more care over the life of your child than we will. And that is critical. That is absolutely critical. From the perspective of becoming part of our family as well, I would simply say that it's never too early. If all we do is look at all of the information and say everything looks fantastic, I can't imagine anything that would make us and you happier. If we look at it and we say there's nothing to be done anytime soon, but you may end up having something done in a year or 5 years or 10 years, from our perspective, data is power. If you know what you're looking out for, then sometimes that's all that you need. And if, for example, we believe that something should be done that hasn't been suggested yet, we are happy to talk to the local doctors and provide the experience that we have and explain why, in fact, we tend to encourage, for example, early intervention. Many of our younger patients who, shall we say, are on the fence, they may need the intervention now, they may need it in a little bit of time. We weigh very heavily their liver disease as part of that decision. So the exact timing of when you want to operate is before the liver disease will complicate that surgery. And the time that you want to fix the heart is before you need a transplant and your heart makes you not a candidate for that liver transplant. Sadly, we have seen that, but we do the best that we can, obviously, to prevent that from ever happening. So the short answer is we never think it's a bad thing to get second opinions. And if all we say is everything looks terrific and we have nothing to add, I can't possibly think of a better outcome.
Excellent question. What is your experience with children that have a recurrent narrowing in the aorta despite several attempts to open and keep it open, like surgery, ballooning, stents, etc.?
So the narrowing in the aorta that I suspect you're referring to is a coarctation. That is less common, certainly, than many of the problems with the pulmonary arteries, but definitely well recognized in Alagille syndrome. What I would say is that sometimes it's incredibly difficult to get a coarc repair just right. For example, the way that the surgical techniques were done in the past, up to 30% of kids would have a stenosis recur, and sometimes the balloons are not sufficient, and sometimes people are not as willing to use stents, for example, which I'm not saying is a bad thing, because the stents obviously don't grow with the child. So sometimes some of these can be quite complicated to try to deal with. That being said, some of the surgical techniques that have come about a little bit more recently tend to reduce the occurrence of stenosis down to about 2 or 3%. Again, if if people are having trouble, sometimes getting a second opinion locally, around the corner, down the street, or across the country may be helpful.
Okay, Katie Temple in Scotland asks, my son has been diagnosed via echo only with pulmonary arterial stenosis and also aorta branch stenosis. Have you found the aorta branch stenosis to be linked to ALGS?
Yes. So I think maybe possibly. Shannon is going to talk about this tomorrow as part of the GALA study. I think that the vascular components, and again, David mentioned this morning, I think the vascular components of Alagille are just beginning to be understood. I think we have a long way to go to completely understand them, but what we are now learning is that the narrowings in the pulmonary arteries and the narrowings in the head, as are seen with moya moya, and the narrowings that are seen in the other portions of the aorta and in the renal arteries, they are real, and they should be looked for, and they should be carefully evaluated.
Can you speak to how moya moya affects the cardiac situation with Alagille families?
Yeah, so there's a new sort of paradigm that's being developed and trying to best understand how to get the information out as it relates to actually looking for moya moya. I think many patients, even if they are diagnosed and followed, they don't necessarily get screened for moya moya. Moya moya, for those of you who are not familiar with it, is a narrowing of the blood vessels in the head and a malformation of the blood vessels in the head. The surgery that's done for it actually drapes the blood vessels, if you will, over the brain itself to allow the blood to get to all of the different pieces, because the vessels themselves are so very small. I think most large centers would recommend that screening for moya moya be done prior to any major operation. And I think things like liver transplant or complex congenital heart disease surgeries often would sort of trigger that box to be checked and get screened. If there are no major procedures to be undertaking, there are various recommendations for the timing of screening for moya moya. Some people suggest that, by the age of 5, some by the age of 8, and then every X number of years thereafter. So the issue with moya moya as it relates specifically to the congenital heart surgery is that when many of these surgeries are done, the patients are put on cardiopulmonary bypass, and the overall blood pressure that's pushing the blood to the head may be lower than what is normal for somebody that's up and walking around. And so those pressures need to be incredibly carefully monitored in patients with moya moya to make sure that the brain sees enough pressure and enough blood flow during the actual operation.
Thank you. We have another question here. Does having pulmonary atresia with MCAS, and the recurring coarctation complicate long-term survival just by having them at the same time, since you have to manage both? And what is your opinion on the approach to treating an aneurysm in an RV to PA conduit? Each hospital has different approaches as to what to treat first and how, etc.
Yes, so those are excellent questions. There's the old adage that if you put 10 doctors in a room and you ask them a question, you will get 12 different opinions. And that's sort of the problem that you're asking about with the aneurysm. It depends, not knowing the specifics around this, it would be a little bit hard to comment. There are quite honestly, different versions of aneurysms. Some require surgical attention and some can be carefully observed. And so sometimes there's a bit of confusion as to specifically which type of aneurysm it may be. In some cases, for example, when the surgery is actually done and there's a very large patch placed to repair tetralogy of Fallot, sometimes that patch can simply enlarge or expand and not actually constitute a true aneurysm. We see that actually quite often. And so those may or may not need to be treated. So getting the specific diagnosis correct is often quite difficult. But if it is in fact a true aneurysm and has a reasonable size to it, in general, we would tend to treat that. Again, not knowing the specifics, I'm not recommending that you walk in and say this should be treated. But I think certainly understanding that there are different things that have to be thought about when it comes to whether it's an aneurysm, the type of the aneurysm, where it's located, and what the risks associated are, those all go into making a decision about what to do and when. As far as having pulmonary atresia and MAPGAs in the cohort, they don't necessarily combine to change outcomes or to change life expectancy. There certainly are issues associated with a cohort, for example, that are not associated with MAPGAs. For example, coarctation is often accompanied by high blood pressure in the body, right? Hypertension. Hypertension over time has a number of issues, whether it's related to your heart's overall health or the risk for stroke or just general other comorbidities that are associated with having high blood pressure in the body. That is not necessarily associated with having the MAPGAs. So each piece of it has its own complication and requires follow-up for a little bit different reasons, but they are not necessarily additive.
That was a good question, Kim. Katie Temple in Scotland asks again regarding moya moya, can moya moya be ruled out at or by age 2? Her son had an MRI to check for it recently due to seizures and stroke-like symptoms. It has been ruled out, but Dr. Feinstein just mentioned it might not get picked up until age 5 to 8.
Correct. Moya moya can develop over time. So one screening study does not necessarily clear you forever.
Is there a recommended time? And maybe you could answer this too, Dr. Piccoli, I see you chiming in. Is there a recommended test or time frame or frequency of when someone should be checked for moya moya?
Go ahead, David.
I'd be glad to. We had put together with our neurologists, neurosurgeons, Binita wrote most of this, an NIH grant to answer that exact question. You know, as Jeff said, moya moya clearly is one of the lesions that progresses over time. So being cleared once does not guarantee you that you won't develop it later. And once it's fully established, the surgery may not work well enough to stop you from significant complications. So we put together a great grant. MR angiography was very expensive. You need to screen a huge number of people to prevent a modest number of terrible catastrophes. It didn't get funded. It was just too expensive a grant to do. So we just made the recommendation that you start at a time when the child does not necessarily need general anesthesia for an MRA, and then go every 5 years. And that's, it's not data driven. And you have to remember that the neurologic consequences of Alagille are significantly more complicated than just moya moya. They can have absent vessels, they can have other stenoses, they can have aneurysms. And in our initial clinical series, and it's a while ago and a lot of things have gotten a lot better, the mortality from CNS events was really strikingly high. And those patients kind of drop out of series because the strokes are commonly fatal. So I think we really very much, as Jeff said, underestimated the amount of vascular disease that there is and the importance of it. And I wanted to ask him, and I break this apart into a couple of questions, but I wondered if, they really have more experience than anyone in the world with this. Do you feel that there's a time in the heart where you can say that there's not a significant progression? I mean, clearly some patients, their disease is mild and stable forever. It's only a small subset who are significantly abnormal. Can you predict any progression at this point, or do you just continue to monitor?
So we monitor in perpetuity, in part because we don't completely know the answer to that yet. And in part, you're only as good as your last outing, as they say about the pitchers. And so we had one patient recently who we saw and looked pretty reasonable at, age 5 or 6, and then looked pretty good at age 10 or 11, and then didn't look pretty good at age 15 or 16. So I think in general, quite honestly, we don't think that the stenoses in Alagille tend to progress, but nothing, they tend not to progress, but nothing is 100%. And so we have developed some version of criteria for the kids in whom we don't think we need to intervene, but we continue to follow them, and then we simply space the follow-up out. We hate to be in a scenario where we give them a clean bill of health, and then they come back 3, 4, 5, 6 years later, and suddenly they're in need of, for example, a liver transplant, and their pulmonary arteries have put them in such a state that they would need something done to their pulmonary arteries, but now their degree of liver disease makes that a much more risky operation. So we certainly have kids who have what I'll call sort of moderate disease that's quite stable, and we just stare at them. We don't think that those necessarily need to be intervened on. I will tell you that the expectations on the part of the liver transplant teams are very different around the country, and I suspect around the world. So for example, our liver transplant team is probably much more comfortable operating on patients with higher pressures in their right ventricle than many other places in the country or in the world. And it's simply because they see more of it, and we feel comfortable that we can get them through the operation. There are some places that invoke other criteria that, in my opinion, are not appropriate. So as you know, liver transplant is very risky in patients who have what's called pulmonary hypertension or high blood pressure in the lungs. And so they invoke sort of those numbers when they think about being able to do an operation in a kid with congenital heart disease. They are not even close to the same. And so trying to educate the teams around the differences here and being able to show sort of longitudinal follow-up that this is not going to be an issue, I think is one of the critical steps that we still have to do.
Second question, do you feel that, so in this vascular phenotype, do you feel that the patients who have significant pulmonary artery vascular problems are more likely to have central nervous system or renal artery or other abdominal artery problems, or do you think that it's an individual event in each organ system?
Yeah, that's a spectacular question that I will answer quickly and say I have literally no idea. But I thought where you were going was asking whether there are particular subphenotypes within Alagille, for example, that may be particularly tricky and may theoretically concern you that there's a much more sort of systemic vascular issue than others. And I'll answer that one because that one I know the answer to. And the short answer is there clearly is a different version of pulmonary artery stenosis and, more importantly, MAPKAs in patients with Alagille syndrome when compared to the general MAPKA population. It is not unusual for the Alagille patients to have what we would consider to be the toughest vessels to work with, to rehabilitate, and to actually see successful growth in, which is obviously disappointing. But certainly if you take all of the MAPKA patients that the surgeons here have worked on, the Alagille patients clearly hold the prize for some of the toughest, without a doubt. And the ability to rehabilitate these pulmonary arteries, very difficult. And I suspect you are correct in that this translates into the other abnormalities we see in these patients in their other systemic vessels.
Yeah. So, and Roberta, you call it when it's too much. We sort of knew at the molecular level early on that jagged and notch are involved in blood vessels at a really high level. And we didn't think enough about that, I think, in the beginning, except as liver doctors, the bile ducts are only supplied by the hepatic artery. And in the fetus, it's the hepatic artery that expresses jagged and notch at a really high level. There's a paper from the French group, from Alagille's group, that says that the blood vessels are different and the bleeding risk is different in Alagille patients. And we certainly have seen strokes, we've seen problems with renal artery dilatations and therapies. And I've often wondered whether ballooning and stenting in vessels that are not quite normal is a less good approach than patching and expanding. And I just wonder, I think you've sort of said you agree with that, but I don't know if you could address that specifically.
So with that statement, you are officially a member of the cardiac team here at Stanford.
Wow, can I get a raise?
No, but we'll send you a hat. How's that? No, you're exactly right. And actually, we just published looking at sort of bleeding risks in Alagille kids when they undergo, for example, cardiac cath. And you don't have to do very much to get those kids to bleed. In fact, you don't even have to do an intervention to get those kids to bleed. And so there is, without a doubt, an increased risk of bleeding in Alagille patients, even with diagnostic testing when the testing is invasive. We've looked a little bit at whether that has to do with platelet function and haven't found anything specific yet, but you are 100% correct in that ballooning and stenting in Alagille kids brings with it a fairly reasonable risk of complications and comorbidities, without a doubt.
Mm. In talking about the small or extremely small vessels, Dr. Feinstein, when a pulmonary artery, for example, is extremely small and other surgeons are indicating that there's nothing that could be done with it, is there something that can be done? Are there repairs? Can it be replaced, completely reconstructed? And what is the statistical outcome of your more severe reconstructions?
Great question. So I will simply say that small is in the eye of the beholder. So the team here routinely works on vessels that are 2 millimeters in size, routinely. So that's not anything out of the ordinary for us. The other thing that is a bit unusual about the way that the team here approaches the patients is that they work a lot further out into the lung itself when compared to sort of the areas that are close to the lungs, close to the heart, for example. So there are a number of different techniques that are used to try to rehabilitate those vessels. I would say that in general, rehabilitation is quite successful. There are patients, however, and the Alagille kids are sometimes some of the best examples of those, that even in the best hands, when everything is cut and pasted and put back together, the vessels simply don't grow. But the biggest sort of piece of the way that Dr. Hanley and his team approach this is to provide the opportunities for the vessels to grow. So one example may be doing one surgery to send additional blood flow to those vessels to get the vessels to grow over time, so that then when you do the more definitive repair, the vessels are bigger to begin with. So it is not unusual that some patients will have what we call a staged approach. They may have one surgery when they're a neonate and another surgery 3 or 6 months later to do the final repair. Or they'll have one surgery to try to bring all the vessels together with what's called a shunt to send extra blood to them, get those to grow, and then do the repair. The team here will not undertake sort of the full and definitive repair until the measurements that they make in the operating room, which are blood pressure measurements, are satisfactory, which leads to the next question, which is, in the overwhelming majority of cases, overwhelming majority, probably 80, 85, 90% of patients, the pressures inside the heart when these types of repairs are done are essentially normal or mildly elevated. So despite whatever sort of pieces you have to work with when you start, in general, the surgical team here can get the numbers to approximate normal. That is incredibly hard to do with balloons and stents, and quite honestly, incredibly hard to do overall as a surgeon, unless you literally go after every single narrowing that they have.
Hannah Craig's son Damien, she asks or says he has an azygous ACA duplication fenestration PCA. I could be totally butchering that. And vascularly affected in other ways. And there isn't, there aren't many reports that his doctors have found on this azygous ACA in kids, much less with Alagille. Can you speak to that at all?
I don't know what that means.
Okay.
So the azygous is a vein that usually runs up from down below. David, maybe you know this, but down below the liver and up into the vena cava up above. But I don't know what an azygous ACA is.
Okay.
All right. But I bet you'd be willing to look at the cath, right?
Exactly. Are these coronary issues? Is that the question?
Hannah?
Are they coronary arteries, posterior coronaries? Long story short, email me. We'll get people to look at the pictures and try and figure it out for you.
Okay, we'll make
Jeff, can I ask one last question? As a liver doctor, I might be exposing something very embarrassing, but the heart, sort of the right heart, responds to the total resistance in a way where if there's a low resistance circuit, the heart doesn't have to work as hard, but then the blood flow is highly differential. You showed the scans. Is it worse for the heart to have a little bit of increased resistance when it's measured in the main pulmonary artery, or is it worse for the patient to have dramatically different flow because there's different resistance right versus left lung?
Yeah, great question. So in general, the approach is to try to make the pressure as low as possible. One of the things that we've thought about is it worth an additional operation to try to not only minimize the pressure, but maximize the flow distribution? So as you say, are you better off with a patient who has a low right ventricular pressure and 50-50 flow, or is it enough to have a low right ventricular pressure and 70-30 flow, right? What we do know is that when we did some of this work in animals, if the flow to one lung is 20% or less, that lung does not grow and develop normally. It ends up being smaller than a normal lung. If you put a bunch of interventionalists in a room, and we actually did this, and said, what degree of narrowing or what degree of flow split bothers you, the number they empirically came up with was 30%. So if only 30% goes to one lung and 70% goes to the other, they believed that it would be important to do an intervention. There's nothing to back that up. We know 20% is probably not good, but I will tell you that our surgeons tend to favor less operations if possible, even if it means a less than perfect flow split. So just to belabor that point a little bit, I mean, normal really is almost 50-50. And it is incredibly consistent in people overall. So even saying that 60-40 is not that bad, that is way off the normal, like 60% off normal. So generally the lungs like to have symmetric flow, but we don't know specifically what number is the cutoff. We know 20 is bad, we know 20% is suboptimal. 30% we tend to live with a lot, and anything above 30% we generally think is close enough.
Dr. Feinstein, what is your experience with kids that have bleeding disorders or no specific disorder found by testing, but platelets don't work and the patient bleeds easily? Does having Alagille alone increase bleeding disorders, or are some caused by repeated exposure to anesthesia or other drugs? It's a good question.
So I am by no means either a bleeding or a platelet expert. I can tell you that in the world of bleeding, we probably know 1/1,000,000th of what we actually need to know. And it is not at all uncommon, and obviously, David, you probably know 1,000 times more about this than I do. It is not uncommon for kids to have bleeding episodes or clotting episodes, for that matter, with no clear diagnosis. So could it be platelets? It could be. We have not done nearly enough work to try to figure that out. David, what are your thoughts?
No, I think that you need platelets for one part of the function. You need clotting factors for a second part. Inflammation can affect this. And then blood vessel integrity matters, and nutrition and anabolism, the ability to build things with protein to heal matters. And I think we as Jeff said, we don't know enough about it. But what was really a fairly striking paper by the first author was Lika Vieras. They tried to sort out, so people are low platelets with Alagille because they have portal hypertension. They have clotting factor abnormalities either because they're vitamin K deficient or because their liver is abnormal and not able to make the clotting factors, even if you give it vitamin K. But they really put forward the hypothesis, and it seems to fit with the clinical situation, that even if you have abnormal numbers of platelets and good clotting factors, that there is something else about patients with Alagille syndrome that makes them have more significant bleeding complications, either from normal life events or from surgeries. I think we certainly believe that to be true. And it may well be the integrity of the blood vessels of the pipes also matters.
Can either of you speak to the occurrence of aneurysms outside of the brain? I mean, we've, at least my experience in the clinical setting was that 10% of Alagille patients have brain aneurysm. But what is the, off the cuff, is there a large percentage of aneurysm not in the brain? And is there related vasculature issues surrounding that make the aneurysms in other areas difficult as well?
Yeah, so it's a good question. The first thing to say is that 10% of Alagille patients do not have brain aneurysms. So, I mean, that makes my heart skip a beat in a non-cardiologist way. So if you have an aneurysm in the brain, perfusion to the brain is really important. But the other thing is that the brain is a closed box. And so when you have something happen to blood flow in the brain, slight decreases or bleeds inside the brain or outside the brain, you can get into tremendous problems. And the brain vasculature is very complex in the way that it is worked out and communicating from side to side and so on. So separate from moya, which is these big vessels, there are other aneurysmal problems. There's blood flow that has to go to each different segment. As Jeff said, you can plug an artery from the outside and plug it into the brain if you have enough time. So clinically, the same size aneurysm in some other places, if they bled, would not have the same consequence. So I think we don't really know the answer, but the brain and the heart are the two most complex vascular structures with the most complex developmental sequences. I mean, and again, my ignorance of things, but you know, the heart starts out like a tube and it folds. And you know, as was said, Alagille has a lot of problems on the right heart, and kind of, we think about all these things as kind of right-sided, but like one of the other notch mutations looks like it's much more left-sided events. Clearly, there are a lot of things that go on there that are complicated. And the aneurysms that are clinically important really are in the head. The others, if they exist, we're probably missing them. I don't know, Jeff, if you agree with that, but.
I do, and we generally don't go looking for them, right?
Right.
Yeah. And leading into that, you know, there's been, there are some clinicians who don't feel that a baseline MRI of the head is necessary, and there are some who feel that absolutely it should be. What are your thoughts on having a baseline MRI of maybe the neck and the head, or, you know, for new diagnosed families coming in?
Yeah, it's a good question that's not answered by data. You know, I think over the years we've seen babies who have had neurologic vascular events and died. We've seen, as Jeff said, or not so much like we've seen, because we get a lot of information from across the country. People have had routine surgeries and haven't woken up after the surgery because they've had a neurologic event during the surgery. Sometimes, you know, you can tell that they have an abnormality in a vessel. Sometimes you can't tell. Some of them have been identified, you know, at postmortem. It sort of would make sense in a way that everybody should get like a whole body MR and a whole body CT. And, you know, there are services, there are companies that will do this for you now. You know, they'll give you a head to toe CT for a certain price. It doesn't, medically, it doesn't make sense right now that that is in the patient's best interest, particularly since for little kids, you would have to do it under general. And if you've ever been through an MR, even a small segment of an MR is a really long procedure. So you would be talking about something that would have significant risk, more risk when they're younger. You know, you don't get anesthesia or die when you do an MRA in a 10-year-old, you know. So I think you have to look at that risk benefit, and we would say, no, you might pick something up. You might also miss things and reassure people. Everything is smaller. You know, I said this, I think, on our last Zoom call. I don't love soccer for, you know, kids with Alagille syndrome. I think everybody bangs their head a little bit too much in soccer and that ball, but, you know, we worry about the vessels. There have been papers that say that the thickness of the skull is less. We see that the thickness of the cortex of the bones in like the femurs is less. You know, you don't want to be falsely reassured either and say, okay, my MRI is fine. I can ski without a helmet, and, you know, I can head the ball, and, you know, I don't know. It's, we lack a lot of data for some of these things, and people are very much influenced by what they've seen, what they've heard about. You know, if someone says there's no reason for an MRA of the head, they haven't seen the cases that have stroked or died. You know, I mean, it's not the same as biliary atresia. It's not the same as other kids.
Are there any other questions? Well, we are half an hour early on ending the Zoom. If there aren't any other questions, then I think we could close. Any last parting thoughts from any of our attendees or clinicians or researchers? Anyone?
No, just to say you put on, I hope everybody agrees, a great sequence today, and I think we're all appreciative. And in these times of COVID, it's nice to see that this actually works and works really well. So thanks to everybody for being on and for everything that you're doing.
Thank you so much. And we are so grateful for the time. Oh, go ahead, Dr. Feinstein.
No, I was just going to echo those thoughts. We so much appreciate the Alliance and the families and the providers. Every time I hear David speak, I learn from him. I learn from the families. It's really terrific, and we really appreciate being a part of it and being a part of the family.
Thank you so much. We are so grateful for all of you for joining this second annual ALGSA virtual roundtable, for the time that you've dedicated today, for coming into this all day long Zoom. I'm glad that Cher built in some breaks so we could all eat and get drinks. I'd really like to just really quickly go over tomorrow. Tomorrow is a recap day. We are going to welcome our day 2 at 8 a.m. where Cher, the executive director, will just kind of go over the half day that we have tomorrow. Starting at 8:15, Binita Kamath and we'll be discussing the Global Alagille Alliance, the GALA study. And then following that will be Shannon Van Drill from Sick Kids as well, regarding the GALA study and an analysis of that. And then we'll move into recaps of each one of these 5 segments, where we hope that each of you, if you have any thoughts or actionable ideas on how we can improve the processes and improve the progress or knowledge, or gain speed on the steps forward in these areas, to bring that to the discussion and see if we can't come together with some action plan for some of our families. These 5 sections today that we talked about are the number 5, I guess, areas of concern in the surveys. And again, we thank each and every one of you who talked and opened up your expertise to this, or brought valuable questions to these areas. I think that's all. Cher, do you have any parting words?
No, just to reiterate, thank you to everyone for sharing your experiences. The patient voice is so very important, and we don't have it without you. So thank you all so much. And if you have questions that you think of tonight, feel free to email those to Roberta or to me.
Mm-hmm. And Cher and I will be staying on the Zoom afterwards if anybody wants to chill and chat for a little bit, and we'll go from there. Thank you, everybody. Have a great night.
Great night.
Bye.
Thank you.
Thanks, Cher.